very much. Good afternoon, everyone, and thank you for joining us for the Medical Board of California Quarterly Board Meeting. Pursuant to the provisions of Governor Gavin Newsom's Executive Order N29-20, dated March 17th, 2020, this meeting is being conducted via WebEx. Public comments will be heard for each agenda item for individuals wishing to do so. In order to be ready for public comment, we ask that you please ensure that your comments can be heard clearly by connecting to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu option at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, it will still allow you to participate and hear the audio of the board meeting. Please see the instructions on how to connect link on the last page of the board meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, President Lawson.
Thank you, Sean, and welcome everyone to the Medical Board of California's Thursday, August 19th, 2021 board meeting. I'd like to first ask all board members and staff to silence their cell phones or other devices, including any that are hooked up to your computer, so that we make sure there are no interruptions during the meeting. Since this meeting is being conducted via WebEx, I will ask that all board members and speakers announce themselves by name before speaking for clarity of the official record. All board members are able to unmute themselves to speak during the meeting, but please do place yourself back on mute when you're not speaking in order to reduce the background noise for all participants. Following this online meeting etiquette will ensure the best meeting quality for everyone. During each call for comments from board members and speakers, we will ensure that all comments that can be accommodated are heard before proceeding with the agenda. Government Code Section 11126.5 does allow us to remove people who willfully interrupt a meeting and to clear the room or virtual space if order cannot be restored by removing or muting the disruptive people. We will have a designated time on the agenda for public comment, and we will ask for public comment on each agenda item. This is an official business meeting of the Medical Board of California, and as such, disruptions will not be tolerated. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on individuals who indicated they wish to make public comments by name. When called upon, the host will unmute the microphone of the individual, and they will have 3 minutes to make their public comment. The host will audibly announce when 15 seconds remain to conclude the public comment. And after the 3 minutes have lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. And please do reference page 4 of the agenda for WebEx instructions on how to connect from the link on the agenda and additional instructions that you might find helpful. During agenda item 2, public comments on items not on the agenda, the board has limited the total public comment period for individuals to 40 minutes. Therefore, after 40 minutes, no further comments will be accepted. During public comment on any other agenda item, 20 minutes will be allowed for the comment period, and after that 20 minutes has elapsed, no further comments will be accepted. Each person, again, will be limited to 3 minutes per agenda item. The board's IT staff will assist me with receiving the public comments via WebEx during this meeting. I'd like to remind all speakers to please stay on topic, keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law, and we do plan to end today by 6:30, and we may take breaks as necessary throughout the meeting. I would like to officially call the meeting to order at 2:05 p.m. and ask that their board members please unmute their computers for roll call. Ms. Caldwell, please call the roll.
Mr. Brooks. Ms. Campoverde.
Present.
Dr. Gronadev.
Here.
Dr. Hawkins.
Here.
Dr. Helzer.
Here.
Dr. Kraus,
Here.
Ms. Lawson,
Here.
Ms. Lubiano,
Here.
Dr. Mahmood,
Yes.
Mr. Rue,
Present.
Dr. Thorpe, Mr. Watkins,
Present.
Dr. Yip, thank you.
Thank you. A quorum is present. Board members, please mute your computers. I would like to remind the members again that we will be taking a roll call vote on all action items. And before we move on to agenda item 2, I do want to note that Dr. Kraus has again joined the board for this meeting. We're pleased to have you with us, Dr. Kraus. Dr. Kraus, his term has been extended as part of the governor's orders, which is why he has rejoined us this afternoon. So thank you for being here.
Thank you, Ms. Lawson. I'd like to note that usually with good behavior, one's term is usually shortened. But my term's been extended to November 28th or until my board position has been filled by a new appointee. So I'll be here with you till that time. Thank you.
Great, thank you, Dr. Kraus. Moving on now to agenda item 2, public comment on items not on the agenda. Before I call officially for public comments, I would like to advise individuals making comments to please not discuss pending complaints, pending licensing applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications, and they could provide information to members that is outside of the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and could lead to a board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances when the decision is still pending. In addition, the board would like to request the public to address the board as a whole and not individual members. Please be aware that public comment during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action that board members can take during this agenda item is to listen to comments and decide whether they'd like a future agenda item on the topic. No other action can be taken on the item at this meeting. And though that may seem at times like the board members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed and to avoid compromising the speaker's goals or the board's mission. If you want to comment on an agenda item specifically, please do wait until we get to that agenda item. Comments at this time are only for items not on the agenda, and please limit your comments to 3 minutes. I'll now ask the host to please call for public comments.
Thank you, President Lawson. We've activated the hand raising feature and the Q&A window for anyone wishing to make a public comment. Please indicate so. First up, we have Susan Lauren. Susan, are you there?
Yes, hello.
We can hear you. Please go ahead.
Perfect. I'm Susan Lauren. In 1937, Germans came to California to study for their eugenics program in Nazi Germany. Until recently, California doctors forced sterilizations on female prisoners. Dr. Heinrich, who has a history of cases that involve deformity to women and children, felt entitled to do so. He believed women on welfare and in prison, 92% of whom are there due to domestic violence, shouldn't have kids. Some of my ancestors were tortured and killed in the Holocaust. Nazis felt righteous, and others stood by and did nothing. People who feel entitled and are without accountability create social destructiveness. They lack ethics and dehumanize people. Medical harm of the magnitude and duration in California is not an accident. The medical board is part of a sick and entitled system that gives doctors a sanction for evil. The cells of Henrietta Lacks made billions of dollars for the medical industry, but those profiting failed to inform, obtain consent, or compensate Henrietta's family. Patient consent is a misleading formality. In the case of Martin Slago in 1957, the judge ruled against the doctor, saying, "A physician violates his duty to the patient if he withholds any facts necessary to form the basis of an intelligent consent by the patient to the proposed treatment." Well, Dr. Sahlberger withheld facts, lied, assaulted and disabled me, and staged a willful cover-up. The medical board failed in my case. They were sloppy and immoral and made sure I couldn't even go to the police or DA with this assault crime. Berger's records are full of fraud and omissions. His lawyer, Tom McAndrews, is unscrupulous. The medical board did not talk to my doctor or care in the slightest. My case of egregious assault never even got to a panel. Anyone who spins my case as a perceived failure or stays neutral is sanctioning surgical assault and cover-up. This will create more medical harm. I propose honesty, patient co-authored records, and real investigations. The board also denied my complaint against Dr. Terry Dubrow for unprofessional conduct and fraud. Dubrow used his medical board credentials to sway my jury with lies. The public relies on doctors to be candid and careful, not cavalier cons. The medical board website warns about counterfeit drugs that cause illness, disfigurement, or death, yet fails to warn about medical scams, assaults, and cover-ups by plastic surgeons. Decades ago, surgeons decided to remove fat to sculpt women into what they thought they should look like. Adipose removal is proven to lessen long-term health. Thanks. The biological changes are non-reversible. After Berger's assault, I connected with hundreds of victims of adipose removal. We discovered a racket. Doctors go against science for ego and profit. An administrative confidential letter will not prevent medical assault, murder, and scams. And I want you to stop trivializing and entitling the harm plastic surgeons do. My case is egregious. It needs to be acknowledged and acted on. Thank you so much.
Thank you for your public comment. Next up, we have Hannah Ree. Hannah, are you there?
Yes, can you hear me?
We can. Please go ahead.
Thank you. So this is Hannah Ree, Dr. Ree of Black Patients Matter. I want to first of all thank you to the medical board. As you know, I've been attending these meetings for a few years now, and it is wonderful to see the progress that's being made in addressing patient concerns and advocate concerns. So I appreciate the quarterly meeting that you all have started to do, listening to us and speaking to us and allowing us a place at the table. And I want to thank you, Medical Board, for seeing the progress and having Kimberly Kirchmeyer step away from the Medical Board and having Mr. Let's see, oh, I forgot his name, but anyways, the new executive director present. And I'm also grateful to see that Mr. David Chris, who was the previous head of the HQIU, stepped down due to a large amount of money unaccounted for within that department. And so Medical Board, as you know, it is now time to investigate the AG's office. They require a huge budget for doing very little and choosing cases that are not the most serious, but the ones they want to retaliate against, especially against physicians of color, as we know, occurs in a previous study. And so Medical Board, and also it's going to be important to investigate the OAH's office, the hearings office. I can tell you with certainty that there is corruption there, and I'm going to submit information to you in that the minutes, the statements that were made in the hearings are altered in transcripts, so much so that the court reporter does not sign them because she knows that they've been altered. So I thank you again for looking into this type of corruption and misuse of the dollars that the Medical Board has in its possession. So thank you again.
Thank you for your public comment. Next up, we have Sandra Martinez. Sandra, are you there?
Hello, can you hear me?
We can. Please go ahead.
Okay. Hi, hello board members, and thanks for your time. My name's Sandra Martinez, and I represent the people of California. And we are telling you, we want you to stop interfering with doctors' ability to prescribe FDA-approved medicines, including hydroxychloroquine and ivermectin, for any diagnosis they deem appropriate. Every single study that is neutral or negative on hydroxychloroquine for COVID is highly flawed, from using toxic doses, eliminating select data, using faulty endpoints and criteria, using the medicine too late in the disease, using an incomplete protocol, or making conclusions that are not consistent with the actual data in the study. All the remdesivir studies show is actually less successful in treating COVID than standard of care alone. In addition, well-known and common side effects of remdesivir are the symptoms that are caused by COVID, such as kidney and systemic organ failure. Yet the FDA and you have given this ineffective and dangerous drug your blessing. Dr. Tess Lowry's meta-analysis shows the overwhelming success of ivermectin. When countries begin to provide ivermectin, COVID mortality goes down to virtually zero. You have no legal authority to persecute doctors with trumped up complaints and charges to frighten them and destroy them. These are FDA-approved medicines, and as such, they can prescribe them as they see fit. Support doctors who honor the Hippocratic Oath and patients. Support patients. The evidence is clear. You should and we need you to remove all restrictions on FDA-approved medicines, including hydroxychloroquine and ivermectin. Please take action on this now. Fix this now and save hundreds and hundreds of lives in California. Retract these restrictions now. Thank you so much for your time.
Thank you for your public comment. Up next, we have Anne Fuqua. Anne, are you there?
Yes, I'm here. Can you hear me?
We can. Please go ahead.
Okay. My name is Ann Fuqua. I am a chronic pain patient. I'm grateful for the opportunity to address the board. Patients like me are rapidly losing access to medication for chronic pain. The opioids I take at a dose many times higher than the CDC's recommended 90 mmE have literally given me back my life. I've been on the same stable dose for over a decade, 21 years total on opioid therapy. The physicians that prescribe medication successfully to patients like me should be lauded for restoring quality of life to patients. Yet they are in fear. They're afraid of they fear board investigations and DEA investigations. I would like to respectfully ask that the board establish an agenda item related to the treatment of intractable pain at a future board meeting and follow the guidelines in the intractable pain law that Dr. Tennant helped pass and you amended about 3 years ago. Again, thank you, and I would respectfully ask that you would establish an agenda item related to the treatment of intractable pain at a future meeting.
Thank you for your public comment. Next, we have Christina Hildebrand. Christina, are you there?
I am. Can you hear me?
We can. Please go ahead.
Hi there. My name is Christina Hildebrand. I'm the founder and president of Voice for Choice Advocacy. I want to second the thank yous for putting together the public advocate meetings on a quarterly basis. As I mentioned in the last one, I would like to see us, the public advocates, leading more of the discussion and the topics. Today, I wanted to talk about. I thought it was interesting. One of the previous persons saying the AG chooses cases they want to make an example of rather than those doctors, I'm adding to it, rather than those doctors that really need to be disciplined. As you know, I have spoken many times about the doctors who have written vaccine.
Christina, your audio connection is breaking up pretty bad. If you can get into a location with a better service.
Can you hear me now?
It sounds a little clearer. Please go ahead.
Okay. Should I start from the beginning or just from where I was at?
We missed quite a bit of it, so.
Okay, I'll just start from the beginning then. So I want to, Christina Hildebrand, a Voice for Choice Advocacy, educate and advocate for informed choice and transparency of what goes into your body. I wanted to thank you for the quarterly public advocate meetings as well. I hope that in the future that the public advocates will be have more say in the meeting and the topics in the meeting than the last one. The point I wanted to make today, I was interested in the person who previously spoke that said the AG chooses cases that they want to make an example of. I would agree with that, and rather than doctors that should be more severely disciplined. I was in contact with the medical board via email, and not with the board members, but with somebody from the medical board, asking about how disciplinary action, how much input the actual board, so you on the board, have into disciplinary action. And it really surprised me that basically on a unless someone on the board requests information on this particular case, when the disciplinary action comes before you, and the disciplinary action has very little information in it, unless someone on the board wants to see more information, that disciplinary action is just taken for what the executive director gives it to you as. And even then, when you bring it before the panel, it's a partial members of the board. At that point, you don't get given all of the information. You don't get all the documents from the hearing. And so, in order for it really surprised me that the members of this board are willing to, basically write off doctors both on the side of too much discipline or too little discipline, without actually even looking at the case and without looking at the true information in a case. So I'm not sure how that gets changed. I'm not sure if that's, I will look into it more, whether it's statute, but to me, board members need to be asking for the information behind doctors that are being disciplined, and really understand what you're signing your name to. In my last few minutes, I'm going to say the board put out a memo to physicians this week regarding masking, and saying that doctors should be careful about writing mask exemptions for children, and that they should go according to standard of care. I would love the board to and the medical board to put out what standard of care is for mask exemptions. Surely that should be up to the discretion of the doctor. But once again, it's a witch hunt for doctors who are allowing children to go to school against the I don't even know against what. Basically a doctor is willing to write a mask exemption, and there's a witch hunt for them when there's not even any standard of care written about mask exemption, about masking and mask exemptions. I thank you for your time.
Thank you for your public comment. Up next, we have Edwin Kendrick. Edwin, are you there?
I am. Can you hear me?
We can. Please go ahead.
Okay, great. Thank you. First of all, thank you for the opportunity to speak. And just want to be clear about what I want to talk about, which is that I do believe that we must create more equitable care within California hospitals, and that includes amongst the medical staff. One of my concerns has been, and I believe several members of the board know this, is a lack of equitable care, which has been resulting in patient safety risk and also patient harm. This has involved the disproportionate care that patients have been receiving. We've seen increased death rates under COVID-19 that have not been evaluated. We've seen higher amputation rates within our hospitals. We've seen minority surgeons that have been excluded. Some of them, as much as 10 years, minority surgeons have not been able to obtain privileges at certain hospitals, and they are qualified to do so. This has resulted in their patients having a lack of access to these facilities. And in order to do this, the medical staffs have often been denying these surgeons access because of violating medical staff bylaws. Currently, there is not a means of actually ensuring that these hospitals abide by these bylaws. There has been a continued fight to try to improve transparency and improve the diversity of the workforce. I think this is important because some of the complaints that may come from patients, such as loved ones dying, often tends to be held within the community and never leaves the community, because the majority of the community tends to be of the same ethnicity. And so what my hope is that when these matters are brought to the Medical Board of California, that they do understand that there's disproportionate treatment, and that it is necessary that we look at how to improve the workforce diversity and how to make sure that people, that there is some type of recompense when physicians are not allowed to be able to perform a practice they're qualified to perform in the community, because it is effective patient care. And it is my hope that something similar to what I would call a minority equitable healthcare project can take place. This would allow the Medical Board of California to assess complaints regarding credentialing and whether or not a medical staff has violated credentials policies. Because I can tell you that it is different if you're Asian versus if you're African American. There's lower levels. We have seen some non-African American surgeons, even who have been reported to the board, have ease of access to the community where they have gone on to create additional harm, wherein Black surgeons who have done an excellent job are not allowed to get privileges. And I believe this is something that should be addressed. Thank you so much for your time.
Thank you for your public comment. Up next, we have Marion Hollingsworth. Marion, are you there?
Yes, I am. Can you hear me?
We can. Please go ahead.
Great, thank you. Good afternoon. My name is Marion Hollingsworth, and I'm a patient safety advocate. I would like to strongly encourage members of the medical board to hold a committee meeting on how they can be more receptive to the public. The reason I say this is that you'll probably notice the increasing friction between members and advocates. We are given the impression that you think we're stupid and don't understand how the medical board works. First, remember that all advocates have experienced medical harm. Don't belittle that. Talking it out won't help this understanding unless the board accepts that errors are made in medicine, sometimes deliberately, and that we go to you hoping for help and accountability. I can give you 2 examples of us being dismissed. At the last stakeholder meeting, Dr. Richard Thorpe stated that we advocates view the board with perceived failings, implying that it's just our wrong perception of the board. I can assure Dr. Thorpe and anyone else who thinks this way that these are not just perceived failings. It's a slap in the face to anyone who has personally experienced the betrayal from a doctor that resulted in harm to them or a loved one. Another example is Dr. Gananadeb telling advocate Eric Andrus in person that he should have chosen a better doctor. I personally heard him say that. And again, that's a slap in the face to any harmed patient who did their homework and checked the board's website. I have a list of 9 doctors who were disciplined after family members or I saw them. Offenses include sexual misconduct, fraud, misdiagnosis, amputating the wrong body part, and overprescribing. One was a doctor who deliberately drugged my father with antipsychotics and falsified a DNR. The other was a primary care who also drugged my dad. You gave him an educational letter, and he went on to overdose a patient and join the death certificate project. How can I trust any doctor or the board itself to protect me with a list of 9 doctors? And this doesn't include the unlicensed resident who passed herself off as a radiation doctor when my husband was dying, or the doctor who told me I had thyroid cancer before the biopsy showed it was a benign nodule. Don't get me wrong, I am not against doctors. I want as many good doctors as we can get. I just want the medical board to have my back if anything goes wrong. I expect you to have some type of compassion when dealing with us and not dismiss us as fools. If you are concerned about the integrity and the reputation of the medical profession, you should start by reestablishing trust in the medical board itself and communicating with us. Thank you.
Thank you for your public comment. Up next, we have Christy Sepulveda-Burt. Are you there, Christy?
Hello, can you hear me?
We can. Please go ahead.
Great. I'm Christy Sepulveda-Burchett of Educate Advocate. Educate Advocate is a statewide grassroots nonprofit organization that serves families with special needs children. We have reviewed your statement in your email sent out to licensed physicians titled Inappropriate Exemptions May Subject Physicians to Discipline, as well as a statement yesterday from the California Medical Association. Many of the families we serve have children with disabilities, medical issues, those who are deaf, and mental health issues. And these persons have exemptions in the face covering guidelines through CDPH. As masks are medical interventions, and as such require efficacy data and information about adverse events, we demand this body to produce this information. In addition, we demand you define what the definition is of standard of care and a doctor providing an exemption. Hold on one second. We don't need a witch hunt after our doctors. We need this body to provide answers that justify this medical intervention of masking our children. Thank you very much.
Thank you for your public comment. Up next, we have Eric Andrews. Eric, are you there?
I'm here. Can you hear me?
We can. Please go ahead.
Hello, all. It's Eric Andrus. Remember me? I'm the guy that wrote and warned Bill and Christina before the advocate meeting that it was not going to go well if you all insisted on making it about yourselves instead of the advocates and insisting on topics we didn't bring to the table and that you wanted to bore us with so you didn't have to hear us speak. How do you all think that worked out for you? From this side of the ever terrible WebEx interface, it was a sham and an embarrassment for the medical board. It's uncanny how you all think you can do and say anything, screw things up, and still pat yourselves on the backs. The advocate meetings were designed to open communication with the public and talk about things we feel is important, not things you feel are important. You get to do that at the quarterly at these meetings. Every single one of the topics you picked to bore us with were topics that should have been saved for this meeting. So what did you all do after I warned you that Bill's agenda was a farce? You ignored me as usual, and it backfired, didn't it? And lest you think I put all the advocates up to everything they called in and reprimanded you all for, I didn't. I didn't speak to a single one of them before that meeting. It was all of their own accord. It's like you all live in a little bubble and you're totally oblivious to the reality of these situations. You strut around and lie to the legislature trying to make it look like you're all doing your job successfully and the public is adequately being protected. You let the California Medical Association strong arm you into so many bad situations that you're now getting criticism from every corner. I'm sure you've all seen the news articles that we've been more than happy to provide documentation and evidence on, and there's more in the pipeline. What's it going to take for you all to wake up, stop being so arrogant and egotistical, and start protecting the public from bad doctors? Bill seems to think it's appropriate now to single-handedly start sending out letters to doctors that he deems deserve it, without absolutely no oversight. As far as we can tell, there will be no public record of any of the cases he chooses to send a letter to, what the doctor did wrong, or if it warrants a harsher discipline, despite Bill acting like a judge and jury to make the decisions himself. Who is going to monitor Bill to see if he's implementing these letters appropriately? It appears no one. For all we know, Bill is now on the CMA's secret payroll, and we'll soon be seeing him having dinner at the French Laundry. We're catching up to you. People and legislators are starting to listen and really take us seriously. Someone asked me recently, how does the medical board and staff live with themselves, knowing how badly they do their job and how poorly they treat the public? I really didn't know how to answer them because when you get down to brass tacks, you're all just people of this state too. You're not special. You're not privileged, or at least you shouldn't be. You should be looking at every situation from the shoes of the victims of the thousands of bad doctors that are brought to your attention. You should become the victim in each case, not act like you're a privileged board member or a doctor out to protect your own. It's not your job to protect doctors. It's your job to protect the people of this state at all costs. The law does not allow you to protect doctors above patients, and yet you do it each and every day. You all, aside from TJ, are building up a hell of a lot of bad karma. Shame on you.
Thank you for your public comment. Up next, we have Rosie Arthurstaughter. Rosie, are you there?
Yes, I am. Can you hear me?
We can. Please go ahead.
Okay, thank you very much. I've been attending these meetings either in person or virtually for more than 6 years. I also worked for nearly 50 years now in the areas of research and analysis, both in the business world and in the scientific and the medical world. And doing that analysis, you run across a lot of elephants in the room. And this board is plagued with a whole herd of elephants in the room, things that are just systematically avoided. Last August, I formally requested an agenda item, and I was promised it would happen, and that was regarding intractable pain. Instead, a substitute was made for substance abuse, for MAT therapy, medically assisted therapy, a therapy that is generally not good for people with intractable pain or legacy patients, whatever you want to call them. The CDC, when they came out with their guidelines in 2016, were for primary care physicians with new patients going on to opioids for the first time, not transferring care from one person to another, etc. For the most part, the pain management practices, the large practices, took that as their mandate to taper, forcefully taper without consent, most of their patients. When the CDC came out afterwards, a year later, saying, whoa, this is not being done right, about 49%, so that's nearly half, have had some adverse event due to this policy being misapplied. And in 2019, they came out with another guidance, and the medical board didn't even put it on their site. Not once. Okay. In the intervening meetings, board meetings or stakeholders meetings, I've continually asked for intractable pain being addressed, and it's not being addressed. As it stands now, oftentimes the treatment that is beyond opioids is more dangerous than the opioids. Patients are
15 seconds
overprescribed
remaining.
non-steroids. They're overprescribed medications that cause harm. And that's where you need to be looking at that. And then I will continue this later. Thank you.
Thank you for your public comment. Up next, we have Denard Fobbs. Denard, are you there?
I'm here. Can you hear me?
We can. Please go ahead.
Okay. Thank you very much. I appreciate the opportunity to talk to you. Let me make sure my other devices are off. My interests are to just point out something that's been talked about a little bit already, and that is that as a previous president of the Golden State Medical Association, I would like to point out that we still have an ongoing problem with disparate treatment of minority doctors, especially at the hospital level. So we're having disparate use of peer review and outcomes that are not justified by the facts. And I realize that you all have difficulty getting accurate information. I will assume that the medical board are a group of representatives who all have the right thing in time, the right ideas and the right intentions. I can speak specifically having defended a couple of doctors just over the last year and cleared them entirely from charges by the board, that the review shows that careful analysis of these doctors' actions would have produced an entirely different result and a lack of charges altogether. What happens in these reviews, and one especially, is that it shows that it was actually other doctors in the hospital system, and at times the hospital system itself, that's including the nursing and other staff members, were actually guilty of the offense which the minority doctor was charged. So that unless we go deeper, unless we have a dedicated intention to look deeper and look closer with the ideas of equity and careful review in mind, then we're going to continue to do these things. It is well established, and I'd like for y'all to look at it continually, that minority doctors are selectively over-prosecuted in peer review. And it would be good in the interest of protecting patients if the medical board had an active part in reviewing what happens in the hospital in peer review and regarding what comes out of that. As you know, there's a lot of protection legally of doctors and hospitals, which allows them to basically do whatever they want. And this can produce a very dangerous environment.
15 seconds remaining.
And has done so. Thank you very much, and I appreciate your attention.
Thank you for your public comment. Up next, we have Khadijah Lang. Khadijah, are you there?
I'm here. Can you hear me?
We can. Please go ahead.
Good afternoon, board members, and thank you for the opportunity to speak. I'm Dr. Khadijah Lang, currently the president of Golden State Medical Association. We are representing the interests of the physicians in California of African descent. Dr. Krause, I'd like to say welcome back. It's great to have you still with us, and we look forward to continued contributions on your. I have two concerns today. First, I'd appreciate any information this board can give us with regards to the recently renewed religious waivers option. In the past, physicians could submit vaccine waivers for medical, religious, and personal beliefs for their patients if that applied. Several years ago, the latter two were removed, but this month, a temporary window has been put in to allow religious exemptions again. Can you please give us guidelines on how, for physicians in practice, on how the religious exemption is to be given for applicable patients without jeopardizing the physician's medical license? And I'll take that answer offline, as they say. My second concern is establishing transparency in the hospital peer review and hospital credentialing processes in California. Due to HIPAA, physicians are not able to get any information out or look at numbers on how people are being selected and or denied for peer review and for credentialing. As two of the physicians have spoken previously, this is happening as a pattern for African American physicians, and because of HIPAA, we cannot document what's going on, and people can't really speak openly about the numbers and what's happening. We would like to request that the board put in place policies that will allow a depersonalized, de-identified collection of data for all physicians applying for credentials to any hospital in California, including their gender and their ethnicity, and possibly their age as well, and how many physicians are credentialed, how many are denied credentials, so that we can see the demographic data in that area, and the same for peer review committees, so that we can see how many physicians by ethnicity and gender are being sanctioned by peer review committees in the state of California. This will bring transparency to a very important issue and allow us to possibly increase the number of physicians in practice, because when you remove a physician,
16 seconds remain.
You deprive service to far more patients, because a typical physician of color may have a catchment area with only one physician for 3,000 to 4,000 patients, as opposed to other physicians of other ethnicities often are in areas where there is one physician per 1,500 patients. Therefore, you deprive a larger number of patients of physical care from
Please
the
conclude.
specialist when you don't do this. Thank you.
Thank you for your public comment. Up next, we have Virginia Farr. Virginia, are you there?
Hello, can you hear me?
You can. Please go ahead.
I was going to review the trauma-informed principles, but I'm not right now because I'm going to have trouble with my connection. But how the board responds mirrors very much what we experience as patients. Like saying perceived failure, that is what we're told when we have a medical error, that we perceive that happening. And it's very frustrating to hear all this stuff that mirrors what we experienced. And we say it's hard or complex or we took the heat. Most of you have not felt the heat or complexity we felt. Like 3 years of trying to figure out how to get pain for something that's totally treatable. 20 injections for pain, having medical records falsified, now having false medical records in Epic where they're shared everywhere that never tells the same story. What's complex is having your wife die, bleed to death for 10 hours while the hospital did nothing. What is complex is losing your limbs and the doctor not getting any trouble. What's complex is being surgically battered and being ignored and treated like she perceived that happening when it actually happened. That's complex. That's hard. We don't perceive the stuff, it happens. So can you please use the proper words and be trauma informed and know what it means when you aren't? The reason we come to the board is not to be heard, not to have therapy, but to get action. We want things to change. We don't want the same thing to happen to other people. We have been calling for years and nothing changes. And then we're told it's perceived failure. No, it's a real failure because we're here 3 or 4 years later calling about the same thing. You still haven't talked about pain. You still haven't talked about liposuction. You still haven't talked about false records. You still haven't talked about trauma-informed care. You still haven't talked how your board members do MICRA and say, oh, California can't afford MICRA. Well, we have a $80 billion surplus. Can California still not afford MICRA? And what other ways are there to deal with medical errors besides ignore it, cover it up, pretend it doesn't happen? If you compare, like in trauma-informed care, there's the event, the experience, and the effect. If this is like the fire, the campfire, and compared to medical errors, they say, what fire? There's no fire. A fire didn't happen. And the insurance companies would say, don't call us. There was no fire. No fire happened. You can see the fire. And the governor would say, oh, there's no fire. Please quit calling us. There is no fire. And the CMA wouldn't fight for us like they did for the fire. Blue Shield wouldn't cover the fire. So you guys really need to pay attention to what's going on and really advocate for us. And those not talking, those are silent and neutral. You're really loud because we can hear you not advocating for us. Thank you.
Thank you for your public comment. Up next, we have Norma Godinez. Norma, are you there?
Yes, can you hear me?
We can. Please go ahead.
Hi, my name is Norma Godinez, and I'm calling in regards to there was a statement that was made out that there would be litigation or prosecution against doctors that write mass exemptions. You know, the thing is that those doctors, when they write those mass exemptions, they write them because they've seen these patients and either they have something going on physically or mentally. A lot of the times, especially now, in 19, 20 months now, nobody sees the psychological effects on kids, even though many people say, well, the kids are fine, they'll be okay. A lot of kids aren't, and it's not okay for the medical board or the state of California to come after these doctors because they are the ones that are seeing the patients. How is it that, let's say, for example, Dr. Galley will come out and say, you know what, all kids should be wearing masks when he hasn't even seen these patients, that when these parents bring in these children and ask for these exemptions, there's something going on with these children. How can someone sit there and say, well, all kids should be masked? That's like saying, well, an 80-year-old emphysemic is the same as a 17-year-old athlete. You guys can go run 5 miles. You can't do that. That's not right. It's on an individual basis. If these doctors are writing these exemptions, it's for a reason. They can see there's something going on with that child, that that person needs that exemption. The CDC was given $42 billion to research the dangers of masks, and only 2% has gone to that. Only 2%, $42 billion. That's a lot of money. And have they come up with a study, a peer-reviewed study that says, you know what, there are no dangers, or these are the dangers in regards to masks? There's no evidence, unless maybe the medical board does know of something and would like to share that. That'd be fantastic. I mean, I wouldn't mind looking at it. I know I'm not a doctor, I'm not a nurse, but I can read this stuff, and it's really sad. I was at a board meeting, and this little girl was just a school board meeting, and she was just crying because she says she has asthma. Her doctor did not give her a medical exemption, but she says she was taking breaks. She would take the mask off, and she was getting reprimanded. She was pulled into the principal's office and told that if she did not wear the mask, she would either be expelled or suspended. I mean, what is this? This is a young girl that's there. You know, we sat there, we met her after the school board meeting. She seemed like a nice kid. You know, I mean, she's there to learn. Why are we punishing these kids when they say that, you know what, I cannot breathe. I cannot sit here and tolerate this mask on my face. And if that's the case, you know what, please just don't go after these doctors that are giving these medical exemptions, because obviously if they are giving them, they've seen these patients and they determine that these patients need these exemptions. It's not okay because one size does not fit all. It's on an individual basis. Thank you.
Thank you for your public comment. Up next, we have Tom Hayashi. Tom, are you there?
Yes. I just wanted to first make a general comment on the state of pain treatment in America. Human Rights Watch did a report in 2018, and the director of health and human rights at Human Rights Watch commented that the treatment of chronic pain patients in the United States is identical to that of, or they have testimonies that are identical to testimonies that they receive from victims of police torture. Another example, perhaps a most extreme example of pain treatment in the United States, is the incidence of suicides, which Anne Fuqua knows a lot about. And just to mention a few, one is the president of the American Medical Association in 2018, Barbara McEnany. Her patient attempted suicide after being refused a prescription at a pharmacy. He has prostate cancer and is metastasized to the bone. In California, in Petaluma, Deborah Bales got a new doctor with a new opioid prescribing philosophy, and after her pain meds were ended, she went out to Bodega Bay and hung herself, with the help of her husband, hung herself from a tree on the side of Highway 1. And also a popular math professor at the University of California, Riverside, Pamela Clute, shot herself with a gun that was provided to her by her husband, Stephen Clute, who is a former California Democratic state assemblyman. And so those are just some of the examples of the state of pain treatment. And there's three issues that are, this is kind of aside from the, this goes above and beyond, I think, the proposed revisions to the state guidelines. One issue is the blatant divergence the state has had from just the most basic guidance of the CDC, which is the CDC guidelines had stated that they're intended for primary care physicians, not pain management professionals. The MME are designed for new patients and not legacy patients. This clearly has not been going on. And if a patient wants to taper, they stress collaboration between the doctors and patients. Tapering should be only with the buy-in of the patient. This has clearly not happened. Another thing is there's a lot of lying across the board that goes on to patients.
15 seconds remain.
Legislators have been telling me stories, pharmacists have telling me stories, and hospitals have told stories that all of not true. And these seem to all be falling victim to considerations of political nature. They just don't want to look bad. So human life has become secondary to being popular. Thank you.
Thank you for your public comment. At this time, we've reached the end of the queue.
Thank you, Sean, and thank you to all of those of you who've joined us and offered public comment during that agenda item. We are now moving on to agenda item 3, approval of the meeting minutes from the May 13th and 14th, 2021 quarterly board meeting. Members, please, excuse me, yes?
Move approval.
Thank you. Dr. Kraus.
Dr. Gallaudet, second.
Thank you. We have a motion from Dr. Kraus and a second from Dr. Gnanadev. Are there any additions or corrections from any of the members, or are we ready to vote on the motion that's on the table?
Can I just take a moment here? Because I went through the minutes and there was obviously not enough time since I only received it 48 hours prior to this meeting. And you know, I'm not always confident about the minutes, but someone mentioned in the minutes that we should use the closed captioning text, and I think that will as a basis for the minutes. I'm just concerned that, you know, some of the stuff that I said is written in a way that I did not have the time to correct it. But I mean, there's actual footage of it, so I guess that's okay. I just wanted to be that on the record.
Thank you, Mr. Watkins. Are there any additions or corrections from other members? All right, seeing none, I believe we need to go to public comment. So Sean, I'll ask you to open the meeting for public comment, please.
Yes, once again, the hand raising feature in the Q&A window has been reactivated. If anyone would like to make a public comment, please indicate so. First up, I have a question posted from Virginia Farr, but you do not have audio open on the line that you're typing these questions on. So I can't unmute your microphone, but next up we have Rosie Arthur's-daughter. Rosie, are you there?
Yes, I'm here. Can you hear me?
We can. Please go ahead.
Okay, I'd like to say that I am the one that made the suggestion about the closed captioning because it is a very simple way to at least get a shorthand version of what the speakers were talking about. Granted, it may not be perfect because, you know, things happen in our digital environment, but I made that comment, as well as 6 other items that I made comments on. And part of it has been brought up this time again, where the communications are just not happening. There's no response. And like the task force for controlled substances that was supposed to be in effect 6 years ago, now suddenly has some members, you know, but people who've asked to be on it or to participate haven't heard anything. Medical records, what they're saying about Epic is great. Now that we can get copies of the records, we're finding out it's full of lies, copying and pasting from one report to another, just so that they can meet compliance items for some other entity, has nothing to do with the clinical record. So it makes it hard for a patient to get care, let alone appropriate care. The minutes addressed other issues, in addition to the repeated requests for something on intractable care, legacy patients, etc. And it's worse than what was stated about police torture. I tend to think it's much worse than that. I've been reviewing documents and then comparing them to some of your enforcement documents so that an individual practitioner will get dinged and lose their license for a couple of minor things, where in a pain practice, they can lie, they can fail to inform the patient that they have an abdominal aortic aneurysm, not follow through on referrals, tell them instead of decreasing non-steroid anti-inflammatories, increase them. There is a lot of accountability that is just being overlooked. And that's one of the elephants in the room. But again, the 5 items that I spoke to last time, none of them has been addressed. They have not been addressed for years and years. So while we might get a better idea of what's being said by reviewing the closed captioning.
15 seconds for me.
Okay. You still need to be responsive. You know, when people communicate with you in writing, write back. When they communicate and ask for a phone call, call them back. Okay, because I've got evidence that you can do something with. Thank you.
Thank you for your public comment. Next up, we have Virginia Farr. I'm going to unmute the other line you're connected with. Looks like you're connected twice here. So, Virginia, are you there?
Hello. Can you hear me?
Yes, we can.
Okay, as I was typing, which now I won't, these minutes omit my statements that I made about my medical records being false and about the doctors not being up to date, it taking 3 years and 80 medical visits each of the 3 years to get a treatment that I'm now paying free. And that's a perfect important topic to be addressed, is especially female health. The doctor's knowledge is outdated. For my C. diff infection, the doctor's knowledge was outdated. For my PTSD I got from all this, the doctor's knowledge is very outdated, as previously stated. And by omitting this from the minutes, it mirrors what the doctors did in the first place by omitting it in my medical records. And I really don't appreciate my medical trauma being mirrored and me trying to advocate for change. And so if I say something, I'd appreciate it being clear instead of I explain my experience, instead of I voice my concerns about these issues and I would like them addressed. Thank you. Hold on.
Thank you for your public comment. Next, we have Hannah Ree. Hannah, are you there?
Yes. Hey, can you hear me?
We can. Please go ahead.
Yes, thank you. Advocates, others present here, I strongly suggest everyone take a look at the minutes. Medical board, I am very concerned about the fact that you have omitted the fact that I am a representative of Black Patients Matter. As you know, I've been coming here to the meetings for 3 years. And on the minutes, you have consistently omitted the word Black or African American. Okay, so please, I see that for the other patient advocate groups, patient safety leagues and others, you have listed their name and also the advocate group they are affiliated with. You even listed the person from CBS News that attended. But I have been attending here faithfully for over 3 years, and you keep omitting the fact that I'm a representative. I'm speaking on behalf of Black Patients Matter, not to mention last time we had a speaker from Black Doctors Matter, Black Physicians Matter. As you know, the healthcare disparity is centered around the fact that we don't have enough representatives, minorities of color in the healthcare field, especially within the hospital system, the surgeons. Okay? And so can we please, at the very least, list the fact that I am from Black Patients Matter. Hannah Ree from Black Patients Matter. Please update the minutes. Do not approve these minutes until that is posted on there. I don't know who had done it, why it was done, but as you know, I had sued a previous board member for marginalizing Black Patients Matter. And since that time, that member of the board is no longer on the board. Actually, there are a few of them. Okay, so please include Hannah Ree of Black Patients Matter in case you all have forgotten that I am from Black Patients Matter. Thank you. Please do not approve the minutes without the word Black or African American. Thank you. Bye-bye.
Thank you for your public comment. Next up, we have Susan Lauren. Susan, are you there?
Yeah, hi. Last time at the stakeholders meeting, I mentioned when we were talking about the website that there was my massage therapist had called in January of 2018. She took her time to do that and knows me well, knows my body well, and the gist of her message was left out. So I emailed this to the board, and you can see where she said she is missing parts of her tissue throughout the body, especially around her gluteus, hamstrings, IT bands, and trochanter. And she said that I was accustomed to being very healthy and active lifestyle, and that, in her words, I just cannot imagine she would ever have possibly agreed to the kind of surgery this doctor performed on her. And I'm putting it mildly.
Corrections to these minutes?
I did. I sent them in an email to the medical board members.
To these particular minutes right now, agenda item 3, these particular minutes. Do you have corrections to these minutes?
No, I haven't looked at these yet, and now I'm going to have to put that on something as something to do for me. And being disabled is not a piece of cake.
No, this
like
is
a job
what the
for
public
me.
comments are directed to right now. Any corrections to these minutes?
Okay, well, I'm going to now have to look at the minutes, which is another job for me when people don't even understand what it's like to be disabled, to be mutilated alive, and I don't feel good.
All right,
and now
John,
it's
let's
something
cut
else I
off
have
this
to do.
commenter. It doesn't appear she's got a comment on the May 13th, 14th minutes at this time.
At this time, we've reached the end of the queue.
Thank you. Let's bring it back to the members, please. And are there any further additions or corrections to the minutes? This is from the May 13th, 14th quarterly board meeting. We do have a motion on the table from Dr. Kraus A second from Dr. Gananadev. Members, please unmute your computers like I asked, and Ms. Caldwell, please perform the roll call vote.
Ms. Campoverde,
Aye.
Dr. Ganadev,
Aye.
Dr. Hawkins,
Yes.
Dr. Helzer,
I abstain.
Dr. Kraus,
Yes.
Ms. Lawson,
Yes.
Ms. Lubiano,
Yes.
Dr. Mahmood,
Yes.
Mr. Rue,
Yes.
Mr. Watkins,
Abstain.
Dr. Yip,
Thank you. The May 13th, 14th, 2021 board meeting minutes are approved. Members, please remute your computers and we will move on to agenda item 4, which is approval of the minutes from the June 1st special board meeting. Are there any additions or corrections to the June 1st, 2021 special meeting minutes from the members?
Move approval.
Thank you, Dr. Kraus.
This is Lori. I had a minor edit on some of my comments, please.
Please, go ahead.
I'm trying to find the page here. I made a comment about how members, it says that are not vetted like governor's appointees. That's what it says here. But I'd like that to be edited to, see, sorry, I lost my page here. I'm sorry, can you come back to me just a second? I can't find the page.
Yeah, are there any other additions or corrections from other board members? Hearing none, I'm going to go ahead and open it up for public comment at this point.
Ms. Lawson,
Yep.
who seconded the motion?
I'm not sure.
I will, Dr. Ganadev. I was going to ask Christina, but yes.
Thank you. I'm ahead of myself. All right, we have a motion from Dr. Kraus and a second from Dr. Gananadev. We'll open it up for public comment, and Ms. Lubiano will return to you once public comment is complete.
The Q&A window and hand-raising features have been reactivated, so if you'd like to make a public comment, please indicate so for agenda item 4 here. First up, we have Hannah Reed. Hannah, please go ahead.
Yes, hello, medical board members. I'm very saddened to see that the disdain for Black patients is so subtle as to be a microaggression. To leave out the word Black or African American patients is not surprising to me, and to approve those minutes by those
Ms.
members.
Reed, do you have a
is not
comment on
surprising.
agenda item 4, which is the Tuesday, June 1st, 2021 meeting minutes?
Yes, I do.
And what is your comment, please? All right, Sean, let's move on to the next comment.
That was, I'm sorry, that was my comment, a moment of silence for all the Black lives lost, which you don't seem to care about, since you are known as a hanging judge.
I think that's enough. Thank you.
This time I do not see any additional requests in queue.
Thank you. We'll bring it back to the board. Ms. Lubiano, I'll go to you first. Do you have the page number for your correction?
Yes, sorry about that. So agenda item 4, it's the, what page is this? Shoot. So there's one paragraph of my comments and I wanted to edit it such that, so it says, Ms. Lubiano recalled 2 incidents of public members versus physician members, and I just want to clarify that what I meant was
2 incidents where the public members were outnumbered. And then where it says Speaker of the Assembly not vetted, I meant that appointees by the Speaker of the Assembly do not go through Senate confirmation like a governor appointee does.
Thank you. Does staff have enough information about the paragraph to know where that's located? I think that I don't know if on SharePoint, if there are the page numbers like I see in my hard copy agenda at the bottom of the page.
Ms. Lawson, I have an additional correction.
Okay, just a moment, Dr. Krause. I just want to confirm that staff knows where to make those corrections.
Corrections are on page 9, BRD 4-9.
Great.
Yes, that's right. I see that now. 4-9. Thank you.
Great. Thank you, Ms. Caldwell. Dr. Krause, please.
I believe that at our May board meeting that Dr. Hawkins became vice president and Ms. Lubiano became secretary. So in the front page of the June 1st meeting, the correction should be made to annotate that.
You're correct. Thank you for catching that. Staff make a note of that. Dr. Krause, are you okay with amending your motion to incorporate the changes that have been requested?
Yes.
And Dev, as the seconder, are you okay with that?
Yep.
All right. Are there any other additional comments or corrections from board members before we move to the roll call vote?
Alejandra, I have one. It's agenda item 4-9. Ms. Campoverde said that it comes down to the integrity of the individual, and after that, the line should read, it would benefit public protection to have a public majority.
Okay. Did staff capture that? Great. So Dr. Krause, I'll go back to you. Are you comfortable incorporating that comment?
Yes.
And Dr. Gananadev?
Yes.
Great. Any additional comments or corrections? All right, we will move on to the roll call vote. Ms. Caldwell.
Ms. Campoverde.
Aye.
Dr. Gonadev.
Aye.
Dr. Hawkins.
Yes.
Dr. Hilzer.
Abstain.
Dr. Krause.
Yes.
Ms. Lawson.
Yes.
Ms. Lubiano.
Yes.
Dr. Mahmood.
Yes.
Mr. Rue.
Yes.
Mr. Watkins.
Yes.
Thank you.
Thank you. The motion carries and the June 1st, 2021 special meeting minutes are approved. Members, please remute your computers. We will move on to agenda item 5, which is approval of the minutes from the June 24th, 2021 interim board meeting. Are there any additions or corrections to the June 24th, 2021 interim board meeting minutes?
Same revision of annotation of vice president and secretary.
Thank you, Dr. Krause.
And move approval.
Thank you. We have a motion on the table. Do we have a second?
I'll second.
Thank you, Dr. Gananadev. Are there any other additions or corrections? All right, I'll now ask the host to call for public comments. Sean?
We've reactivated the hand raising and Q&A features. If you'd like to make a public comment, please indicate so. First up, we have Eric Andrus. Eric, please go ahead.
This seems to me like there's been an awful lot of problems with the minutes lately. Can we find out who is responsible for actually compiling these minutes and printing them out and giving them to everybody? Because something's going terribly wrong here, you guys. I think we need to make that public as to who's doing that.
Thank you for your public comment. Up next, we have Hannah Ree. Hannah, please go ahead.
Hello, this is Hannah Ree of Black Patients Matter. No comments at this time. Thank you.
This time, there are no additional requests in queue.
Thank you. We'll bring it back to the board members. Are there any additional comments or corrections from board members to the June 24th, 2021 board minutes? We have a motion from Dr. Kraus, second from Dr. Gananadev. Members, please unmute your computers, and Ms. Caldwell, please perform the roll call vote.
Ms. Campoverde,
Abstain.
Dr. Ganadev,
Aye.
Dr. Hawkins,
Yes.
Dr. Hilzer,
Abstain.
Dr. Kraus,
Yes.
Ms. Lawson,
Yes.
Ms. Lubiano,
Abstain.
Dr. Mahmood,
Yes.
Mr. Rue,
Yes.
Mr. Watkins.
Abstain.
Thank you. And I'm not sure what's happening there. Could council just confirm that with 6 votes that we have a majority?
Yes, it
Great.
passes.
Thank you. The motion carries. The June 24th, 2021 interim meeting minutes are approved. And members, please remute your computers. I will now move on to agenda item 6, which is the president's report. Let me just switch gears for a moment here. The first order of business with the president's report is a swearing in of our new board member, Dr. James Hilzer. Dr. Hilzer was appointed on June 25th, 2021 by Governor Newsom. Dr. Hilzer is the chair of the Chiefs of Quality for the Permanente Medical Group and staff anesthesiologist at the Kaiser Permanente Santa Clara Medical Center. Dr. Hilzer is also the chair of the Permanente Federation's Peer Review Advisory Committee. He earned a Doctor of Medicine degree from the UCLA School of Medicine and a Master of Science degree in Biological Sciences from Stanford University. Dr. Hilzer, welcome to the board, and I would like to swear you in today. Can you please raise your right hand and repeat after me? I, James Hilzer,
I, James Hilzer,
do solemnly swear or affirm
do solemnly swear or affirm
that I will support and defend the Constitution of the United States and the Constitution of the State of California
that I will support and defend the Constitution of the United States and the Constitution of the State of California
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance to the Constitution of the United States and the Constitution of the State of California,
that I will bear true faith and allegiance to the Constitution of the United States and the Constitution of the State of California,
that I take this obligation freely,
that I take this obligation freely,
without any mental reservation or purpose of evasion,
without any mental reservation or purpose of evasion,
and that I will well and faithfully discharge the duties upon which I am about to enter.
and that I will well and faithfully discharge the duties on which I'm about to enter.
Welcome, Dr. Hilzer. We're excited to have you on our board, and we look forward to your participation as a member.
Thank you, Ms. Lawson.
And I didn't know if you wanted to say anything at the outset, but I wanted to give you the opportunity.
Oh, great. Thank you very much. Hi, everybody. My name is Jim Hilzer. As Ms. Lawson said, I'm an anesthesiologist in practice in the Bay Area. I've been in practice for about 30 years. I work at Kaiser Medical Center in Santa Clara. I also have an interest in peer review. Have been doing this for about 15 years, and I'm looking forward to working with you all.
Thank you. It's great to have you. Moving on to just a couple of brief updates before we get into the remainder of the board's business this afternoon. Just some brief updates. The board, of course, held a public stakeholder meeting on July 29th. If you're interested in the webcast, that is available on our website, www.mbc.ca.gov. The board's July 2021 newsletter is also available on our website. I'd also like to remind applicants and licensees that pursuant to AB 3330, the mandatory cures fee has increased from $6 to $11 as of July 1st. And finally, the board is receiving an increase in calls from licensees stating that they're receiving calls from scammers claiming to be board staff or with the DEA and are investigating their licenses. Board staff will never contact physicians by telephone to demand money or any other form of payment. More information on this issue can be found in the news releases section of the board's website, as well as on the Department of Consumer Affairs website. Are there any questions or comments from the members on the president's report? I will now ask the host to please call for public comments.
Okay, we've activated the hand raising and Q&A feature. If anyone would like to make a public comment, please indicate so at this time. First up, we have Hannah Reed. Hannah, are you there?
Yes, except that the host again has refused to state my name correctly. My name is Hannah Reed of Black Patients Matter, and as usual, he drops my name entirely and just says the first part of it. So I would request that he state my name correctly. Thank you. So it's nice to see that we have a representative from Kaiser present, but I am a little concerned about their algorithm, the algorithm that they use to determine preventative treatment. So obviously, it's cheaper to treat Black patients. Excuse me.
Ms. Reed, do you have a comment on the president's report?
I do. On the president's report?
That is this agenda item, the president's report.
Okay, I have a comment on 6A. You don't want me to comment on 6A?
Do you have a comment on the president's report, agenda item 6?
My question is, isn't A part of 6? I would like to comment on 6A.
Proceed if you have a comment on agenda item 6. Feel free to cut me off if I'm not understanding you correctly, but I'm answering 6A with the new president from Kaiser. It's nice to see a medical board member from Kaiser, but I'm a little concerned about their algorithm towards African American patients, where it's cheaper to let them die of heart disease than to screen them earlier in life, like their CEO Tyson that died at the age of 60 from heart disease because of the algorithm.
Ms. Ree, 6A is only about the swearing in, not about Kaiser's processes. Thank you.
Now let's take the next public commenter, please.
Next up, we have Eric Anders. Eric, please go ahead.
I just think it's ironic that a doctor from Kaiser would be appointed to the board when Kaiser requires all of its patients to sign away their Sixth Amendment rights to a jury trial by signing arbitration agreements. Kaiser likes to manipulate their lawsuits, so it makes me concerned about a Kaiser doctor coming to the board and possibly protecting doctors in a similar way. Thanks.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Thank you. We'll bring it back to the board. And this is not an action item, so we will move on to agenda item 7, board member communications with interested parties. Do any board members have anything to report? And please do unmute your computers if you'd like to speak.
Ms. Lawson, Dr. I just want to make sure that I say that usually every board meeting, I'm actively involved in health policy, and I do talk to people from all sides. But I won't we don't do anything about the medical board issue. Thank you.
Thank you, Dr. Ganana-Dev. Ms. Lubiano.
Yes, I wanted to note that I had a brief exchange with someone named Samreed Farid, S-A-M-R-E-E-N space F-A-R-I-D, about a complaint that I believe that she filed, and I referred her information to staff. That's all.
Thank you. Any additional communications that board members wish to report? Like Dr. Ganana-Dev, I'll just report that over the course of the past several months, I have had numerous conversations with legislative staff, with legislators over the past couple of weeks. I've had a number of conversations with patient advocates and other advocates who've reached out to me directly following the public stakeholder meeting. I, like Ms. Lubiano, receive email correspondence and phone calls from time to time, either about issues that may come before the board, all of which I forward on to staff for an appropriate response. Any other communications that board members wish to report?
Yeah, Dr. Asif Mahmood. So
thank you.
I do a lot of advocacy work, and I come across a lot of people every single day, but there is no discussion at all about medical board issues. But I meet a lot of doctors. I'm a practice physician. I do a lot of events and kind of stuff, but nothing to do with anybody who's being investigated or anybody who has any concern. Nobody has reached out to me, but I intend if somebody comes to me, I will direct them to board office.
Thank you, Dr. Mahmood. Additional member reports? All right, seeing none, I will ask the members to please remute their computers and ask the host to call for public comments, please.
We've reactivated the hand raising and Q&A features for anyone wishing to make a public comment. First up, we have Rosie Arthur's-daughter. Rosie, are you there?
Yes, can you hear me?
We can, please go ahead.
Thank you. Last year, before the new board president was installed, I was told I would be able to communicate with her following her installation, and I attempted to do that. And it was meant to be a conversation between me and her, and I did reach out to her, send it to her, and she did just like she said she would. She sent it back to staff. So it sort of circumvents the intended party, and it makes all the work that's been done moot. If you're supposed to be able to talk to the board president, then let us talk to the board president. Don't send us back to some staff member. That doesn't make any sense. Anyway, that's been my experience. And again, I said I've been attending these meetings for 6 years now.
Do you have a comment on anything that was reported as part of this agenda item?
Well, you said that in the last few months, and that's when this occurred, that you just put the things through to staff when it was meant to be conversation with you. So I haven't had a response from you yet. So yeah, it would be on that same agenda item. So is there some way to actually open up this line of communication? Obviously, it's not supposed to be done here, but if I'm told I can speak to you, and then when I reach out to speak to you, then you refer it to somebody else, that doesn't accomplish the purpose. Anyway, thank you very much.
Thank you for your public comment. Up next, we have Hannah Reed. Hannah, there?
Yes, hello, Hannah Reed of Black Patients Matters. So for disclosure, it's unacceptable for a board member to say in general terms, yes, I spoke to some advocates. I spoke to a few making generalized comments. Disclosure means who did you talk to? You need to name names. I think the board, I thank the board members who specifically stated and disclosed who they spoke with and what became of it. For Ms. Lawson, just to make a general comment about, oh, I spoke to some people, what kind of disclosure is that? That is unacceptable, but it exhibits her personality of believing she's above the law. Thank you.
At this time, I do not see any additional requests in queue.
Thank you. We'll bring it back to the board. And as this is not an action item, we'll move on to our next agenda item, Executive Management Report. Mr. Prasifka, I think you are up first.
Okay, Madam President, thank you very much. I would like to first go through the administrative report. In terms of meeting updates, this was a very busy time for the staff. We had many meetings with the president and vice president about a variety of matters. We had orientation with our two new board members, David Rue and Dr. Heelser. We've had a significant amount of continuing interaction with the Attorney General's office and also with the HQ. We had an interested parties meeting in relation to the Mexico pilot project, and I'll be able to update you there. And of course, a huge amount of meetings taken up in relation to the Sunset Review. In terms of a staffing update, we welcomed 8 new employees, and it's important to note that there continues to be a lot of fluidity in terms of staff movements. I think what we're doing is dealing with some of the legacy effects of COVID, which has been very disruptive. There's been a lot of teleworking, which continues, and we have noticed that it does seem to affect staff retention, particularly as we move to go to full-time working here. The COVID update, as you will notice, where everyone here is back in masks, and so it's been a very challenging time for us. And if you look at the data there, which we have in terms of teleworking, we continue to have a significant numbers of staff in teleworking. In licensing, it's 25%. In enforcement, it's currently up to 30%. ISB, close to 60%. So it has been very disruptive, very challenging. But I just want to thank staff for having risen to the occasion, and we continue to keep activity levels at very high points, as will be shown in other parts of the presentation. External communications has been a very important part of the work that we've done. We've had a redesign of the website. We continue to work on a complaint tracking system. This really involves micro management of the Breeze process, which brings in DCA. So that's going to be a very significant process, but we continue to work on that. We've had to refresh the website in terms of ADA compliance. That's been a colossal project, and I want to congratulate my staff on doing that. We've looked at the physician survey redesign, and we're scheduled to launch that in mid-October. And we're also working on launching the print yourself pocket licensing cards. Docs continues to be a very important part of the licensing process, and there's been continuous growth in that as we try to move successfully to an all online process. And we continue to work in terms of redesigning the complaint form, and we've also placed a special emphasis on WebEx training for medical experts, and that's been a very important part of our program there. Moving towards enforcement, again, the expert reviewer is a very important part of our process. We're continually looking for new reviewers, reviewing existing consultants, and you see we have been advertising for new expert consultants there. Central Complaints Unit, there we continue to work on reducing the days to initiate complaints. For the fourth quarter of the current year, that was down to 3, which is considerable progress over where it was just a year ago. We've instituted a quality compliance program to ensure that all current letters are being utilized to provide updates to complainants on the status of their cases. And there's further information about staffing levels in the Complaint Investigator's Office, the Discipline Coordination Unit, and the Probation Unit. I would like to take you very briefly to some of the charts there in terms of the metrics in relation to enforcement, just to say the only way to measure your activity level correctly in an enforcement complaint system is to have some assurance that you have a methodology that applies the appropriate level of investigation and resources to bring you a successful outcome in each case. But the metrics are important, in that they give us some indication of how the overall system is operating. In terms of the first metric, PM1, the complaints received, again, at the end of the year, we were approaching, well, we had over 10,000 complaints. It is down slightly over trajectory over the previous years, and we know why that's true. That's all the activity of COVID, which has been very disruptive not only from the complainant point of view, but we know it's been very disruptive in terms of healthcare delivery. There are lots of procedures and lots of things that have not been done, have been put on hold. I think that we have to anticipate that as we perhaps get back to something that is more like normal, that the complaints will resume their prior path, that we will get more complaints. And this is something which we simply have to be prepared for. And that's something to keep in mind. Going to PM2, the complaint initiation time frame, again, we've made considerable progress on this. This is something which is entirely in control of the medical board. This is something we handle entirely internally. The average days to complain of complaints in the central complaint unit, we've made some progress there. I know in the next chart, which is the average days to complete investigations in the complaint investigation office, I know there was some discussion about this at the last board meeting. This is something which is of great concern to us. We don't like to see the days increase in terms of the average days in which to complete a complaint. And basically what's happened here is that back in 2019, we had a significant increase in the number of complaints in relation to vaccine exemption cases. These cases present a certain administrative challenges because typically in these cases, the patients do not give consent for us to get access to the medical records. As a result, we have to engage in what is a very time-consuming legal process of subpoena enforcement. We are still in that process, and that has caused our average days to increase. Speaking to staff there who are on top of the problem, have indicated that they hope to in the next quarter or the next quarter or two to have these cases finally work through the system, to have gone through that lengthy subpoena process, and we should see some return to normal days there. So just to update you on that. In terms of average days to complete investigations in HQIU, they are there, and they will be addressed more completely in the HQIU presentation, which is to follow. Going to agenda item 8B, the next chart, the average HQIU investigation days by case. At the last meeting, there was concern, and there's continuing concern about the lengthening time in terms of unlicensed activity, which has gone from 1617 to 351 days to in the current year 659 days. Again, this is also of concern to us. I have to tell you that the amount of consultation and collaboration between ourselves and HQIU has increased dramatically just in the past 6 months. And it's something which we have raised with HQIU, and this will be involved, and this will be explicated on in terms of the next presentation from HQIU, who will point out some of the particular difficulties, again, in terms of getting medical records, etc., in terms of unlicensed activity. Finally, I would like to take a look at the last metric that we have here, which is BRD 8B12, which is something that we have instituted since November. What we have tried to do in this particular chart, in this particular matrix, is to capture the total number of cases that are in the system. And again, this is but one snapshot, and it is our goal to reduce the average times, reduce the amount of times it takes to bring cases, but that should not take away from our overall goal, which is to decide the cases correctly. And here, after we've been at this by about a year, when we first started looking at this metric back in November of 2020, we had close to 6,000 cases in the system, 5,949. We've got that down to just above 5,000. That's a 16% reduction. Again, I think what it indicates to me are a couple of things. Number one, at this point, we're not falling further back behind. So that's a good thing. Number two, as I said, it may be the case that we have benefited from a reduction in total numbers of complaints. So this is no time for us to be complacent. We have to be prepared for increased complaints, and we'll have to look at this. But again, it doesn't tell the total picture, and the total picture remains a commitment to deciding each case on the merits, and in particular, to devote more resources to the more serious cases and to attempt to deal with the less serious cases effectively, efficiently, and in a timely manner. Moving on to the licensing program summary, this has been a particularly busy period for the licensing team. They've received a very high volume of complaints, very high number of license applications, and they have managed throughout this increase in license applications to keep the average days for review around 30 days, which is the target period. This is also the period in which they were able to prioritize the PNS license applications for residents completing training. And this was the first time we had a significant tranche of license applications relating to transition from a PTL to a PNS. And the staff were prepared for it. They had their systems in place, and in most cases, I'm told, were able to effect the transition in 3 days. And so this is a very good outturn for them. In addition, because of the PTL system, whereby if there's a change in program status, this has to be notified. This is a new workload, and there's been a record number of applications indicating a change in status, and we have managed to stay on top of that as well. Moving on to the Mexico pilot project, just a very brief update. As we indicate there, at the time that this was issued, there is one license that has been issued. Actually, since this was prepared, a second one has been issued, but the balance of, I think, the 20 more licenses remain to be issued. We are ready to issue them, and we're simply waiting for the go-ahead from the applicants, but it deals with the coordination with the visa process, and it's been decided that they've requested a delay because they want this to be the last step before they initiate the visa process. So we're simply waiting for that. In terms of the COVID waivers update, there were 2 that were of note. Those were orders extending the postgraduate training license, and those are noted there. In addition, sorry, I'm having difficulty. My glasses keep on fogging up. Sorry. I think I should have been used to this by now, but it's still a difficulty. Again, we have updates there about the DOCS program, which has been very successful, and it continues to be a great uptick in terms of its use. And we have indications there of the activity programs. So it's been a very busy time for the staff in terms of dealing with complaints, in terms of dealing with license applications, plus very busy time with the sunset process, and myself and the staff would be happy to take any questions that you would have.
Thank you.
Howard, I have
Thank
a
you.
question.
Howard, go ahead.
Thank you, Mr. Prasifka. You can stop your eyeglass fogging with a piece of tape across the top of your mask or the use of the N95 mask. When I read in the LA Times that we have 10,000 complaints and a few hundred items of action, it concerns me that we may be shooting ourselves in the foot by misuse of the word complaint, that there may be a semantic and nomenclature problem. When there's a phone call to the medical board about a misbehaving podiatrist, and that's referred to the Board of Podiatry. Or when there's a phone call about the egregious $55 parking fee to see a doctor or the long wait in the doctor's office, I would suggest these should not be logged as complaints, but inquiries. When there are 800 phone calls about one doctor's billboard, I don't think that should be listed as 800 complaints. I think that should be one complaint. The term complaint should be reserved for a complaint of lack of professionalism, medical negligence, or criminal behavior of a physician. And if there are 32 complaints about the same action, that should be viewed by the board as one complaint. And this is a manner in which the public and the press can better judge what percent of complaints are becoming actionable items, rather than to have that number 10,000 held over our head whenever there's an article in the newspaper. Thank you.
Thank you, Dr. Kraus. Are there any other questions or comments from board members on Mr. Prasifka's report?
Yes, I have a bunch of questions for Bill, obviously.
Please, Mr. Watkins.
Good afternoon, Mr. Prasifka. This is TJ. So here's the deal. I'm becoming extremely concerned. I'm sitting here, I'm listening to you being busy, and I get a sense of overwhelm from you, and it troubles me. And I've noticed a few things. And the biggest thing of them all, and the most obvious thing, the elephant in the room, is that we've received this board pack, 48 hours ago, and a link to it 40 or 36 hours ago. Now, that is within and operationally your domain, right? And so my first deal is, do we need to be concerned, or are we setting a new standard? Because I can't review these documents at the level of attention that I personally would like, and that's a problem for me. That's my first.
Mr. Watkins, could I just ask you to clarify what you mean by receiving the board packet 48 hours in advance? Because I believe it was posted 10 days, at least 10 days in advance, and I received my copy sometime last week. So I want to make sure there wasn't perhaps a problem with the one that you received.
There was a problem. It wasn't on the website. It was posted on the website. What? You can ask staff 48 hours ago, before this meeting. And that is a problem, clearly, right? And the fact that nobody knows about it is even more of a concern for me. The second concern that I have that relates to that is the actual work. When I skim through the board meeting minutes, I've never abstained. I don't like abstaining from anything because of opinion matters. And I read through the comments, and it's like, I can't get to all of this. I can't go review the video because I just simply do not have the time within the 48-hour time frame, right? Here's the other deal. As it relates to the enforcement part of this, another concerning pattern, you see, this is the thing that troubles me right now. This is my single biggest thing that keeps me awake at night. And I want to have an answer. The complaints that Dr. Kraus wants to have redefined is decreasing. And yet the rate of public reprimand has increased dramatically. Right now, the rate at which the board is writing public reprimands is going to be the highest number of any executive officer since the board has been, since I've found records for it. Right now, the complaints have decreased for this year, but the public reprimand rate has increased by 44%, right? That's the board's numbers. My own numbers, when I go back and I do a 6-month review for the last 7 years, and I see, oh, the board's actual, just a simple calculation. Last year, up to the end of June, we wrote 57 public reprimands. This year, at the end of June, we are writing 101. If we're going at this rate, we're going to be writing 50% of our complete disciplinary tally for the year. And it's public reprimands. So you listen to the public advocates and you say, and they are concerned like I am concerned, is this the new burial ground for cases? And I'm not being unnecessarily explosive. I'm asking that in actually all seriousness, because I'm concerned about when we review the enforcement process, because there's holes in there. I know nobody, everybody listens, but there are holes in it. You can't have this many people calling into it, talking about the complaints process, not being notified, all of these things. These things are actually really important. And I just want to understand, if you can explain to me how to satisfy the dramatic increase in public reprimands in the last periods in the year that you've been in office here, I would really appreciate that. Thank you.
Okay, Mr. Watkins, I'm very happy to attempt to begin to explain that. I'm very happy to hear you say that when you use the word burial ground, you're not attempting to be explosive. So I take you at your word for that. And you also have to understand when I make my comments to you, I am not attempting to be explosive to you in return. When you talk about the number of public reprimands, I just want to make sure that we're both talking from the same sheet. Basically, in the most recent year, we issued 154 public reprimands. In the previous year, 2021, we issued 108. In the previous year, 135. And the previous year, 133. So I don't see that as an explosive increase in the number of public reprimands. If you look at the public reprimands as they were issued in the quarters here of the most recent year, we issued 32 in quarter 1, 26 in quarter 2. Yes, there was an increase to 56 in quarter 3, and then it went back down to 40. For me, and this is the absolute critical point that I have to stress, when we begin any case review, we have to review every single case on its merits and in the most appropriate manner possible, with a view to resolving it in a way that serves the public interest. For me personally, if that means in any one year a dramatic increase in the number of revocations, well then so be it. If on the other hand it is a reduction, provided we are operating upon a robust methodology, then for me, looking at simply the numbers of absolute sanctions tell you very little when you divorce it from the methodology that you bring to every single case. And we are dedicated, as I indicated to you, to devoting the maximum amount of resources to the most serious cases. And ones that we do not deem to be serious, we attempt to resolve efficiently and effectively. There is no ethos here of issuing public reprimands and somehow turning that into a burial ground for complaints. I can assure you that that does not exist.
We're looking at the same, so we are looking at the same numbers, right? So if you do not think that a 44% year-on-year increase is significant, then you don't, then I am going to say this, that you do not understand the correlation between numbers. This is showing a pattern. So the curve is moving like this for 7, 8 years, right? Here you've got the numbers, right? And then it spikes to 154 from 107, 108 in the previous year. So what you are saying is that that is for a year. So what you are saying, okay, that's just a normal, but at the same time, you say that the number of complaints have reduced. So the correlation of now between numbers is that the complaints reduced, that number should have been way lower. And
which number should have been lower? The public reprimand should have been lower?
The reprimand should have gone lower if the complaints process is like that. Because numbers tend to take a trend. Events take a trend. And it's been consistent with the board for 13 years.
See, what I'm trying to explain to you unsuccessfully, when you look at the 40% spike, you're ignoring the 2 previous years in which there were 133, 135 cases. So it's more a return to trends that had existed previously. You can't just take 2 years and declare that to be an immutable trend.
7 years. I have got 7 years. I took other data, superimposed it on this data,
right,
to get an even more accurate trend. And this little chart that you presented us is consistent with the superimposed pods that I have for the last 6 months. I can take 6 months for the last 13 years and get a trend that will give me an accurate indication of what has happened on the board for every 6-month period, which takes into account all the trends that have happened. With cases flowing up and down, it will give me a stability and a confidence, right? What I'm saying very confidently that this is outside of that trend. And it has never happened to this degree before. And what is concerning is the complaints number has dropped for the year. And I mean, I'm happy to take this up with you offline, because this is concerning for me, because it adds to the narrative that we are creating that burial ground for cases, right? With a board like us that has a trust level that is so low, right? And on top of it, trust is made of competence, honesty, and your care for other people. On the competence side, when we do not receive the board meeting minutes, when there's inaccuracies, it points to competency, basic competency. And this is the Medical Board of California. We have to maintain a higher standard. Or is that just me? Maybe I'm idealistic. I don't know. And I don't mean to come after you as hard because you're just doing a job. I'm just saying that it's a leveling up. Busy is going to be part of what you do, right? Seeing a whole bunch of people, coordinating things, doing orientation, that is part of the job. And then there's going to be the extra. At an executive level, and I don't mean to sound like, like I'm lecturing you, but just at an executive level, when we come to this information, we want it summarized, we want it concise, we want it straight to the point. And that information should be two things. It should add value, and it has to be accurate. And I am saying that I just watch trends, because the trend shows me internal systems that are not working as well. So that's all I wanted to say.
Thank you, Mr. Watkins. Are there additional questions or comments from board members on the executive report? Dr. Mahmood?
Yes. So this is a very interesting discussion. If I don't offend, TJ, I get the impression that you are trying to say that boards, executives, and board has something to not save the public or not protect the public, or we are biased towards the professionals. I don't really see any reason for anybody to be saving anybody. I think everybody in a very good conscience, in a very strong discussion, come onto this thing. Several times we come up and we increase the punishment, and I resent so many times, why so little, why not more? And sometimes we think of, okay, there's not much evidence. And going on the number of complaints and saying, okay, trend is going down or trending is going up, and just public reprimand is not going to really prove something. I think if you are so much concerned about that, what I would do is pick 10 cases of public reprimand randomly for last 3 years each year, and have committee from the board or whoever you pick review those cases, whether those letters of reprimand were fair for everybody or there was some bias, because we want to make sure there is not any bias at any level. And I really don't see anybody to have any bias, because we keep it to the highest standard to investigate and keep anybody who has done something wrong liable and responsible for that, and basically definitely suffer from that. But if there's a concern on that, I think the best thing will be to pick the cases where the decision has been done and review them again. Maybe not go and change the decision, but review them where the decision was made either biased, or decision was too lenient, or where the protection of public was ignored. That's how we can, just going through the numbers, 100 complaints come, maybe 70 out of those 100 complaints are very mild complaints, and things went that way. I mean, I'm not trying to protect that, but I think we have to have a solid evidence to say or get to that extent, where we are just saying that we all are sitting here and we're trying to protect one professional group, and we are against public protection and public safety. Not that. Honestly, I come and I take it very seriously. In some cases, I read, in spite of being physician, and I really deal those things every single day. Sometimes a case I read once and twice and 3 times and 4 times. And sometimes I know staff has to call me, oh, the time has come and you haven't voted yet, because I really take it very seriously that whatever my decision is going to be not only affecting that person, but it's going to be affecting so many of those people how out there, 44 million, 42 million, or 40 million of Californians. Anybody, my sister, brother, my cousin, my relative, my neighbor should be affected by that. And if I'm going to ignore or leave somebody loose, that person is going to be affected. But at the same time, I don't want to okay, every single person comes in, I'm going to assume that person is guilty. I want to look at everything. So we really need to have something where we can really come up to the conclusion, okay, last 3 years, these are the cases done, the decisions are right or not, and we can pick 5 or 6 people, 3 professionals, 3 doctors, 3 non-doctors, and having a discussion and having a very open, candid discussion on those. And there was some decision, we can bring the report up. But I agree with you. We want to keep our impression. We want public to see that we are protecting their interests. Our sole objective and mission is for the protection of public and protection of Californians. And if there is any misunderstanding, if there is any concern, we definitely need to consult that and we need to correct that. But in a real positive and solid, consolidative, logical way, not just going on the numbers are going up or numbers are going down, because these cases are discussed. And these cases have a guideline. And if there is some problem with the guideline, we need to correct that, get to the basic root of the problem, not just have a discussion and debate. That's what I want to close.
Thank you, Dr. Mahmood. Additional comments from board members?
May I speak?
Please, Dr. Kraus.
I'd first like to declare my conflicts of interest. I'm a physician. I've served on this board for 8 years. And I truly am primarily concerned with the health and well-being of Californians. In my 8 years on this board, I have not encountered another board member who has been so negative about our process as Mr. Watkins. And our executive directorship, our staff, our board, our actions should be supported. There are flaws, there are problems, there are many things that are out of our control, We don't control our investigators. We don't control the Attorney General's office. We have a lengthy sunset report in response to the Senate that outlines in very positive manner how we can be more effective. And when I hear repeatedly criticism of Mr. Prasifka, criticism of the board, it worries me that this unrelenting criticism is going to become destructive of our leading to a positive outcome for this board. So I would encourage those of us who may have a relationship with Mr. Watkins or myself to have separate meetings to see if we can bring TJ around to working productively and appreciating our staff and our board processes rather than throwing a grenade in the room. Thank you.
I'm going to
I'm
respond.
sorry, I have to interject and just remind people of the Open Meeting Act and limitations on discussions outside of open meetings. Thank you.
So I want to get, just back to answering Dr. Mahmood's question. I have identified what the issue is. If anyone has gone through what I said in the last meeting, I said that there's a system, and it's not individuals. We are all part of a system. So what this statistics shows, Dr. Mahmood, is the system's operations. And the statistics bear out that we are very lenient towards doctors. And I am identifying and I am doing this behind the scenes to really come up with a solution that would adequately address the system's issue. This is not personal against to any one person. As for Dr. Krause, you see my feedback, you see my criticism of the system as some kind of attack that I want to bring down the board, which is a misconception, right? The other deal, I don't need to be brought around. I take exception to having people talk to me like I'm somehow out on left field. I know exactly what I'm doing. And here's the deal. That me being criticizing the board and the board's processes is directly everything that the board has ignored, pushed aside, and absolutely did not want to address, that every public and patient advocate has said. They scream at us, they tell us everything, and we are completely insensitive to that. We don't hear. It took me all this time just to get the attention of the board, just to be heard as a board member. We are all in the dark as to communications that even happen within the board. I'm trying to help create a 21st century digitally based thinking board that has a fairness as its root, where the numbers do not look so ridiculous. If you think about it, 1.2% of 11,000 complaints gets a probationary period. If that is not alarming, then nothing is. So to clarify, I am not pointing fingers at individual people. I'm shedding a light on a system that has been operating in a particular way. And the side effect of that is dead patients, maimed patients, and people with mental trauma that we hear every day. But we hide behind a legal veil because we don't want to address it because it could compromise us. This board has some of the lowest standards of all the healing arts boards in the Department of Consumer Affairs. And that's all I have to say. And I don't need to be talked to. I am open to a discussion with anybody in a constructive manner, but I will absolutely not stop speaking out to these issues that are arising. Today, you can tell me, oh, bring TJ around because the 44% public reprimands is not a thing until it's 100%. Until we write 200, because we're on track to write 200 for this year. We're absolutely on track to write 200 this year, and that would be appalling. I don't care what anybody says. That's just the fact. So I'm done. Thank you.
Additional comments or questions from board members?
Madam President.
Alejandra, oh, I'm sorry.
Dr. Gallagher. So I'm sorry. Go ahead, Alejandra.
Thank you. I just had a follow-up to a request from the last board meeting that I think would help give some clarity with these spreadsheets that we're looking at for our oversight, which is a regular reporting on the criteria used to close cases, how and why they are closed. So that'd be really helpful if we could see that broken down in the future.
Thank you, Ms. Campoverde. Dr. Gananadev, you had a comment?
Yeah, Madam President, I just want to get off this subject, which I think we all have our own opinions. TJ has his, I have mine, Howard has his. So, but for Mr. Prasifka, so tell me though how we can maintain our financial stability. I'm getting a little worried because the dues increase is going nowhere, and what happens if we don't get any increase or $80 increase or something they're proposing? So I just want to know a little more, because without no money, no mission.
Well, the position is very simple. The $80 increase, which is currently in SB 806, is not adequate, and it does not put us on a sustainable path. With the if you have the effect of the increase, which we hope will come into effect on the 1st of January, plus you have the loan, which will come over from the Automotive Repair Board, those two things together will keep us afloat through the end of the financial year. After that, we go over the cliff. And as has been indicated, we have been trying to operate efficiently as we can. We have identified certain savings. They have had a marginal effect of delaying that day of reckoning. But on the $80 fee increase, that day of reckoning is coming rapidly. And certainly in our discussions with the legislature, we have made that extremely clear.
Well, I think for any budget, usually there are two things. One is increase in revenue, and second one is decrease in costs. And unfortunately, most of our costs are not under our control, which is AG's office and HPOU. So have you gone anywhere in looking at those costs?
Well, of course, we are forced in a position to look at all of our costs. We have a presentation coming up shortly from the Attorney General's office about their costs. Their costs are all activity driven, and we are extremely busy. We're extremely busy trying to manage a very significant caseload with the direction that we're trying to get control of the inventory of cases and to reduce the timelines. Certainly in the short term, that means more activity rather than less activity. But if you look at the overall trends that were said in the last metric, if we continue to be closing more cases than are coming into the system, and continue to prioritize closing cases efficiently and effectively, we will hope that in the medium term, that should bear some additional cost savings. But the point remains that we are currently not on a sustainable financial path.
Okay, I got enough info that Unfortunately, you couldn't do anything much with the AG's office cost at this time. So that increase was significant per hour rates increase. So that put us in a bigger bind. Keep working. Thank you.
Additional comments from the board members, questions?
Jim Helzer, how much of a fee increase would be required to return to a break-even basis?
Well, it would be the fee increase which we had recommended in our fee report.
Which was?
Which was?
I'm happy to help with that question. It was roughly 50% increase across the board for our various licensee populations. It differed a little bit, but I believe for physicians it was 50%, which is the first time in about 15 years, Doctor, since those fees have gone up.
Thank you.
Welcome.
Lori here, if I may, Madam President.
Please.
Thank you. Just circling back to what TJ was saying, as board members, besides upholding our mission on the board, I see it's also our duty to provide oversight and give guidance and advice on how we can improve and shape the board. So when I hear TJ talk specifically about the two issues about, not receiving our board packet on time, that's I take that practically. I myself also I felt that I did not have enough time to receive it. So if there's ways we can help improve that, I'm sure staff is looking at that, and I'm happy to help be involved in that discussion and what improvements we can make to help us help the board. Now, with respect to the public reprimand data, coming from tech where data drives decisions, when I hear a fellow board member talk about statistics like that, I want to see numbers myself. I want to see if that's true. What does that mean? Because our baseline are previous trends, and if that is true, that this trend is going up, then I feel that is alarming enough, at least for me, to ask why. And so, like he has asked, similar to what Alejandra has asked, and more information about how cases are closed and how we could look at this and what we could do. I hope we can move that discussion forward. Thank you.
Thank you, Ms. Lubiano. I did learn that part of the reason why the web formatted agenda and the staff packet was delayed was due to the need for it to be formatted for ADA purposes, and that process took too long. So we'll make sure that doesn't happen in the future. I did receive my hard copy packet in the mail earlier than that. So perhaps one way to remedy that, if it's going to be problematic, is that we provide those hard copy board packets. Maybe that's a workaround, but we'll certainly work on that for the next meeting to make sure everybody gets their packets with sufficient time. Ms. Lubiano, much like you, addressing the question that TJ is raising about, is the number of public reprimands we're issuing this year, is that a signal of something that is amiss in our process, or is it perhaps a signal of something that is right in our process? I think it is worth us, and this is directed to our staff, I think it's worth us understanding that and looking at the evidence that's really behind, so the data that is behind that particular number, that particular data point, right? Is it the case that we resolved a number of old complaints? I don't know, right? More than we had in years past. Is it the case that we were catching up for one reason or another? Or is it the case that for whatever reason, we are being more lenient? So I think for our next board meeting, we can come with that additional information, and make sure we're all working with some additional data that I think would be helpful for all of us to understand, what's going on there in that specific category. Are there other questions before I go to public comments? Other comments?
A quick comment. Well, thank you. That's all I want is an exploration into those numbers. But just on the the board packet deal, I understand things go wrong. I work every day in a space where lots of stuff goes wrong. Here's the difference. If things go wrong, there's 13, 14 of us. Yeah. All it takes is an email and say, hey, we're having difficulty. Bear with us, a communication. When I don't hear 2 weeks out that this is not happening, a week out it's not happening, I'm just thinking, well, maybe there's not important stuff to be discussed. And I go on about my day. And when I receive the packet and I'm like, wow, I want to do this, I want to do that, I'm under pressure, but my life is calling. That's the first point. The second point, to answer the new doctor on the board, welcome Dr. Isa, is that increase was for $367 over 2 years. It's $183.50. There was a fee study conducted that was the absolute minimum just to make this board survive, because we knew we were going to have trouble getting this through the legislature. So the 1150 went from 783 to 1150 on the fee increase. Right now, that is sitting at a ridiculous rate. I mean, that we are not going to see the light of a financial solvency anytime soon. And props to and an acknowledgement to Mr. Prasifka and the team for all the attempts that they've made. I know that I say a lot of criticism, but I also acknowledge the positive stuff. And I think maybe I can do better, Dr. Kraus, in mentioning that positive things too. So I'll own that. Thank you.
Thank you. Additional comments before we go to public comment? All right, Sean, let's open it up for public comment, please, on the executive management reports, agenda item 8.
Okay, give me a sec to open up the Q&A window and the hand raising feature. If you'd like to make a public comment, please go ahead and indicate so by raising your hand or typing something in the Q&A box. First up, we have Rosie Arthurstutter. Rosie, please go ahead.
Hi, thank you very much. For over 40 years, I was working in developing digital records. They could work for medical records or industry, etc. And so in the early 80s, I was making paperless paper trails for all sorts of records. And this is your problem. Now that we've converted pretty much to electronic medical records, you have a lot of different stages of getting up to speed. Now we have patients that can now get records that have been withheld from them and kept in secret for many years. When you get a complaint, you have the complaint, and then you have to get the medical records. As I said before, many of the medical records are more a compliance document that's been copy and pasted from a template, as opposed to an actual clinical record, which is what you have to have your experts look at. And I've seen some enforcement documents where the person says, this record I had to look through. You have to ferret out the actual clinical facts in order to have a complaint, to move forward, or to default to a public reprimand. And that's why the numbers are looking so funny right now. Since about 2016, we've been trending to this new age of electronic medical records, and yet your experts aren't up to speed on how to ferret out the information. And I've seen places where a doctor had a public reprimand, and as soon as that happened, then all of a sudden into the entire practice, all of a sudden there is a note to warn patients about overuse of Tylenol or whatever, and it's keyed on when they got the public reprimand. Now, if patients don't have access to their records, it's hard for them to have a complaint. It's not like the old days with a paper record where if it wasn't in the record, it didn't happen. Then you have people
Ms.
who.
Arthur's daughter, could I ask that you focus your comments, please, on
Okay.
Mr. Prasifka's executive management report through the substance of those reports?
Well, it's based on Mr. Watkins' comments. So that's the reason why the numbers are trending one direction for the reprimands. But if you can actually get the actual clinical record, then you're going to see a different trend totally. Anyway, so it's the record that you are having to deal with that is driving these inequities in the numbers that you're seeing. Anyway, and it can vary from practice to practice, entity to entity, as to how it manifests itself. So it's basically a numbers problem. Anyway, thank you.
Thank you for your public comment. Next up, we have Hannah Ree. Hannah, are you there?
Yes, I am. This is Hannah Ree of Black Patients Matter. So I thank you, Mr. Prasifka, for speaking. You brought quite a bit of clarity and direction for the medical board since Kimberly Kirchmeyer stepped down or stepped away. And so I think you're doing an excellent program. And of course, Mr. Watkins, you're doing wonderfully. There's, of course, many of us that support you and what you're doing. You know, I had presented the solution previously, and I really want to emphasize this because I do think that it bears relevance, and that if it is within the scope of what the medical board can do, and it is a mediation program. A mediation program has the potential to be much less expensive, a faster type of solution rather than a hearing and filing complaints sort of thing. So it is something that we should be looking at. But in terms of bringing it to fruition, I wouldn't know where to start. But mediation would help to reestablish the physician-patient relationship and also help to bring closure to patients who many times are not even approached by the AG's office about complaints. And so I just want to bring that to you and to have it on an agenda and have it looked at. Thank you.
Thank you for your public comment. Next up, we have Susan Lauren. Susan, are you there?
Yes, hello. I'm responding to the comments by Dr. Krause and Mr. Watkins. I am not a number. I'm a person. Sahlberger assaulted me. My case is res ipsa loquitur of surgical battery. The board could not have been any more lenient or biased or apathetic. There were no mitigating circumstances. This is an elephant in the room. I tell you every time that women that I know that have been harmed by plastic surgeons do not file with your board. They know about my case and many other cases that are extreme and egregious, and nothing has been done about that. It saddens me, but I'm not surprised to hear the suggestion that TJ quiet his valid concerns. I've said it before and I'll say it again. Thank you so much, TJ. And what has been going on, not just for these past 8 years, but for decades in California is not protecting patients. And if someone can't see that, there seems to be a problem of perception, that we have a massive problem. And I focus a lot on the plastic surgeons. It is a massive problem. Thank you for your time.
Thank you for your public comment. Next up, we have Marion Hollingsworth. Marion?
Hello?
Yes, please go ahead.
Okay, thank you. Hello, my name is Marion Hollingsworth. I agree with TJ Watkins' alarm regarding reprimands. The sudden increase in reprimands has skyrocketed since Bill Prasifka took office. If you look at the disciplinary alerts that are sent out now compared to previous years, the majority of cases result in reprimands or surrenders. Reprimands have been given for egregious cases such as childbirth deaths, where the woman literally bled to death and the doctor ignored symptoms. Baby deaths, where the doctor wasn't diligent enough and again ignored warning signs. Even sexual abuse cases. I can give you case names if you don't believe me. If a doctor is found responsible for a death, how can the board in good conscience give a reprimand for that? Do you have such little regard for a person's life that you think a reprimand is good enough? And again, the attitude of the board seems to have shifted from good to good enough. Responding to Dr. Krause's response to TJ, don't you want whistleblowers? You old guard board members and longtime CMA members are more concerned about staying on their pedestal than hearing how they can improve to help the people of California. You pushed Judge Feinstein off the board and she resigned, saying in her resignation letter that her bar was higher than yours. Do you see a pattern here in getting rid of board members who don't get with the program? When I spoke at the beginning of this meeting, it was to at least respect us advocates and listen to us. Now I see you are willing to tear down anyone publicly who doesn't agree with you, even if it's a fellow board member. This shows just how divisive this board is and how ineffective this board is. Get your house together and start working for the people of California before you hurt any more of us with your bickering over doctor disciplines. And regarding the fee increase, the CMA charges as much as $1,200 a year in some counties, which is almost 3 times the amount of a 2-year licensing fee. So I don't see why doctors are whining about the small increase. Thank you for your time and get your act together. Thank you.
Thank you for your public comment. At this time, I do not see any other requests in queue.
Thank you, Sean. We'll bring it back to the board. Are there any additional comments or questions? This is not an action item. All right, seeing none, I have the time at 4:32 p.m. We're going to take an 8-minute break and be back at 4:40 p.m. Our next item, I expect, will be a lengthy one about our sunset review process and the legislative vehicle, if you will, going forward. So we'll take an 8-minute break and we will resume at 4:40. Right, Sean, I have 4:40, but if you could just let me know once everybody has reassembled on WebEx, I would appreciate it.
Staff is back here in this room at least.
Okay.
From the looks of it, looks like most board members are back on camera as well.
Okay. We'll just give it another minute. I'm seeing a couple board members who haven't turned their camera back on. I'm not sure if that's because they don't want to be on video or if it's because they're not here yet. We'll give it a minute or two.
Yeah, Christine, I just didn't want to be in the video.
Okay. Yeah, if there are board members that are back and if you could just turn your video on for a moment, even if you're going to have it off for some period of time, just so we can know you're back, would be helpful. All right. It looks like Mr. Watkins, are you back? Let's see that he's back yet. Dr. Hawkins. All right, let's give it a minute.
I'm back.
Thank you.
Wow.
All right, I've got Ms. Lubiano, I think. All right, I think we are ready to get going. So we are on, I'm sorry, did someone have a comment? No. We're on agenda item 9, update on sunset review and discussion and possible action on SB 806. I just wanted to begin this discussion. We've got a couple of new board members and a fair number of us that are going through this sunset review process for the first time. And so I wanted everybody to be sort of brought up to speed with all of the same information. So we all have the same foundation to work with. And in my mind, as I was preparing for this item, I thought, well, what is the sunset review process even all about? Because that sunset review term is, sort of unique to agencies and government and that sort of thing. And so at the most basic level, this process is really an evaluation of the continued need for the existence of the Medical Board of California, right? It's an assessment of the effectiveness and the performance of the board over the period of time for which the legislature is reviewing us. And so just for background, especially, like I said, for those members of the board who are new or who weren't here with us last fall, during 2020, really for a period of time of about 6 or 8 months, our board staff in collaboration with the board was preparing the board's sunset report, which was approved by the board in November of 2020. That was a 380 plus page document. It provided a report on the areas of interest to the legislature, but it also established our priorities as a board, areas where legislative changes would help us advance our mission and improve our effectiveness and performance. And of course, that full sunset report is available on the board's website, for any member of the public who wishes to take a look at it. It's easily findable if you Google Medical Board of California Sunset Review Report. So that report, once it was approved, the priorities were established by the board almost a year ago in November of 2020. In January of this year, it was then published and submitted formally to the legislature. In February and March, our board staff met with numerous stakeholders and staff of the various members of the Senate and Assembly committees on business and professions to explain the board's priorities, explain the specific requests that the board was making through the report, and also to respond to initial questions. The first hearing we had as part of the sunset review process was on March 19th of this year. And I should note as well, while the confirmation of some of our members in the Senate processes really is outside of the true sunset review process, There were, Senate confirmation hearings for our members that were really touching upon many of the issues that our Sunset Review report addressed. And so they've almost been incorporated into this process by default, if you will. Following our March 19th for Sunset hearing, I actually responded formally in writing with staff's help in preparing that response to the specific questions that the legislature had raised in our first Sunset Review hearing. We had a subsequent hearing on May 6th, which again was followed by staff responses to questions that were asked of us at that hearing. And then in May of this year, so a few months back, SB 806, which we're going to be talking about in just a moment, was amended to include provisions related to the Medical Board of California. So it was at that time that bill became the vehicle for this sunset, or if you will, sunrise. At our June 1st interim special meeting, the board did take a support if amended position on SB 806. I know Erin's going to go into a little bit more detail in a bit about what that position was all about. There's a staff report, of course, included in your board packet. In June, following our board meeting, our staff distributed a board position letter to the legislators, and also met with staff of members of the Assembly BMP committee to further explain the board position. In July of this year, just over a month ago, staff and I met with Senator Roth and Assemblymember Lowe, the chairs of the respective Business and Professions committees in the Senate and the Assembly, again, to articulate our board's position on SB 806 and answer any questions that they have. It was a great discussion. It was a comprehensive discussion about our position, and gave us some insight into what Senator Roth and Assemblymember Lowe were thinking as well. Following that meeting, SB 806 was again amended, and then there was a hearing the day after SB 806 was amended on July 14th, was the Assembly Sunset Review hearing. So following that meeting, staff and I met with Assemblymember Lorena Gonzalez, who is the chair of the Assembly Appropriations Committee, again regarding our position on SB 806, and really to articulate the board's concerns and position as they relate to the funding issues and the fee issues that face the board, given her position again as the appropriations chair. And then again, throughout the course of the summer, really on a daily basis, our staff has had numerous contacts with the Business and Professions Committee staff, Senate Rules staff, and a variety of stakeholders who are interested in this legislation. Just in terms of what's up next for the process, and setting aside what we decide is our specific position, I just want to kind of give a procedural update. SB 806, we expect that it's going to be approved by the Assembly Appropriations Committee by the 27th of August. That's just the legislative timeline. So that's where the bill is currently at, is in the Assembly Appropriations Committee. The bill may include amendments at the request of the author, Senator Roth, or at the direction of the chair of that committee. Following SB 806 moving out of that committee, we expect, of course, the bill to then move to the Assembly floor for consideration by the entire Assembly. There's another chance for it to be amended before approval by Assembly, and it must be approved by the full Assembly and the full Senate by the time the legislature adjourns for the year, which is around September 10th. So that's the background. I guess that's how we got to where we're at tonight's meeting. Just in terms of how we're going to proceed to evaluate SB 806 and have a conversation about it tonight, I thought actually our process at our special meeting in June worked really well. So Aaron's going to give his full report on the legislation, bring us up to speed as to where it's at. We'll move to clarifying questions from members. We'll take public comment. I expect there to be a fair amount of public comment from various stakeholders. And then I'll try, like I did at the last meeting, to organize some topics or themes for us to then have a conversation about. So I'll be on the lookout as you ask your clarifying questions and as the public commenters make their comments as to what those themes are, so we can kind of organize our conversation and then seek consensus or a position on those particular topics. Of course, if I miss something during that process, speak up and please let me know if there's something I didn't get, written down as one of the themes. But I think that'll help us guide our conversation, particularly given the significance of this issue, as well as just the sort of wide variety of issues. And then we'll take a vote if we get to that point on our position. So with that, Bill, I think you may have some remarks about the sunset process from your perspective, and then we'll also move to Aaron's specific remarks about SB 806.
Well, simply very brief. I can certainly share the view of those board members for whom the sunset process is an unfamiliar one. This is the first time I have gone through the sunset process. I have found it to be sometimes mystifying and opaque at times. But what we have seen going through the entire process is that I think we are beginning to see light at the end of the tunnel. There are obviously some things that are extremely important to the board, which we have prioritized. We have already spoken about them. The fee increase obviously is fundamental. It goes absolutely to the sustainability of the board. If the board does not have financial independence and the ability to operate, then it cannot be effective. So that is absolutely critical. We were obviously disappointed when the bill was amended and the fee increase was significantly rolled back. That was a setback, full stop. However, we are still engaged in the process, and subsequent discussions that we have had since that date with the relevant chairs of the committee indicate that they fully understand that we are not on a sustainable path and that is simply unacceptable. And so, yes, there is a commitment that this will be re-looked at next year. And so that gives us another opportunity to make the case, and we will effectively be in a stronger position if for no other reason than we will be closer to insolvency and without an ability to operate. So yes, it was a setback, but we do see a way forward. We have cost recovery, and that's in the bill, and that's a very important part of it. Also, what we have now is on the agenda is firmly, even though it was taken out of the bill, is a lay majority. The board has spoken on that, and that's a very important change. In addition, there are some technical amendments on enforcement and licensing, which are there. So yes, we've had setbacks, but we have engaged with the process. We are very fortunate. We have a very professional legislative expert in terms of Aaron Bone, who understands these things and has been able to guide us through the process. We have an enormous amount of engagement that we've had with the relevant decision makers here. And also to the other board members to know that the president and vice president have been extremely supportive of the staff in all these endeavors. So I am optimistic, maybe cautiously optimistic, and I think it's very important we remain stuck in the process. That's all I have to say.
Thanks, Mr. Prasifka. And Aaron, I think you are up to provide us the analysis of SB 806 as it stands today.
Thank you, Madam President. I feel like you were flashing back throughout my entire year when you were going through that timeline of activity. It's really been quite an eventful year, I would say. Good evening, members. Yes, so we're talking about SB 806, our sunset bill. The board in its prior meeting on June 1st, and I'm grateful that we were able to have that off-cycle meeting. It did prepare us to have really the kind of informed engagement that you heard outlined by the president and Bill. So having that position from the board was was and continues to be very valuable. The outline of that is mentioned on the first page of the analysis. There's some bullets there under the header, the subhead of recent amendments in action. That lays out the position that the board took of support if amended, with those 4 specific items there: updating the majority of the membership of the board. Excuse me. Some changes we were seeking in the enforcement monitor language, of course, fees, and then extending the board by 4 years. And then in addition, we've been continuing to advocate for the various statutory amendments that you heard Ms. Lawson reference in our sunset report. It is a great read. Yes, I think 367 pages is 87 pages, and I think it weighs in at, I don't know, 4 or 5 pounds. So some light reading. The bill has been amended. It was amended July 13th, again, as reference. Those amendments are bulleted out for the members on page 2 of the analysis. I'll just pick a few of the key ones that are, particularly significant. Again, the role and the authority in the enforcement monitor has been clarified in the language, and certain milestones for that monitor have been established in the language right now. The board's authority is expanded to use electronic licensing applications and removes the requirement to send paper renewal notices to renewing physicians. This relates to a previous board discussion where we indicated the desire to eliminate paper and establish those certain efficiencies that will lead to hopefully quicker processing times as well as reduced expense. The bill right now states the intent of the legislature for the board to grant a medical license to an applicant after as little as 12 months, with the requirement that they continue in and complete 36 months of postgraduate training. As we've discussed in prior meetings, and as you've heard from advocates from the physician community, great deal of concern that's been raised with regard to the postgraduate training license and the amount of time. What should be the amount of time that a physician should be spending under postgraduate training before receiving their physician and surgeon license? And there's a discussion later on in the analysis that speaks to that. And then the last significant amendment deals with the issue of the confidential letter of advice and the authority that the bill would grant the board to provide to the executive director to do so. The language also provides for rulemaking would be necessary in order for that to take effect. And as noted in the analysis, that was one of the priorities of the board as approved in your report at the end of last year. Unfortunately, as we noted, there are things that are not included in this bill that the board has been seeking and we've been working toward all year. Licensing fees are not where we need them to be. The composition change to the board is not included. The board is still being extended for a 2-year period. We've been seeking a 4-year period. And the bill does not include for a new board to regulate licensed midwives. One of the most significant policy matters, as I mentioned, yet to be finalized, it does have to do with postgraduate training. Again, the bill has intent language that will need to be amended further by the legislature before the board could implement any such policy. And the board has that opportunity tonight to indicate to the legislature whether it agrees with that approach or desires to go in a different direction. When considering a position tonight, I would like to remind you all on the final page of the analysis that includes some summaries, a summary of some of the priorities of the board that are being addressed in the bill. As also stated there, the board does currently have a supportive amended position, and if we were to maintain a supportive amended position, that would authorize staff to continue to go out and work again on these priorities for the board for the remainder of the year. However, even if the bill does not get amended in all the ways that the board wants, because this is a sunset bill and it's unusual compared to other bills, I'd still recommend that the board direct staff to request the governor sign the bill into law, lest the board be sunsetted, which I don't believe it's the priority of the board. So with that, Madam President, I'm happy to answer any questions.
Thank you, Mr. Bone. Are there clarifying questions from board members at this time?
I
Someone,
have a question to Aaron.
Mr. Watkins.
Yes, this speaks to the process, but, as we go through this process, I take a public perception view when the board does its business, and I also understand this legislative process that we are moving through. I've gone through sunset. So on the 1st of June, when we had the special board meeting, right, and it's on the recording at the 3-hour mark, we established the position that says we actually oppose this bill because it has nothing that we really want. It doesn't have the public majority. It doesn't have the 1150 increase. It didn't address all of it had cost recoveries. It didn't have the 4 years, those types of issues. So on the fundamental things, this bill did not have it. So the spirit in which we made that decision was we couldn't, again, that will be our back against the wall. We couldn't say oppose unless amended. So we had to take support unless amended. This is the thing that troubled me, that on the day that this bill went before the assembly, our executive officer went onto that committee, and now I understand why. And he gave a foolhardy support position if amended. The impact of that means essentially, from my perception and understanding this space as well, is that now you can go back and you want to negotiate. Aaron can go back, and they'll just say that the board already supported this position, right? And my second question is, and this is going to be controversial, but since I'm there, I might as well, is how much of this influence is coming from the California Medical Association? I want to ask that from Aaron if he knows, because this bill actually does nothing to really impact the future of this board in a positive way. It gives us consolation prizes. If we don't get the 1150 fee increase and we kick this thing down the road a year from now we go through this whole thing and we'll give up cost recovery. We know how the story goes. At some point, we got to take ownership of the board and really determine, hey, what is it that we want to do? And what is it that we are going to, how are we going to proceed strategically? Going to the legislature every time, knocking on their door and coming up with another compromise, then when we don't even know who we're negotiating with and what we are negotiating against. But I can tell you, this force that we are negotiating against is way more powerful than the legislature and all of us. And I'm just putting this out there because this is a conversation that we are going to have over and over again. I'm strategically working on this because, like I said, this is a system that we are operating in. And again, I'm not knocking any one person. I'm saying we are all, we've been maneuvered into a corner that we must accept whatever the legislature gives us because we want the board to continue. And I just really want real straight kind of insight into this so that we can actually address this thing and not go through the motions. I'm just going to stop. Thank you.
Well, I mean, Mr. Watkins, I'd like to take a shot at answering a couple of your, or not really answering, but commenting on a couple of those points, right? Because for better or for worse, we exist because of the legislature, right? So we're in a process that isn't our own process. We're just one stakeholder of many who are participating, right? We're participating, on behalf of this agency the legislature created, 100 plus years ago, right? With some real, and I should say, we have a real understanding of how what the legislature has done works in practice, right? So whether it's the Medical Practice Act that we are applying, or whether it is this sunset legislation and prior sunset legislation, right, that has authorized us to exist and authorized us to continue. I know, I mean, there are members of the board, including myself, who participated in the last Medical Board of California sunset review process, which literally went down to the wire at the last day, at the last minute, and was held up over, you know, a political issue, you know, that was being debated amongst legislators. And so I guess I know how this can go, and that in fact, that's sort of how it's going here, right? There's a variety of interested stakeholders that have a variety of different opinions, and we have ours. I can assure you that we have been strong and strident advocates for the board's priorities and positions. And, you know, having been in the meetings with Senator Roth and Senator Lowe as your representative, you know, in this process, I can assure you that they know very well what our position is about fees. And for whatever reason, they're reconciling a variety of other stakeholder positions about fees. And we are, you know, we're getting copies of the bills and the amendments as they come. And so, you know, it's not an ideal position, right, for us to be in terms of consumer protection, because our sunset report actually outlines ways that we can improve and enhance the effectiveness of the board, the performance of the board. It tells the legislature and the public, frankly, exactly how much money we think we need to do it in the constraints that exist for us, right? We don't have any say as to who we use for our lawyers or how much they charge or HQAU, all these other things. So we've crafted this sunset report, which I think is a really pretty comprehensive, you know, substantively adequate representation of how we can improve. And on all points, we're not being listened to. They're hearing us on some, but we're not being listened to on all points, right? But it's not because this board or the representatives you've designated, which are me and Dr. Hawkins, and of course our staff, it's not because we're not advocating, you know, as strenuously as we could for these positions. It's because there are lots of other forces at work, right, in the legislature. And ultimately, at the end of the day, we're a creature of this, you know, we're a creature of statute, you know, and our continued existence depends on the Senate and Assembly willing to extend our existence.
Thank you, Madam Chair. That was more enlightening, and it restores that thing in me that is always questioning, why did this happen? Because of the public perception of it, right? But what you just explained is, again, you know, the precarious position that this board finds itself in, and everybody in the process is doing the best that they can, and it doesn't always look like that. I'm the first one to give criticism before the, you know, public advocates come on. I can see that we are in such a precarious position that we want to continue the board and then be left with another opportunity to remedy some of the issues that even I have raised. So I'm very grateful for that explanation. That really cleared up a lot for me. Thank you.
Sure. Are there other comments or questions, clarifying questions about the legislation or the process before I open up for public comments? Dr. Gananadev, I see you're ready.
Thank you, Madam Chair. As the last board president who went to the sunset with multiple negotiations till the last day when it looks like this board will be shut down and given away. So these are negotiations. Don't forget, there are multiple players in these things. It's not any different than education. Teachers on one side, education board on the other, or the police, law enforcement. The law enforcement on one side, with the advocates for the accused are on the other side. So this is the responsibility of the elected people, and they do in their best thing. So our job is to recommend, and we get some, we don't get some. That's the way it goes. but slowly we got more and more and more. I think I'm fairly happy that what we are getting, except in the finances, which still worries me a lot because, as I mentioned, that no money, no mission. So, but I don't have any doubt that if it is not solved this year, it will be solved next year or a year after. So I still wonder where that automotive place has $12 million to loan to us. I was just curious how even that money, how come they have that money? Maybe they don't have to pay the HPOU and the AG's office. I have no idea. But actually, Mr. Prasifka and Ms. Lawson, I think you guys are doing a good job. This is a tough job. I've done it before, so I know it. And it can get to a point where last time Assembly and Senate were on the opposite sides. If one wanted one, the other did not, and they were going to let the medical board die. So if it is not sunrise, there is no sunrise, then the sun sets. So that's what it is. So I think it's a negotiation. I understand TJ what his feelings are, but that's what life is. Thank you.
Dr. Hawkins, may I speak?
Please.
Yeah, Christina, so thank you. I couldn't make that meeting, but thank you for your response. Thanks for your question, TJ, because that was my question. You've answered it. I'm going to ask you another question, which you may not be able to answer now, because you specifically said you had some insights when you met with Roth and Lowe. And I don't know that we'd want to show our cards, but do you think that based on the skills that we have with staff, and I'm including leadership as well as you and prior members, that there are things that you believe are in the toolkits from your interaction that you think can help move us along the way?
Sure. Yeah. And I mean, just to address that, I'll give an example. And I don't, first of all, these conversations aren't confidential, but I don't feel like I'm, breaching some confidence by saying, we have had a robust conversation directly with the legislators about our need, for additional funding in order to continue to protect the public in the way that we have all of these years. And so I think that in having the conversations directly with the legislators and with their staff, we can get a good understanding of, the types of things they're looking for, what they prefer to see in the fee study, what they want to know about our operations, right? Perhaps in a different way than we had packaged it in our sunset report for them to review. The types of things that would help them reach the decision that the fee should be increased to X or Y level, right? And so that's why I think these conversations, especially the conversations that Aaron and others are having directly with the staff to these committees, the staff to the legislators, really gives us, kind of good insight into what they're looking for. Frankly, again, how we can improve. How over the course of the next year, if SB 806 stays in the current form, we're going to be having that conversation again about our fees, and we're going to be providing more information and doing a deeper dive into our operations so that they can really understand, and so that they, to Deb's point, they're elected officials. They are elected to represent their constituents, who, all of whom are us. And, they take that responsibility very seriously, too. And so we can do our job better in getting them information that they need. Again, we had a great conversation with the chair of the Assembly Appropriations Committee. She was asking very good questions, right? And that, again, helps us, think about how to improve our performance. I think it makes us better as an agency to be having those conversations, frankly, to have the sunset review process as time consuming, and in some cases, frustrating as it can be, because we can't always get our way. But those are the types of conversations we're having. I also would say that the board's priorities and the board's positions are always top of mind. And our staff are always providing, the legislators and their staff, information and ideas that will advance the board's priorities and the board's position, right? So even if something in the legislation isn't exactly as we might want it, it's still well informed by our staff and and by conversations saying, well, here's how to move forward in accordance with the board's priorities. So it's tough, right, with this language, and ultimately at the end of the day, when we take a support if amended position, we are taking that position knowing that we might not get everything we want, right? But with a priority in mind that the continuation of this board protects the public, right? That perhaps that's the paramount priority. We haven't had that conversation yet today, but perhaps that's the paramount priority, that we continue in existence. And even if we can't get our fee increase to the 100% level that we'd like it to be, we'd still like our mission to continue. So I do think we benefit greatly by these, the ongoing conversations. Dr. Gananadev characterized them, as negotiations, which is really what they are. And Aaron is doing just a great job behind the scenes, and I'm in constant communication with him weekly, about everything that's going on. Additional comments, questions? I think I heard somebody come off mute.
Oh, I had a few questions.
Sure, Ms. Lugano.
Yes, with respect to the 2-year extension, so one, I was wondering, when does that 2 years start? Would that be when the law is signed? And then second, I think many of us feel that 2 years is really short. By the time we feel like we're making progress, we have to prepare for sunset again. And wondering what are our chances realistically of getting that increase back to 4?
I'm happy to take those. So the chances of getting them to 4, I'm gonna not good. So I think with all the scrutiny and the comments that have come through stakeholders, through the sunset hearings, as well as the comments that were made, in general to the legislature, because they hear them all year round, not just at these specific points through sunset. I think the sense is waiting 4 years to address some of the items that I think maybe they're hearing from, but they don't have all the information, which they hope will come from the enforcement monitors' work and their reports. The timing of the enforcement monitors reporting is intended to align with this 2-year sunset extension. So that's the first part. And then to answer your prior question, the clock will begin January 1 of 2022. So it doesn't start when the bill is signed, which will happen September or early October. The clock will begin January 1, 2022, and it's a 2-year clock, so the time will run out December 31st of 2023. So that's why you see the dates in there, moving from the sunset dates, moving them from January 1, 2022 to January 1 of 2024. Is that helpful?
Got it. Yes, thank you. And the other question I had was with respect to cost recovery, assuming that stays in there, who developed the framework and model, and also who is the muscle on making sure those amounts are collected?
So I'm happy to answer what I can, and then maybe I don't know if Ms. Webb may be able to help me out. But so cost recovery can, I think, be initiated through 2 different means. One, it could be through an order from an administrative law judge. And at some point in the process, there is the opportunity for the board to report costs. So there'll be a tracking system that we'll be working to implement of what those costs are. And then if it's a proposed decision from an ALJ, then that individual will determine an amount. But then also that could be something that could be done through the settlement process through a stipulated settlement. I don't know if I've left any points out. I'm sure Ms. Webb will jump in to clarify. But is that helpful, Ms. Libiano?
Yes, I was hoping, I wanted to make sure that if that stays in, that we're ready to be able to collect those funds in a timely manner.
And I can tell you that not all cost recovery that is ordered is actually collected, but it is something that comes up when physicians seek to have their license reinstated if they've surrendered it following discipline action, or if they're revoked. If they seek reinstatement and they haven't paid their cost recovery, then that will be an issue for them. So it's an effective tool there, but not everything is recovered that's ordered. And sometimes not all the costs are ordered by the administrative law judge if it goes that far. Sometimes it is reduced, but it's still an effective tool in negotiations, and the board has used it in the past and will be prepared to pick it up if it stays in this bill.
Are there other boards in the California DCA that have cost recovery, and has it been effective for them?
Cost recovery is common, and to our knowledge, we are the one that does not have it, which I think kind of got us on this journey, some time ago. So in the analysis of the bill on page 4, there's a bit of a discussion on cost recovery. There's a table there that we produced with some estimates of what revenue might be, and that was based upon a analysis of the Osteopathic Medical Board, who's been using cost recovery for quite some time. And so to Ms. Webb's point, their collection rate over the last 10-year period is 62.3%. But the order amounts are relatively small. The average order amount over a 5-year period was about $7,500. So now that's a very small percentage of the actual costs that get invested into, prosecution and investigation. So, clearly something with the administrative law judge process, there's a great reduction that we're seeing that comes with that. Because, some cases could be 6 or 7 figures, right? That the board might sink into a single investigation in prosecution cost. But anyway, those are what the numbers that we have, to lean upon right now, Doctor.
Dr. Hawkins, may I say something briefly? The PA board has cost recovery, and they say they collect. Ms. Castro also stated that which she is able to view says that they collect as well. And they have some arm twisting ways to get some of the funds.
Yeah, Aaron, I think the biggest benefit probably from cost recovery is not just collecting the funds. It will somewhat prohibit the doctor's attorneys to drag this on forever. I mean, that's one of our biggest problem is they keep asking for extensions, this and that, so it just drags on and increases our costs. So I think cost recovery acts that pretty well. But let me ask you on this one, why legislature, I'm still not understanding, wants only go for 2 years, even though they have a right to amend any time. I mean, Sunset Bill just says that medical board will exist for 4 years. It doesn't say they can come back next year and change anything they want, and the year after they change anything they want. So yeah. I'm just curious why they're stuck on this 2 year.
Well, so couple thoughts on that. One, some boards are only getting a 1-year extension. So we could be there. We could be with one. One of the other items that in the consideration that I learned is that because of COVID, a number of boards that were to be reviewed last year, the legislature was simply unable to. They were out of session for weeks while with the pandemic in full swing last spring. So a lot of that work got pushed into this year. A lot of boards were put off last year into this year. And so there's a lot of boards. I want to say it's 15 some on boards that they had to deal with this year, which is out of balance compared to the 35 to 40 some odd boards that there are right now. So I think there's a bit of a reshuffling of the deck that they are looking to do. But there are, I can think of at least two boards that are only getting a 1-year extension. So I'm going to choose to be optimistic and be pleased that we're not in that boat.
Is there any remote chance that this could be over to next year, or are we confident that there'll be a resolution this year?
I cannot imagine a scenario that anybody intends to put this off to next year, because not only are we in this bill, the Osteopathic Medical Board is in this bill, the PA Board is in this bill, the Podiatric Board is in this bill. So with 4 boards in one bill, I'm not going to say nothing's ever going to happen, Doctor, but you can knock me over with a feather, I suppose, if this bill does not get down to the governor's office and sign the law.
Thank you.
Welcome.
Additional questions? I do want to get to public comment.
Alejandra, to switch gears to the confidential letter of advice, it seemed like pretty murky, things haven't been figured out. There's still an implementation and oversight question of how it's going to work. So what, in your conversations, what is that looking like? And what exactly is already written into this bill?
Sure, I'll let Mr. Prasifka cover most of the response, but what is in the bill right now is, let me pull it up, is not a lot of detail, because the legislature is delegating authority to the board to establish the parameters for this program in regulation. And it does speak to, the language speaks to, I'm on section 14 of the bill, and speaks to, there would be, there would be some sort of remedial action, some sort of educational course or other remedial action intended to resolve the complaint. The language speaks to the complaint, and the letter would be confidential, would be maintained for 3 years. From the date that the complaint was received, and if no further complaint against the licensee is received, the complaint and the confidential letter of advice shall be purged. But
Well, I guess I saw all of that as well, but
yeah.
For example, I saw that it said it would be purged, but what does that mean? Purged completely? Would there be any record of there having been a letter? Like how, like those levels of detail seem important. And they're delegating to us, I understand that, but there just seems to be a lot of question marks here. And is the enforcement monitor going to also be looking, and is this going to be a part of the enforcement monitor's report as well? Like what does that look like?
And Ms. Campoverdi, if I could just interject, subsection D of that section, 14, section 2227.3 requires us to go through the full formal rulemaking to establish this program. And that's the way it's currently envisioned, right? It says we may establish, or excuse me, the board may delegate to its executive director the authority to issue these administrative confidential letters of advice. It requires us to adopt regulations that spell out exactly what that program looks like. So there is a lack of definition in this statute or in the bill as it's currently comprised as to exactly what those details would be. Those details, however, would be entirely within our control as a board to set once they came to us in rulemaking. And the rulemaking process, is lengthy, it's thorough, it's inclusive of public comment and public participation. So from my perspective, the fact that this would create the opportunity for this confidential letter of advice certainly does not, mandate that it be created, and two, it leaves open the program and what we would expect of that. Really to us as a board, to create that. I know Mr. Prasifka has some ideas about the types of things that he would recommend, right, when we got to that rulemaking, and Bill, happy to have you speak to those. But I do want to make sure the board knows this is going to be a program that's entirely within our control, as it's currently written in this legislation.
That's
You know,
helpful. Thank you.
if I could maybe just speak very briefly on the points. The first thing I would like to say is that this is not some new novel approach that I or some staff member just dreamt up out of nothing. From a very cursory study, I think we've identified at least 20, 21 other medical boards in the United States that have such a power. I suspect that there are many more because they, call them different things and they operate in different legal systems. There's a couple of things to say about it. One, these are for the less serious matters, and I am a firm believer that the way to manage an efficient complaint system is that the less serious ones need to be resolved on an expedited basis, and that means not having everybody have to lawyer up. Number two, this is to keep in mind, under the current system, if you have a complaint and the accusation is quite serious and you look into it and you do an investigation, you subpoena the records, and if at the end of the day it may be considerable expense, you find that there is only one simple departure identified, then the medical board drops out. We can't do anything at all. At least here we would have the ability to fashion some kind of remediation and have that be in some way enforceable rather than just a suggestion. But really what this is about is having an alternative tool which needs to be used in a responsible manner. I would like to remind the board that every single disciplinary sanction, whether it's revocation at the highest or letter of advice at the lowest, can either be inadequate or can be abused. For example, if there's a letter of advice that's issued, and let's say the physician has done nothing wrong, but we force them to sign this because we say, unless you sign this, we're going to continue the investigation and cause you pain and anguish and money, etc. That's an abusive process, and that would be terribly wrong. On the other hand, if we have a letter of advice for a matter which goes to fitness to practice, that would be completely inadequate. But you can say the same thing about revocation. For example, you can have a doctor who's engaged in very serious wrongdoing and we revoke the license. But it may be the case that the appropriate sanction is actually a criminal sanction and is incarceration. So revocation itself can be inadequate. And of course, it can also be abused if there is no significant deviation from the standard of care. Simply put, when I came to the medical board, it seemed that there was a glaring gap in our rulemaking kit, and everybody else in the world is looking to resolve these complaints informally, whereas we in California did not have that. Now, I'm fully aware that the tool is not appropriate for certain cases. I certainly am aware that the most serious cases need to be investigated, and you have to lawyer up because we're talking about very serious sanctions. So it's not there for that. But lots of cases come across my desk, and there's been a lot of investigation, a lot of resources spent, when you can tell very quickly that this was never a case that was going to amount to a significant sanction, and that if there was a way to resolve it in which you could have the appropriate remediation, that was the best way to protect the public. So that's certainly the spirit of the proposal.
I have a question quickly for Bill. While you speak to this letter of confidentiality, maybe you can speak to all of the concerns that the patient advocates have with the deep trust of the board, because it's terrifying the patient advocates when I'm talking about excessive, sudden increase in public reprimands. I would like you to explain to them and maybe perhaps reinstall some confidence that this is how we will use this tool. You see, because when you speak about 21 other boards are doing it all over the world. It's not a novel idea, right? This board is very different because it has an inherent distrusting public for good reason. And I just would love for you as the executive director to speak to that and kind of help us along to kind of instill some trust in this thing so that it's less terrifying.
So Mr. Watkins, I'd like to just have us pause there. The confidential letter of advice is our idea. It was in our board sunset report that we all approved in November of 2020 and then forward to the legislature, right? So the legislature is responding to something that was our idea and was advanced to them as one of the tools that we could use. The way it's currently written, and we can debate SB 806, which is what I'd like us to focus on. And I'd like to actually get to the point where we hear those comments from the public, so then we can think through whether we want to change our position or not. But that conversation is, in my opinion, really best had when we're going through the rulemaking, when we're trying to decide what this program would look like, what we want the program to look like, right? From the board's perspective. This is just allowing us to have it, right? The way that the legislation is currently drafted.
I was just trying to address some lingering anxiety that will come through the public comment part.
Fair enough.
To give that build an opportunity. Thank you.
Yeah,
well, okay.
Bill, I'd like us to actually, let's get to the public comment and then let's have this conversation following the public public comment. Are there additional comments from our board members about, clarifying questions about SB 806 in particular, or any of the particular, topics that Aaron raised earlier?
I have a question on our process on this topic.
Yes.
And that is, so far, we don't have a motion on this bill.
Correct.
If we go to public comment, come back to the board, and then propose a motion, do we have to have another round of public comment? Should we entertain a motion before we go to public comment?
Carrie, can you provide direction? I didn't understand that we needed a motion before we heard from the public.
We've done it both ways. I think that right now the position is support if amended. I think if there's going to be some dramatic change after that with a motion, that may open you up for another round of public comment. But that's within your discretion. But I think you're trying to be informed by the public on whether that's a legitimate position to maintain and what the talking points should be going forward. So
I'd like to open it up for public comment. Yeah. I guess I'll take the legal risk, and then we can, if we need to go back out, we'll go back out. So Sean, let's open it. Unless there are other comments from board members, I'd like to go out for public comment. All right, Sean, let's open it up.
Okay, I've activated the hand raising feature in the Q&A window. For anyone wishing to make a public comment, please indicate so, and we'll call on you in the order received. First up, we have Hannah Ree. Hannah, are you there?
Yes, hello, I'm here. So this is Hannah Ree of Black Patients Matter. And Mr. Prasifka, I am so grateful to God for your presence here. It is whoever sent you in this direction is just so blessed, and I'm very grateful also to have met you in person when you came to interview for the position. So, yeah, speaking of revocation that can be abused, you need to look at my case, of course. So, of course, in my case, my license was revoked in retaliation for speaking out.
Ms. Reed, do you have a comment on SB 806?
Yes, I'm commenting on it right now.
I think you're commenting on your disciplinary process. Can you comment on SB 806 in particular, please?
As you may or may not know, when speaking, we often have an introductory comment, so introductory statement. And so that was my lead-in to SB 806. That being the fact that, to quote Mr. Prasifka, we need to resolve complaints informally. So what I see in SB 806 is the fact that, yes, it's wonderful to see that the advocates, the comments that we have, do carry some weight with the legislators. So that's very nice to see. But where we're headed to, and I'm very excited about, is mediation. This is where we're headed. And I'm going to reach out to the legislators to discuss with them extending 806 and myself understanding better the process by which the medical board operates. I think that we are all headed in the same direction, but that some of us may be a little stubborn about having others at the table. So thank you.
Thank you for your public comment. Next up, we have Rosie Arthur's daughter. Rosie, are you there?
Yes, I am. And I wanted to speak to the confidential letter of advice as well. I think this used to be called resolution to correspondence. Maybe it's been given a new life or new name, or maybe it's an alternative. Anyway, because of the diverse nature of different entities, some places you're likely to get complaints that arise, and in others you won't get any, like for chronic pain patients, because they can't get a new provider under the current situation. They're not going to make a complaint, even though something may be very, very bad. And if they do get a complaint in, it's likely to be brushed under the table. Some of these organizations have become safe havens for incompetence. So if you're going to resolve something by telling somebody to take an educational course, then you have to look at the educational course. A lot of these courses for pain management are based on revenue generating schemes and people who have a one focus for the patient, that's MAT. So MAT isn't for everybody. So you could be funneling valid complaints that really deserve more investigation, but are difficult to investigate because of the precarious position of the complainant. And, you know, I could see somebody sends something to the wrong name or the wrong area code, or, you know, there's a paperwork error. It's fine. It might be appropriate for that. But when somebody intentionally double bills or triple bills or bills for things they didn't do, I recently saw a chiropractic evaluation for a patient located in Northern California, done by a chiropractor in Southern California, and they had no qualms in billing for it. They billed like $700 in excess of what was actually done for clinical visits. So, you know, you could see these being, oh, that's a paperwork. Somebody did it by accident. You know, we shouldn't get a anything bad. Just this little confidential letter. But I can see it as being something, as an advocate, I see this as being something that creates a safe haven. I can understand there are times when it is appropriate, when it is merely a paperwork, when it is a paperwork problem or something like that. But anyway, that's my big concern. And then the education that people get, it needs to be more diverse, not just focused on a particular manufacturer's medication or treatment modality. Because thank you.
Next up, we have Dennis Cuevas Romero. Dennis, are you there? Dennis, your line is open. Are you there? I'll try back with you in a minute, Dennis. Next up, we have Marion Hollingsworth. Marion, are you there?
Yes, I am. Can you hear me?
Yes, please go ahead.
Thank you. Good afternoon. My name is Marion Hollingsworth. Regarding SB 806, the Sunset Bill, The confidential letter it contains is alarming. It's so generic, no information on how it will even be implemented. Saying the board will have total control over it is not reassuring because you're already so lenient on most cases anyway. Mr. Prasifka could very well use these letters for death cases, and we will never know. One person deciding on a discipline could be rife with conflicts of interest and personal bias. I can tell you firsthand that these letters the medical board sends are not seen as anything serious or threatening by the doctors. The board told me an educational letter was sent to one of my doctors in my complaint, encouraging him to reach the highest level of professional care. That did not have any effect on him whatsoever, if he ever did get a letter, because within 6 weeks he had overdosed an addicted patient on 480 Vicodin pills. Later at his panel hearing, he blamed the dead patient for being manipulative. This is my concern with these letters. Doctors will gleefully agree to them because no one will ever know they were ever in trouble. It's a get out of jail free pass. Also, why vote for a bill that says someone will decide on a rulemaking before the confidential letter goes into effect when you don't even know when those rules are? I strongly encourage you to either take this letter issue out of SB 806 or at least have some type of notice to the public that these letters were actually sent and for what violations. You could do this while leaving the doctor's names confidential. That way the public would at least have an idea of how many letters are being sent out and why. And finally, will Mr. Bond or someone else answer Mr. Watkins' question on how much influence the CMA has had in the development of 806? No one has done that, and many of us are interested in that answer. Thank you.
Thank you for your public comment. Next up, we have Shonda Wesley. Shonda, are you there?
I'm here. Thank
Please
you.
go ahead.
Thank you, members of the board, for the chance to address you. My name is Shonda Wesley, and I'm a medical negligence survivor. The egregious change made in the Assembly Policy Committee, which granted the medical board's executive director sweeping new authority to issue a confidential letter of advice to a licensee to resolve a complaint for an alleged violation of the Medical Practice Act, should be struck. It would be irresponsible to afford this authority to the executive director, which will further hinder transparency and accountability in an organization that has already very low public trust, and take the place of the role that should be the board members. To make matters worse, these letters are thrown out with the patient's original complaint 3 years afterwards, giving the patient no opportunity to be part of the process and no record of the discipline. So the board should lobby to strike this amendment. The current fee, payable every 2 years, is $790 per licensee, and the fee study suggested it should be $11.50. That's a difference of 50 cents a day. I've noticed a staff member referred to the increase as a 50% increase, which it is not, and I suggest that the medical board steer away from the opposition's talking points further in this matter. In the meantime, I suggest the board should lobby for the full amount since the fee has not been raised in 16 years. The opposition successfully cut cost recovery out of the bill and appropriates every time since 2006. Right now, cost recovery still lives in SB 806, but the CMA will attempt to strip cost recovery out of the bill as they have already testified. Keeping cost recovery in SB 806 is the only leverage the board will have to discipline doctors. The board should lobby for both cost recovery and the full original fee increase to be part of the final form of the bill, if this board to even have a chance of redemption in the eyes of the public and show they stand up for patients. If not, I'm not truly clear on what benefit the medical board can provide to consumers like me. Thank you for your time.
Thank you for your public comment. Up next, we have Katrina Reyes. Katrina, are you there?
I am. Can you hear me?
We can. Please go ahead.
Great. Thank you. Good afternoon, board members. Katrina Reyes with the California Academy of Family Physicians. We urge the board to support amendments to SB 806 that would include the language in AB 1156 in that residents are eligible for physicians and surgeons license after successfully completing 12 months of postgraduate training for graduates of medical schools in the United States and Canada, or 24 months of postgraduate training for graduates of foreign medical schools. Allowing residents to be eligible for a physician's and surgeon's license after 12 or 24 months does not mean that residents will be moonlighting without the knowledge of their program director or without any oversight. Residents must obtain prior approval from their program director before they are able to moonlight. Moreover, residents receive oversight from the supervising physicians where they are moonlighting. Prior to the PTL, residents were eligible to receive their physician's and surgeon's license after 12 months, and there has been no data presented of the frequency of residents leaving their program after 12 months. We need to immediately address the real problems caused by the PTL and not create a licensing structure based on perceived or hypothetical problems that are not the reality of what residents are doing. To address the board's consumer protection concerns, we suggest additional language that upon license renewal, postgraduate trainees shall provide documentation to the board that they have completed postgraduate training or shall provide to the board attestation from their program director that they are in good standing and making progress to complete their training. Requiring receipt of credit for 36 months of postgraduate training in order to retain and renew their license leaves us with the same problems we're seeing now with residents that have taken leave. We believe the approach we have presented is a better middle ground that addresses the unintended consequences of the postgraduate training license while ensuring consumer protection. Thank you.
Thank you for your public comment. Next up, we have Tracy Dominguez. Tracy, are you there?
Hold on.
We can hear you, Tracy.
Oh, you can hear me? Oh, okay. I'm sorry. I couldn't. Okay. Hi, I'm Tracy Dominguez. I am from Bakersfield. I do not support the confidential letter of advice. There is no room for confidentiality when it comes to the standard of care. It takes a miracle to move a complaint through your enforcement system. I have seen that you plan on using this confidential letter of advice for a simple departure. Your medical experts do issue a simple departure based on a complaint related to a patient's death. There is no room for confidential letter of advice to be used for a patient's death at all. The Sunset review process is supposed to help rebuild our trust. The use of a confidential letter of advice does not help rebuild the trust of the public. And using it based on a patient's death certainly does not build the public's trust in this board. You must assure that the confidential letter of advice is not used for quality of care or standard of care cases. This is dangerous. Please listen to us. Thank you.
Thank you for your public comment. Up next, we have Natalie Diaz. Natalie, are you there?
Hi, yes, can you hear me okay?
We can. Please go ahead.
Okay. Good evening. This is Natalie Diaz with the California Primary Care Association. CPCA is in strong support of AB 1156 by Assemblymember Weber, which aims to remedy the various implementation issues that have come up due to the PTL requirements that went into effect on January of 2020. Numerous government agencies and payers, including DHCS, recognize that the PTL as a restricted license, causing a myriad of issues for residents to deliver care during the COVID-19 pandemic and fill the provider shortage. We appreciate the efforts that have gone into addressing this issue from the medical board and the legislature to date, but the current language in SB 806 does not address the fact that the current limitations of the PTL as a restricted license and new licensing timelines, which residents did not experience prior to 2020. While we urge support of AB 1156 today, we also support efforts to include similar language in SB 806 as a vehicle to remedy these access to care concerns. As we continue to think this through, I also want to reiterate a clarification that was made in a previous comment. Allowing residents to obtain a physician's and surgeon's license does not mean that residents will be moonlighting without program director approval. Prior to the PTL implementation and even now, residents must obtain program director approval to moonlight. Thank you for your time.
Thank you for your public comment. Up next, we have Michelle Montserrat Ramos. Michelle, are you there?
Yes, I am. Good afternoon. My name is Michelle Montserrat Ramos, and I'm with Consumer Watchdog.
I understand Senator Roth and Sarah Mason may be working on the specifics of the confidential letter of advice, but on behalf of consumers, I need to state that we are against any type of confidential tool, and especially a confidential letter of advice that will provide less transparency for Californians. We have been told that it is meant to be used for minimal offenses, but how the legislation is written now, it leaves the board wide open to use these confidential letters for any action. It permits the executive director to issue a confidential letter to a doctor to resolve a complaint for an alleged violation of the Medical Practice Act. The way it is currently written, it could be issued for a death or anything. I understand the rulemaking process. I've been through it before and had to go to a legislator to make the board follow the law and place every aspect into regulations. Given that we have this confidential letter to work with, I need to make it clear that the legislation needs to be amended now to specify that the confidential letter of advice cannot be used for standard of care violations, except for those cases where the statute has run out. In your Sunset Review report, it states that you can use a confidential letter of advice to address a simple departure from the standard of care. If you want to address a simple departure, then seek legislation or make the changes necessary that will allow you to address a simple departure with a public form of discipline. We need to be very specific with the guidelines. They need to state that it cannot be used for quality of care violations, but it can be used for administrative violations such as a doctor refusing to release medical records within 15 days, a doctor not releasing medical records to another provider, a case running out its statute, a doctor not reporting a malpractice judgment or a conviction, or your doctors who grant mask exemptions without a physical exam. It should also be limited to the number of times you can issue a confidential letter of advice. It should be listed that you can only issue a confidential letter of advice once every 3 years. It should also not be purged after 3 years. It should be kept for the board's records to use as an overall portfolio of the doctor. The investigators, medical consultants, and medical experts need this information to get a better overall view of the fitness of the physician. It is no different than the physician having the full record of a patient to best assess the overall fitness of their patient. You don't purge a patient's medical record after 3 years. Give the investigators, the medical consultants, and the medical experts information they need to do their job. We need balance here. These complaints are not a mere piece of paper. We're talking about people's lives. Thank you.
Thank you for your public comment. Up next, we have Susan Lauren. Susan, are you there?
Yes, hello. I'm honored to follow these incredible women who are so intelligent and driven. I agree with Marion, Shonda, Michelle, and Tracy about the confidential letter of advice. It's good for doctors, but not good for patient safety. Since 2014, legislators who have bothered to talk to me about the process, and sometimes that goes on for many years, say that doctors' lobbies are too strong for them to stand up to. Electronic records must be co-authored by the patient. Until that happens, until records are co-authored and approved by patients, we will run into the same problems with fabricated records and ongoing patient harm. Victims like me aren't able to lawyer up, I found that a very offensive term, with effective lawyers because like in my case, I'm disabled and they left me destitute at risk for homelessness. So the whole process is based on wealth and privilege and not justice. This process is based on wealth and privilege and not justice. The whole process is abusive to victims and their loved ones. I asked to add back the majority of public members on the medical board because we need it for patient safety. But those members, public members, should be vetted for conflict of interest and not, for example, have a documentary sponsored by a medical device company that trivializes and misleads about elective cosmetic surgery when we have got an epidemic of people in California and around the world being harmed by this. When the medical board started, there wasn't cosmetic surgery and it's not able to handle what's going on and you're not dealing with it effectively. Since you let someone assault me, do this to my body while I was unconscious and you did nothing. Thank you for your time.
Thank you for your public comment. Up next, we have Christina Hildebrand. Christina, are you there?
I am Christina Hildebrand, a Voice for Choice advocacy. We educate and advocate for informed choice and transparency of what goes into your body. And along with that, with transparency along those lines, again, we agree with what previous speakers have said regarding the confidential letter of advice. You know, this board is having issues with trust and transparency. And so to take that away from the consumer is really concerning. I think the other piece is that I'm really concerned by the words of, I think it was Mr. Prasifka that said, you know, you get to decide what are, you know, sort of basically the important cases and not the important cases. And I think we have a serious issue in that to begin with. You know, the cases that, as I said at the beginning in my very first public comment, the cases that are being chosen are cases that you want to make an example of, rather than the doctors that are doing harm. I think we hear that over and over at every medical board meeting, at every public advocate meeting. So to me, the fact that the executive director, who I think probably has the least trust, you know, above all board members, has the least trust, the fact that that executive director is going to be able to decide who gets the confidential letter and who doesn't, and which cases, you know, are basically covered up, you know, is extremely concerning. So I would ask that you do not go down that route. I think it is a very, you know, if you want less trust in the medical board, go right for it. But I think, you know, I'm hoping that some of you are saying, you know, that you are trying to build that trust. This will not build trust. Thank you very much.
Thank you for your public comment. Up next, we have Dennis Cuevas Romero. Dennis, are you there?
Yes, I am. Thank you. Dennis Cuevas Romero with the California Medical Association. CMA remains opposed unless amended to SB 806 due to the unresolved issues related to the PTL. A robust coalition continues to ask the legislature and the board to consider language from AB 1156 or language substantially similar to be placed into SB 806. The coalition has provided to the bill's author, the relevant committee staff, and the medical board staff language that we believe will resolve the many issues, maintain consumer protection, and honors a proposed solution offered by Senator Roth. We remain willing to engage collaboratively and to resolve this issue before the end of this year's legislative session. Finally, CMA wants to reiterate that it supports the enforcement monitor language and concept. We'd like to see more developed language on the independence piece of related to the appointee and more details about the scope of the enforcement monitor's work. Thank you very much.
Thank you for your public comment. Up next, we have Eric Andrews. Eric, are you there?
I'm here. Can you hear me?
We can. Please go ahead.
Oh my gosh, I'm so frustrated. Spectrum Internet went down right as TJ was doing such a good job standing up for patient safety a few agenda items back, and I wasn't able to call in and support him. I will do it tomorrow morning in opening comments, but it's very wrong that you've taken away the public's ability to call in by telephone. It prevents some people from participating at all, and I think that goes against the open meeting laws. First, my usual disclaimer that the CMA represents less than 1/3 of California doctors and does not speak for the majority of doctors in this state. That needs to be remembered at all times. They are a union for doctors out to protect doctors, not patients. Let's say that Bill can issue these letters. Who is going to monitor him to make sure he's appropriately doing it right or at all? Who's going to monitor whether all of these causes in a case aren't bartered away, except for one, so that a letter can be sent instead just to save money? Remember, Bill's hell-bent on saving money to the detriment of patient safety. This will help him do it. And he's building into it that it's all going to be confidential, so no one can monitor him. That is highly suspect. Remember the reason the diversion program failed? Because it was confidential and bartering occurred. You're setting that up again with this letter. If the offenses are so benign, why does the letter have to be confidential? You're already bartering cases down to public reprimands, and this adds yet another way to not reprimand doctors properly. Bill's excuse is that all the boards all over the country are doing this, but study after study is showing how lame most of the country's boards are. So is that really something you should be boasting about, Bill? You're going to copy other boards that aren't even as good as California is supposedly is? You are supposed to be beefing up protection, not giving yourself a secret way to protect bad doctors. Shame on you, Bill Prasifka. Thank you.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Thanks, Sean. We're going to close that public comment period and bring it back to the board. I think that so I heard a few themes from the public comments and then from the previous board member comments in the discussion we had. I think that the operative question that we should be considering as we have this discussion is whether or not we want to change our current adopted position, which is support if amended. And Aaron can again walk us through what the positions were on these specific topics. One of the ones I heard was confidential letter of advice. On page 215 of our Sunset Report, that articulates our original position dating back to November 2020. That position now, of course, is informed by what we have in print for SB 806. And so I think we should address whether or not we want to change our board position as it was adopted. I think that we should address whether or not we want to change our adopted position with respect to the postgraduate training license. We heard some comments there. Those were the two ones where I really thought that there potentially could be a change in position. I want to, and Aaron, you can kind of help step through as well. Our current position with respect to fees and cost recovery, which we heard some comments about as well. I mean, we have been advocating strenuously for the full fee amount as well as for cost recovery. I didn't hear anything from the board members that would, or from the public that would lead me to believe we wanted to change that position unless we somehow wanted to increase our ask. But we have been advocating for that. That is part of our adopted position. I did hear from Ms. Lubiano about, whether or not we wanted to take a new position again with respect to our the term of the extension. Again, our adopted position is 4 years. I don't think we want to change that, notwithstanding that we don't think we're going to get it. And then the public member majority, I heard a comment along those lines too. Our adopted board position is in favor of the public member majority on the board. So again, if someone wants to propose we change our position, we can do that. But the two items I'd like us to tackle first are the confidential letter of advice and the postgraduate training license. And so I'd like us to think about it though through the lens of, do we want to change the position that we currently have? Aaron and Bill, I'm also open to any other suggestions, and if the board members think I missed a big issue, let's take it after we go through these two topics first.
Yeah, I think you've covered it, Ms. Lawson. I mean, I didn't hear comments saying that we should go back from 4 years, a 4-year extension,
Right.
or go back to some other position on our fees, or the composition of the board. So I think those three items I think are probably maybe in one bucket of maintain is kind of what I'm hearing so far. And then I agree with you. Lots of comments and on confidential letter of advice. Certainly the PTL is one of the biggest, if not the largest unresolved issue that the bill is kind of facing right now. And then I don't know if there's any other items that board members have in addition to that, things that they wish to see differently. And then did you have a question about our position in terms of?
Yeah, I think let's take these two items. So let's take the confidential letter of advice, and then we'll take the postgraduate training license issues sequentially. And I think it would be helpful if, so let's start with the confidential letter of advice. I've pulled back up our sunset report, which it actually is on page
217.
217. 215 is the section where it started, so I misspoke a minute ago. It's
And that's
217.
linked in the analysis. The Bill's analysis has a link there if members wish to, pull that up as well.
But if we could just step through what our position has been and whether or not we believe the current version of SB 806 is consistent with that position, and frankly, if based on the additional information we have had this evening or additional thought that people have put into it as this has worked its way through the process, whether we want to change our position. I think that's the question I'd like, to try to achieve consensus around.
Can I speak?
Christina, Dr.
Yes.
Oh, I'm sorry. Asif, go ahead.
Sorry. So I just wanted to get more attention on this confidential letter. I know there is a lot of resentment on that. What was the idea behind it? And is it really necessary to have a confidential? Because this is only going to increase the mistrust and doubts public has about board and board functioning. So if there is not any compelling reason to keep it, I would bring it to debate, and I think we should consider it to making it more transparent and more open, so it's not just a confidential that there is a conspiracy going on between us and helping doctors. I think that is definitely needs to be addressed. Every single person had a comment on that, and a very strong comment.
Ms. Howard, may I invite Mr. Prasifka to reiterate the merits of having that confidential letter in our tool chest? It doesn't have to be used with great frequency, but Bill, could you highlight for us the advantage of having it available?
Yes, I would welcome an opportunity to do that. I think that
could you also add, as the chair alluded to, the initial intent versus what it is now?
Okay, well, no, I don't think there's much change there. It really is what have always tried to emphasize is that when you look at regulation and the management of a complaint system, is that it is not very accurate to simply look at it only from an end product disciplinary point of view. In that, as we've seen with certain reports, they've said, well, if a medical board, if they're revoking twice as many licenses, if they're issuing more public reprimands, if they're doing more suspensions, if they're imposing more public sanctions, they're doing a better job than a body has less sanctioning. Certainly sanctioning is very important, but it is not the only thing. There's a whole area of what is called upstream regulation, which basically you look and you try to identify problems before it results in a fitness to practice issue. You look at areas of education, of continuing medical education. You look at the culture of institutions. You look at reflective practice and peer review. And what you're trying to do is to create a culture of open disclosure, continuous improvement, not one of fear and concealment. So it is very important in regulation to look at the complete spectrum of different methods, of different incentives that can be given to licensees. And that really is where the confidential letter of advice falls in. It is simply one tool. If you look at sanctioning, if you go from the least severe to the most severe, it goes from confidential letter of advice to public reprimand to probation with conditions to suspension to revocation. What you're trying to do with the confidential letter of advice is to catch problems before they get to fitness to practice. You want to create a system whereby the priority is one of remediation, perhaps simple remediation that can be done quickly and cost effectively. We're not talking about fitness to practice cases. We are not talking about cases where there is a dispute about the facts. It's not we're saying, well, gee, this is really complicated. It would take us a year to investigate. No, that's not what the confidential letter of advice is. And it's confidential because you're trying to take the angst out of the system, the element of fear. I reject the idea fundamentally that the only effective sanction must be a public reprimand. Public reprimands, public sanctions are extremely important. They are absolutely necessary, but they are not appropriate in each and every case. And if we have a system in the state of California that every time a doctor does anything out of line, they will be publicly humiliated, that is not going to serve patient care. That is going to create a culture of fear and concealment, not one of open disclosure and continuous improvements. Now, I fully accept the position that the letter of advice could be misused. As I have said, as every potential sanction could be misused, but appropriately used in certain circumstances, it is a very valuable item. And I have to say, the fact that California does not have it means that we are falling behind international best practice. Now, if I could say one point of view, one point that I would like to comment on, it's something that Marion Hollingsworth made, which was a very valuable point. And she said, well, you have these confidential letters. How can there be any transparency? And that is an extremely good point. There's a body called the Professional Standards Authority in the UK that has been looking at these things, and they advocate more informal resolution. But you're right, there has to be some transparency, some accountability. So therefore, there should be certain reporting on this where the doctors are anonymized, the data is aggregated, but it can give some public information about where these letters are being used. These are things which should be looked at. But again, I go back to the simple point. Do we really want to live in a society where every time that there is a simple departure from the standard of care, that there is a public reprimand? Does that serve patient safety interests? And I think if you look at the movement of medical boards all over the world, the answer there is no. And California should not fall behind.
I appreciate having that in our armamentarium. Although it would be a confidential letter, what would be the level of board oversight? Would the board be able to see letters in confidence, or is it also hidden from the board?
Well, no, I have absolutely no desire to hide anything from the board, nor do I propose that this is something which is in my sole ambit. I mean, everything that I believe in terms of regulation, is that these are not my own individual decisions, but we have an established methodology which is shared throughout the organization so that these letters will be issued in a consistent manner. And I would welcome any type of system where the board would have oversight of this.
So, Dr. Krause, I'd like to just interject because we could spend all night talking about the details of a program, right? Now, if we have specific items that we would like the author of SB 806 to include in the legislation so that it provides some direction to us as a medical board as to what should ultimately end up in the regulation, or provides, some guardrails, if you will, as to, where we can go with that. I think that would be a productive conversation, because right now the way that SB 806 is set up, it establishes the possibility of this as an enforcement tool, if you will, and then says the board has to go develop all the regulations if it chooses to, enact this program as one of the medical board. And so I just worry if we keep getting caught up in these details, we're not actually addressing the legislative issue right now, which is, we told the legislature throughout this entire process that we wanted this tool. The legislature now has put into the legislation the tool that we asked them to put in. And so if we want to tell them to take it out, that's what I think we need to have on the table. Or if we want to tell them that, thank you for putting the tool in, we need some guardrails on ourselves for this. Tell us that it can only be for this type of violation or what have you. I think that's where we should focus our conversation.
I agree. My concern was I saw a conversation moving toward asking for it to be removed. And I think it's a valuable tool that should be retained.
Right. Well, let's focus on that then. I mean, if that's a position, I mean, that's what our board position is currently. I guess I'd like to hear from people who would like to change our board position, right?
I would like to move away from that because it's becoming pretty obvious that the public don't want it, that this board's culture doesn't even suit Bill's own definition of upstream regulation, because he talks that there has to be this culture. This culture in this board right now is that it is systematically favoring doctors already. So the people's perception is going to be, this is just going to be more of the same. And the fear that he wants to take out of the system, that this letter would take out of the system, is the fear for doctors. But it instills more fear into the public, because every time now when a case goes before that, I file a complaint and they write a letter, I'm going to be afraid, they just write letters. So we must kind of get it right that we are here to protect the public. We are here to listen to the public. The public says no. The public are in fear right now at the letter even being mentioned. So I think that if we listen to the public, remove this condition, we start rebuilding that trust. And I think that is more important than anything else. We have been doing this job and we'll get better at this.
Madam Chair, I would give a counterpoint.
Please.
When Dr. Granado, so when this was brought up, couple reasons why I was pretty excited to see is that number one is that it prevents somebody who could have made a simple mistake going into hurting somebody for the next 3 years. That's what it's taking us to suspend or to put him on probation, revoke and put him on probation. It's that long. Number two, our staff can concentrate on more serious offenses which has quality of care issues. So this is why when Mr. Prasifka brought this up, where all the boards in the entire industrial world are going, I thought it was a bright idea. That is, we got some bright idea to really make a difference compared to dragging the investigations for 3 or 4 years, where some bad doctors continue to hurt people. It made no sense to me. That's why I support.
Can I chime in? Being new to the board, and everyone's talking, it's very important, and people are talking about issues of trust and transparency. I didn't know CMA had our medical board, CMB, had a trust issue till I got on the board. And then hearing from other board members, hearing from the public speakers. But having served for about 2 months now and having served on the first panel, there's a big difference between perception versus reality. The perception of the lack of trust versus the reality, because I think, Madam Chair, you talked about it best about how we are limited in scope. I mean, there's a lot of speakers, public comment folks who are saying that we should change X, do A, B, or C, or change X, Y, or Z. But the reality is that's what the legislature does. we have to work within the means and the boundaries that we have. And when I saw the first cases, the instructions I got was I could only make the decision on the information that's in front of me. This is not a medical board thing. This is a legal matter. So, I mean, it shows that you could only do certain things. And of course, there's so many parameters put on us. So, you know, it's really unfortunate. There's some mistrust issues. But one other thing I learned in my short time here on the board is there's a huge backlog. You know, and and not only that, I think Dr. Ganadev just said it well, where we're spending, the staff as well as the board is spending so much time on minor issues when the bigger issues are just being stuck for several years. So when I hear about this confidential letter of advice, I think you answer my question. I was going to say, what are the parameters? And it looks like there are none. But I think the first mistake was maybe the name confidential is really scaring people. What I hear this is actually like a ministerial decision where staff could make some of the decision for the lighter cases. So, you know, I like to learn more about this idea, and based on what Dr. Ganadev said and Dr. Kraus says, I think this could be a tool that'll help make it more efficient for us to make decisions, move through the backlog of cases, address the more important cases that need to be addressed. But maybe we could really hone in and define what cases could actually be considered by this ministerial decision so that the public could feel a little bit more at ease so that we can be more efficient. Because, you know, it's the chicken or the egg, where we're complaining on one hand that we don't have enough money and enough staff power to go through all these cases, and the cases are just are stockpiling up. Then when the staff comes up with an idea to resolve some of these very minor cases, where we know, even if the board decides on it, because of the conditions, they're only going to get probation. You know, I think it's very important that we take this into serious consideration and see if we could try to thread a needle here and try to get the public's trust and explain to the public what this is, because this is not a confidential letter. From what I'm hearing from our executive director, this is a ministerial decision that for some cases he and the staff could make and maybe bring it to the board for review, right? Or I don't know, it seems like we can make up these rules right now, and it's hard to make it up in the next 30 minutes, but I see some positive benefits.
So Mr. Rue, along those lines, I mean, since we are working with some draft legislative language, right, which has these 4 components to it. One, you know, talks about the idea and having this as a potential tool that we could delegate to the executive director, this confidential letter of advice. And then there's a couple other provisions, and then the requirement that we actually adopt regulations to implement this program. I guess I would ask the board, perhaps, again, just trying to frame and move this discussion along, if we modified our position from the one we have on the table, the one that we have adopted already dating back to November, such that this confidential letter of advice would only be used for minor violations. I mean, would that help move in the right direction for the board? I mean, I have a couple of board members already saying they want to keep our position exactly as it is, but Mr. Rue, would that address yours? And then again, we would be subject to developing and then adopting regulations with the legislature having provided us that direction that it is only to be used for minor violations.
I would even go so much further to say minor violations that does not include death, that does not, I don't know what the severe cases are, but major drug addiction, I don't know, some major, point out many of the major things that to exclude off the bat.
So Alejandro, can I jump in?
Please.
I apologize for being off video. I have very bad service right now, but I did want to weigh in on this because I hear the previous speaker was saying about the word confidential, and obviously transparency is the biggest goal for us right now, and that feels like we're moving in the wrong direction. I also had a reaction when I first read that. I think, and I agree with the idea that we move towards making it crystal clear if we are going to support this letter, to amend it to be very clear that it does not include standard of care, like it was mentioned by a lot of the public advocates. I agree. I think just saying it shouldn't include minor infractions, I think that's too vague. I think we need to do everything we can in our language to assuage, to let the public know that this is not something where they're going to find cases embroiled that weren't meant to be there. So the more clear we can be here, that would make me more comfortable, because otherwise I feel very uncomfortable with it as it's written.
Okay.
I just want to find something that is related to this that will clarify this pretty interestingly. Because we're listening to people's lived experience, not perception about trust and mistrust and all of that. You either trust somebody because of your experience that you've had with them, or you don't trust them because of your experience that you've had with them. This medical board right now, we oversee, we only discipline about 385 cases, and we dismiss the rest of it, right? So I'm asking the question, when this letter comes out, does this tap into the 385 cases? Does this go into the cases that has been dismissed because we didn't have a method for what, we haven't had a vehicle to write a letter to them for the ones that we did dismiss? Because the concerns that the public have, that I'm hearing, is that they are afraid that we're going to give the executive director all this power. He's not, the executive director is going to have no oversight. We as the board will never see it, so we can't manage that process. So if we want to include this, we need to go list by list to address each of those concerns and make sure that there's no loopholes.
Okay.
That's the only way anybody's going to accept this.
All right, but so let me
quick
reframe
comment.
this. Wait, I got a timeout for the board. This was our idea, right? So this is in our sunset report. I need to know from the board right now, and I guess I need to do kind of a check,
Right.
whether we want to change our position, right? And I'm hearing a couple people say we want to change our position, but let's figure that out before we get into the details of what that changed position looks like, I guess, because well, based on where we're headed tonight, we're going to be here for several more hours if we try to develop that changed position. And I'd like a read on that, kind of at the outset. I've got a couple of people who've weighed in on both sides of it.
Madam Chair, I hate to speak again, but when legislature is passed, it's our responsibility to see what exactly it looks like, what offenses we can go. So that's why it's in our ballpark. So I was just wondering why we are even trying to come up. That rulemaking might take several hours because you come up with all those things. It's the board's responsibility. Board can tell, okay, board is everything has to go through the board. These are the ones we can do. So staff is not going to decide what they're going to do. It is the board. So that's why I'm not sure why we need to change the person. That's my opinion.
Yeah, can I mean, again, to try to move this along, could I ask someone to make a motion on one side of this to say we should keep the position or we should change it? So we at least understand.
I move retention of the position on the confidential letter.
I second.
All right, so we have a motion and a second. Do we want to have some further discussion on that? Whether we keep our position as it's articulated in the board sunset report on page 217, or whether we change that based on knowing the way that the legislature has put that into this legislative vehicle. Dr. Mahmood.
This is Alejandra. I guess I'm confused if someone could clarify if the intent is not to use this letter in any way that doesn't affect anything but the most minor administrative disciplinary matters, then what is the problem with adjusting the language to make that clear so that everyone is everyone's on the same page? I guess I don't understand what is the problem with adjusting that language, and then we can keep our position as far as wanting and requesting the letters. That seems like a pretty simple
change that will make everyone comfortable and make it very clear that this is not meant to be abused in any way.
Yeah, I think that Ms. Campoverde, from my perspective, that's why I was going in the direction of, could we request the legislature to add the word minor, for example, into the legislation? I mean, my concern is that in order for us to develop that list, and for example, I mean, when we tried to develop the list and have a conversation around, you know, when physicians would need to notify their patients if they were on probation or not, that's probably several hour and or maybe even over the course of several years discussion about exactly what goes into that, which is why the legislature has proposed in SB 806 to have a rulemaking, right, on exactly that point, so we can get into the details of what we would be comfortable with and what we would not be comfortable with. And so that's where, if we could provide some direction to the legislature as to what would go into the statute to provide the statutory guardrails, so that when we have the rulemaking discussion, it would limit us. I mean, that's where I think it would be useful, right? So that's why I said, could we use the word minor? But if we get into not standard of care or, you know, these very specific details, unfortunately, we're not going to be able to resolve that tonight, because we're just not going to be able to keep our staff on this line, and we're not going to be able to get to any of our other business.
So, Madam Chair, if the maker of the motion can change, amend the motion to adding minor, the seconding person who is me, I'm fine with it, because we can't define all those things right now, but I don't have any problem putting a minor, because I am expecting the entire, when we make the rulemaking process, we'll be looking at this thing, so I'm okay with it.
I have a little comment, Madam
I'm
Chair.
fine with that
I
as
have
well.
a little comment. On this minor thing, we need to reassure public fully that minor will be taken into trust, and they will be taken into confidence that minor is minor. And I think we know that a couple of speakers from public came up, and they brought up some very explicit cases which could be minor and which could be considered on this letter, and I think public will be all right with that. But yet the discussion on minor should happen, and we should be very particular and very specific on those minor things. And I think if that minor is included and it's agreed, then I think this should move forward.
I agree.
I think listening to the public would be the best guidance to build this trust again. We're not listening right now. And what I'm saying is that the public, new information, the public has said that they are uncomfortable with this, right? They feel that it's primarily a protecting the doctors kind of initiative. And it's important to take that note in light of the board's culture and their lived experiences, and to want to adjust this, because this is the way it goes. You see, we don't listen tonight. We just do what we usually do. We get a vote and we move on. And then it's again, yeah, they just did exactly what they wanted to do, right? Where they ignored us. And I mean, that's kind of how we operate. And I'm just saying, take a pause. We have things in place. I don't know where the new cases are going to go get letters from when we have such a low rate of issuing the disciplining doctors anyway. So on a bigger picture, I don't see what it is that we're trying to, what we're solving for when we're dismissing these cases anyway.
So, Mr. Watkins, I understand your position is to oppose the motion that's on the table right now.
Madam Chair, I think I probably, parliamentary procedures, I probably have to make the amendment. If I'd like to make the friendly amendment to add the word minor. Maybe it's too early for me on this board, but I'm going to trust the board that we will later on, because I think your point is well taken. While I would love to define it even further, that could take us several hours. So I'd like to make a friendly amendment to the motion maker to add the word minor, with the trust that we as a board will have a lot more guardrails later on.
And let me just.
I would say adding the minor, and we should add also that just not the board, experts and the public opinion should be respected in that minor. That public opinion should definitely be counted in that minor before we make the decision and a later discussion. It's not a scope for tonight. but public should be reassured in that minor thing that their input will be taken and respected.
Okay. So what I'm hearing
Lori here.
Go for it.
Oh, sorry. I just wanted to build on Mr. Rue's point and go further. And besides minor, actually say that these letters shall not be used where there is a concern related to the licensee's fitness to practice. Thank you.
All right, so I'm understanding, well, I guess I would ask whether or not the maker of the motion and the seconder want to accept both amendments. I heard they wanted to accept the idea that we would ask the legislature to amend SB 806 to provide that administrative confidential letters of advice are only available for minor violations of this chapter, which is the way the statute is written. And then what I'm hearing Ms. Lubiano ask for is additional language that would say minor violations of this chapter that are not related to fitness to practice or don't implicate fitness to practice issues. And we could.
As a seconding person, I'm okay with it. That's what I'm taking it for granted. So, David, we already made the minor amendment before. So this is the second one Ms. Lubiano is asking. I'm fine, Howard, if he's okay.
Yes, accepted.
All right, so we're making progress.
We can finish by 8 p.m. Go ahead.
I know. Mr. Watkins, can I just check you that you're still a no, even with that? You're still opposed, even with those changes?
Yes, because it's not what the public wants.
Fair enough.
We're not including public, yes.
I'm sorry?
Yeah, we are not respecting still in the thing, minor thing we'll be deciding. We need to have public reassurance to that because the major opposition is coming from public and we are changing still with our mind, creating that mistrust which is already there that, okay, we don't care about public. We are going to make, okay, this way will be more acceptable. Let's do this way. So as long as we don't include whatever the minor will be, not we are deciding with complete assurance of public, then it's not going to work. I think I am not happy with that.
Okay, I'm not sure how we can go so far when what we're doing is commenting on legislation. So I'm not sure how we can go so far to add those assurances beyond the fact that the legislation itself requires a robust process, right, for the rulemaking. I mean, I will say from my perspective, and the way that I think about these matters is what's best for 39 million plus Californians, right? Is it, would it be helpful or useful for us to have this additional tool in our quiver, potentially, which is all this legislation is setting up. This legislation isn't saying we have to have this tool. It isn't saying it has to be applied in a particular way. It's saying Medical Board of California will let you have this additional tool if once you go through the rulemaking process, you determine that that's a valuable process and that it could enhance the protection of the public, enhance health quality in California, then we'll adopt that rule and then we'll proceed through the rulemaking and get that robust comment. But I wouldn't want, based on what I've heard, for all of California to limit the tools in our quiver going forward. So that's where my head is at with this. I'm okay with us putting some guardrails on that, right? Saying we don't want this to apply, outside of the context of minor violations, but I want us to be mindful of the process we're in, right? We're commenting on a piece of legislation. We're not designing this program in this meeting.
So, Madam President, what I thought I heard the motion would be to amend SB 806 to limit the confidential letter of advice to minor violations that are unrelated to fitness to practice.
That's what I hear.
I think that's fair. Okay, great.
All right. Can we, should we move to a vote on that? Do we want to wait and take everything all together, or should we vote on that piece? Ms. Webb, I guess I'd like your advice on that.
I suggest voting on that piece. Otherwise, you may muddy it.
All right, we'll
Yeah.
vote on that piece.
Okay.
So we'll move to a roll call vote on that motion, which I think Aaron completely articulated.
Shall I repeat?
I don't think that's necessary.
Great.
No, thank you, Aaron.
All right. So it is, I will
We're
say
good.
it's a modification of our position, right? But it's still in support of the support if amended overall position on the legislation.
Yeah, so if we, yeah, so if this would fit in, if, you know, the board's going to continue with the support if amended, which we can, I guess, get to that in a moment, but this would fit it. This would be one piece of that to say, hey, we support if amend, and we like you to do this to the confidential letter of advice language. Right. So
okay,
with that, I think Valerie's ready to call the roll.
Got it.
Campoverde.
And Ms. Campoverde may have dropped off. She notified me earlier that she had a hard stop. She was trying to stay on as long as possible, but it looks like we might have she might have dropped off now.
Thank you. Dr. Gonadev?
Yes.
Dr. Hawkins?
Yes.
Dr. Helzer?
Yes.
Dr. Kraus?
Yes.
Ms. Lawson?
Yes.
Ms. Lubiano?
Yes.
Dr. Mahmood?
No.
Mr. Rue?
Yes.
Mr. Watkins?
No.
7-2.
All right, so that motion carries. Moving on to the
PTL?
Easier item now.
Yeah.
Sorry, I shouldn't be joking, but PTL issues. Aaron, do you want to, I guess, you know, reset us as to what our current position related to PTL is, and maybe step us through where the legislation is currently at, and then we can have a conversation about it.
Yeah, happy to. Let me pull that up. So right now, the position of the board has not substantively changed, I think, since the board, you know, the prior board, you know, 3-4 years ago, instituted the 36-month postgraduate training requirement, along with the creation of the PTL as a component of that. So that is the board's position. The board has made, you know, statements in the past at previous meetings that, you know, expressions of desire to address the issues that you've heard articulated this evening from the physician community. But that is the board's position, that 36 months of postgraduate training is appropriate in order to adequately protect consumers. Of course, there's more to it than that. There's some additional history beyond, you know, associated with that. At the same time, the board changed the way that it approved medical schools. So that was one of the other components that was, you know, part and parcel to that change that occurred, you know, 4 years ago during the board's prior sunset.
Are there any questions from the board members about, you know, sort of our current position or where we're at? I guess I just want to make sure we're all working with the same set of information, given that we have new board members and this is a complicated issue.
Yeah. So is the current board stance that you need 36 months continuous to get the PTL?
You need 36 months of approved postgraduate training. 24 of those months must be continuous in the same program for a total of 36 months. And once you do that, then that's a key eligibility requirement to receive your physician and surgeon license.
Yeah, your full license. So what we did several years ago, or a couple years back, was to change the scheme such that this new postgraduate training license is issued to those in those postgraduate training programs, right? And then you need to meet a certain threshold, and then you're issued your full physician and surgeons.
And if it's helpful, Madam President, maybe just to go back in time a little bit. So 4 years ago, before the PTL and the 36-month requirement was instituted, the law at the time was that you could, if you graduated from a U.S. or Canadian medical school, you could be eligible for licensure in as little as 12 months of postgraduate training. It was 24 months if you went to a medical school anywhere else in the world. And the board, in addition, there was a certain amount of requirements that certain international medical schools may had to meet that required certain amount of review from board staff, depending upon the various circumstances. The board believed, and the legislature agreed, that this 12 and 24 month variability of requirement was inappropriate, and that rather what was appropriate was for an applicant to complete residency. And since 3 years or 36 months was the shortest amount of time for a residency program, that was where the board settled upon, which was the appropriate amount of training. At the same time, the board took a different view with regard to medical school requirements. And so now there are more medical schools that are approved as a result of the law change that occurred, because the board really was resting upon that approved 36 months of postgraduate training. So that's just a little bit more context. And so the physician community, they are arguing that we should maintain the PTL but move back to the timeframes that I just described: 12 months for U.S. or Canadian medical school graduates, 24 months for everybody else. That's contrary to where the board is, has been on these issues. I hope that's helpful as well.
So real quick, when you say physician community, that included the speakers, and as well as, I'm looking at the last page here, opposition, Altamed, Community Clinic Association of LA County, the California Physicians, California Academy of Family Physicians, all want the 12 months, 14 months.
I can't speak to every single one of those groups, because different groups might have a little bit different nuanced opinions on the Sunset Bill, but the individuals that you did hear call in earlier, the California Medical Association, the California Primary Care Association, which represents federally qualified healthcare centers and rural healthcare centers where there's a lot of primary care being delivered in the state, as well as the family physicians. Those are the three organizations that I think we heard from tonight, articulating that viewpoint that I just mentioned, Mr. Rue.
Thank you.
You're welcome.
Dr. Hawkins, I have a motion.
Please.
Motion to maintain our position on the PTL without change.
Thank you. There's a second for that motion?
Second.
Thank you, Dr. Kraus.
Madam Chair, I'll give I know I was on the losing side on this one, but I'll give it anyway. So I am in the teaching institution. I've been there doing this for 40 years. We train doctors to go anywhere in the state of California mostly, and some in the other states, but mostly in the state of California. So there is a huge problem with 3-year where you have to finish 3 years before you get a license. That's on the license side. So it takes some time. I think I heard that maybe once it took so little time to get the full license after it finished. But if you apply to privileges in any hospital, it takes anywhere from 2 to 6 months before you get privileges, and you can't apply without a full license. So that's the major part. And some of these young people, mostly minorities with a lot of loans, are struggling to get somewhere to be employed. That's why the primary care associations are supporting, where you give them a PTL in 12 months or 24 months, and then, you give them a license, but if they leave the program, they don't have a license anymore. They have to finish 36 months before they get unrestricted license. I think it is the better option to do for having enough physicians in California. Otherwise, what is there for my surgery resident or our family medicine resident or internal medicine resident in my when Nevada, Arizona, or somewhere else, they have a license and they can join July 1 or July 5th, after July 4th, and have a job compared to California, it takes 2 to 6 months. It makes no sense. That's the big one. The moonlighting is a issue for rural clinics or some urgent care centers, but the biggest one is trying to employ these docs and keep them in California when it costs so much money for us to train these people. I understand some of the other people feel, but because I've been in the training settings for so long, I know it. That's why University of California Systems also supports that amendment.
Thank you.
I have a question.
Are we able to get ahead of the application process for licensure and staff privileges such that on the day of completion of residency, the privileges are there?
That was my question. The day of electronics, we can't get ahead of that. Yeah, same thing.
I think Aaron can answer the licensure, but I can tell you hospital privileges, they need so many direct communication from wherever you were there, and the background checks and so many things. So I haven't seen I don't know, maybe Dr. Hessler can tell me if Kaiser moves faster, but usually minimum 2 months, and many community hospital takes 4 to 6 months to get hospital privileges. So if you want to be a hospitalist, or you want to be a primary care doctor who has privileges to admit patients to the hospital, you can't get it. And if you're a surgeon, forget it.
It's Jim Hauser. Credentialing is still a very slow process out in the community, in my experience.
So I guess I'm not, Dr. Gnanadev, you articulated that as a huge problem. What's the number of people, of physicians that have their PTL that we're waiting for them to have their full license after that 36 months that is affected on a yearly basis? Are we talking 50,000? Are we talking 50?
No, I think we graduate, if I recall, I don't have the right number, but California graduates about 1,000 plus doctors from the residency programs.
Right.
Almost all of them will have the same problem, except if they just want, even if they want to go and open up a shop, they might have a problem because they're not licensed. So all of them will have the same problem if they stay in California.
Here's what I'm not understanding, because that problem is going to exist under the proposal that the various physician groups have, because under that proposal, there still won't be a full license, because there still will need to be this, check. It won't, essentially renew. So you're still going to be in this limbo position until 36 months, unless we truly roll back the length of training requirement, which I'll just put on the table. I don't support us doing that. I don't think it makes a whole lot of sense for us to say, we think that it's in the best interest of California consumers and patients to have our physicians have 36 months of training, and then 4 years later say, whoops, you're right, 12's just fine, right? When medical boards across the country are moving in the direction of longer periods of time for training. So I'd like to solve for administrative problems when we can, but I'm not comfortable rolling back training requirements when we've already articulated that we think a certain amount of time is really important for consumer protection.
So I'm not even bringing that up about rolling back, but I brought it up last time that if you take, instead of 36 months, if you take 13 months, it will solve so many problems because there is no way somebody is going to be fired in a primary care program after 2.5 years after they're in training because they have only 6 months left. So if you get that license, then they can actually get privileges in a hospital July 1st. So that would be a much better solution, but the rest of the board was not even willing to listen to me, so I didn't bring it back this time. So I think it is, in the end, my goal is, remember that as a surgeon, there is no conflict of interest for me because surgical training is 5 years. All my people have license. I'm worried about primary care docs, internal medicine, family medicine. These are the two, and pediatrics. These are the three. And I hear from them all the time. So that's why I think we need to solve, but you asked about, so if the way it is being structured is that this they have a license which is a little different than PTO when they are after 12 or 24 months. But if they don't finish 36 months, that license doesn't stay, it goes away. So that means that they can apply to a job, or they can apply for privileges with the program director saying that this person is going to finish 36 months and will get full license. So that's the difference with the current, I think, 806, and well, there is another assembly bill, but that's coming tomorrow. So even in my mind, the better solution is cut the training requirement down to 30 months.
All right. So we've got Dr. Hawkins' motion on the table. Dr. Kraus seconded.
So I do have a clarifying question about the motion, Madam President, when at the right time.
Please go ahead.
So, Dr. Hawkins, and I think this maybe speaks to one of the points that maybe Dr. Gonadev was making, is that with regard to the 36 months, I guess when in your motion, Dr. Hawkins, are you saying that is your motion to reject the approach in the bill right now that has this intent language that is being worked on right now to kind of flush out that would have you get your license after 12 months, maybe 24 months if you go to an international medical school, but it's contingent upon you continuing? I guess I'm hoping you can kind of clarify, because I want to make sure I'm able to articulate, if this motion is approved, what you mean by that, Dr. Hawkins.
So there'd be would not accept 12 and 24 months, would not go back to that period of time or that approach, if you're asking that. I really believe that the PTL should be as it is. Dr. Ganadev has reminded us of some important things. I don't think that the moonlighting is a critical, but if in fact the hospital association cannot make this happen, then I'm concerned about primary care doctors not being able to get a license to admit patients, get approved to admit patients to hospitals. I mean, I don't know, does that help you answer your question?
Yeah, so maybe another way of framing that is that your viewpoint that the licensing structure as it exists right now is essentially appropriate.
Yes.
Okay, that's helpful. Thank you.
Oh, could I ask a quick clarifying question too? Aaron, wasn't there, when we brought this up before, wasn't there a clause or an exception for the 24 months continuous part where if it was maternity leave or some other special circumstance that with their advisor or something could write a test?
Yeah, so there is language in the bill, Mr. Rue, that speaks to so right now, under current law, you need to have essentially 36 calendar months. I'm simplifying. But where the bill is going to right now is that it would move it from an amount of time versus a credit. So the issue that is attempting to resolve pertains to folks who take leaves of absence for all the expected reasons, right? And because of that leave of absence, they don't have 36 months of
right. So
but they are still meeting the terms of their program. And
so that exception is going to be in there. That's all I care about. That exception is going to be in there, right?
That's in the bill right now.
Okay.
And sorry, correct me if I'm wrong, Carrie, but the board application review and special programs committee has adopted a policy that I think has been ratified by the board, if I'm remembering what has happened correctly over the summer, that's how we interpret that provision.
Yes.
Okay. So, I mean, that's already the board's policy, right? That it's not, it's the credit for that 36 months. If the program director certifies that you've completed the program and that it was a 36-month program, not might have been on leave.
Yes, and this would, I don't mean to speak over you, this would codify that. The other portion of the bill on the PTL pertains to signing forms. So it clarifies any forms that a physician and surgeon can sign, that a PTL holder, can sign. I think that might be it in terms of what is in the bill currently. Oh, excuse me. The bill also currently grants authority to the board to, in its discretion, upon review of supporting documentation, it reads, the board will have discretion to grant a physician and surgeon's license to an applicant who demonstrates substantial compliance with this section. To me, those are things that are kind of, getting back to Dr. Hawkins' motion, these are somewhat, these are important, but these are not kind of major structural issues with how the licensing structure works right now. So I didn't hear Dr. Hawkins' motion to be a rejection of those things that I just articulated, but rather to say that the essential current structure that we have right now for the PTL and 36 months of training, that is his motion, that the board should that the legislation should be reflected and maintained that structure.
Okay. My motion would include those.
I'd like to revisit Dr. Gananadev's concerns, because if we are turning out 1,000 primary care physicians from California residency programs who on July 1st can't have hospital privileges and therefore seek employment in other states, then ultimately we will end up with a manpower problem. So is there any way that we could smooth that transition for those 3-year residency completers to not have to wait 2 or 3 months to have hospital privileges?
Are
I-
we actually turning out 1,000 primary care physicians? No, I think
what-
you said
what-
all physicians. Yeah.
1,000 physicians out of all the residencies.
Right.
Right.
I mean, my concern is that this is a problem that should be solved by a process improvement or, some type of administrative improvement, not by legislation that rolls back how long we expect our physicians and surgeons to be trained for.
I hope that turns out to be the case.
Can I don't want to make it more complicated, but if I could suggest something, I sympathize with Dr. Ganadev. I served on the Health Professions Education Foundation before as well, that commission. I don't know if you want to, if this will make it worse or if it will cause a legal problem, but can you do 30 months for those primary care physicians serving in underserved or rural areas? Because those are the areas that are really struggling to have physicians work there. So it's kind of an incentivizing, but I don't know if that opens up another can of worms.
David, I brought it up and I was shot down last time, but I think it solves so many problems. It still doesn't solve some of the complaints the Primary Care Association have, but it solves a lot of problems with physicians finishing and staying in California. That's my biggest concern as I said, it doesn't affect surgeons because we got 5-year program, it doesn't matter. But internal medicine, family medicine, pediatrics are 3-year programs. And I hate to lose these kids when they're finishing. And by CMS account, it costs $1 million plus to train a doctor, not including their own loans. That is the money CMS dishes out for the GME programs and so many other issues. So why are we doing this when we have a serious access problems? It makes no sense to me, but that's my personal opinion.
So I'd like to bring us back to having this conversation in the context of SB 806, right? Because we can debate all these various issues, but there's some legislation that's on the table where we have the opportunity to provide our input or advocate for a particular position, right? But I'd like to refocus us on what the issue is and not get too far out of the bounds of the process. Dr. Mahmood, do you have a comment?
Comment, Dr.
Please.
Mahmood. the thing is, the concern we are bringing on these primary care physicians that are licensure, every single thing they can complete months before they apply for license. Only one thing will be licensure, and we can streamline the procedure, and they complete the training, next within week they will get the license, and all the hospitals will give them the privileges if everything else is completed and done, and that process can start 4 or 5 or 6 months before they finish the training. I mean, we've been doing this thing and things have been done, and when they finish the residency, next day board should have all the information, and next day they should be able to get the license. I don't think that's really such a complicated thing that board has to get the application for license until they finish it. They can process everything. Okay, finally they get the letter, training is finished, they get the license and go on.
Yeah, I mean, I guess Dr. Mahmood, sort of to your point, I guess I'm not like, why is this the Medical Board of California's problem to solve, and why isn't it the hospitals who should start vetting them sooner, knowing
Yes.
that they're about to complete their program? I mean, so again, I feel like there's a collaboration issue here that can be solved without the board's instrument that is legislation, right?
Madam
The
Secretary,
unintended
Exactly, and
consequence.
it's not
I
medical
can
board's
answer
problem.
that is that California doesn't allow anybody to apply for California license without a license in another state. If you're applying from another state, hospitals do not allow anybody to apply for licensing or privileges without a license. So you got to have full license. It's not as simple as Dr. Mahmood thinks it is. So it's unfortunate, and I you know, that's why all the hospitals in the country are. It's not just California hospitals. So I mean, I can get that Dr. Hessler can comment on that because it's a requirement.
I know licensing is a requirement, but if the hospital knows, again, I don't know why this is the Medical Board of California's issue. If the hospital knows that the license holder has a postgraduate training license, and you can prove that up, and the hospital knows that at the end of 36 months, if you filed your paperwork, you get your full license, right? I don't know why why we should revise what we believe is the standard for training in California by what could be done with a change of policy, the hospital letting that application come in if you have a PTL and you're at 30 months, right? I don't know why we need to change the standard for all California to accomplish what should be an administrative or, you know, collaboration issue. So anyway, I don't know. I think if we want to change our position to say we want a lesser period of time so we can solve for this problem, if that's the board's, I mean, that is the board's prerogative, we can do that. I'm not hearing overwhelming support for doing that. But I do hear you, Dev, and I hear Dr. Kraus as well. So, but let's maybe try to figure out what the board's position is on that.
Could I ask a quick question to Aaron and Carrie? Can you have it 36 months for all PTL, but 30 months for those doing PTL in low income neighborhoods, inner cities, and rural areas? Is that legal? Would that be legal?
That would require a statutory change, but then you set up this two-tiered system, and the board doesn't license by specialty. So you grant a license to a physician, they can change and start practicing in another specialty. So
I was just trying to solve another problem of trying to attract primary care doctors to low-income neighborhoods and rural areas. And if they go there, some might stay. So, but
so
we do.
Can I just take a pause here? Because I'm actually going to need to do a quick quorum check because we've lost some board members and we're going to lose another one in about 2 minutes. And so I don't know if we're going to have a quorum to be able to continue this discussion.
We'll lose quorum if we lose 2 people. So
we've lost.
We will.
Okay.
We will lose quorum.
I'm sorry. So if we lose one more person, we're going to lose quorum?
If Mr. Watkins is dropping off and
Mr. Watkins, I believe, is dropped off, but he may still be on the line.
And so with that, we would still have 8. So if we lose one more person, we will not have a quorum.
So we're losing Dr. Mahmood in 1 minute. So we're not going to have a quorum because I don't believe.
I still have 5 more minutes.
We could vote on it now.
Well,
Well, but there's other aspects of the bill.
yeah, I mean, if
as
we're gonna
well,
lose
but-
quorum, we're gonna have to postpone this and the remainder of the board's business to tomorrow when we have a quorum. So who do can we do it? I need to go through everyone on the call and see who's here. Because I see Mr. Watkins' screen up, but I believe that he is not here, but his computer may still be on because he was going to potentially return. But that doesn't solve the problem of we still can't conduct business if he's not present and coming back. Carrie, what's the best way for us to I guess, TJ, are you there? I guess he's not, right? And Dr. Mahmood, I understand you're leaving shortly. Okay. So we're gonna, all right, Carrie, tell me what to do.
Well, if the board is in a position now to vote on a position, it still sounds like it's a support if amended position, then you could do that. If further discussion needs to be had, then this has to be postponed.
Yeah, I guess we could potentially vote on this issue about the PTL. I had a couple other issues. I don't think they were controversial. I don't think we were going to change our position, but I did want to be able to come back around and confirm that there wasn't something else that anybody was interested in having a conversation about. So I think we could handle this PTL issue if the board wants to do that right now. We want to do that right now? All right.
So I guess I have another clarifying question. I apologize. I do want to make sure I'm understanding. I don't want to, belabor the point, but I do want to make sure that I'm understanding and the board is understanding of kind of the situation. And so with regard to, the PTL and the concerns that have been raised, by the advocates that we've been hearing from with regard to X waivers and it's prescribing buprenorphine and moonlighting and and the rest, the board would be in essence the board would be saying that we don't believe that we need to change the licensing structure in order to address those particular concerns, that we like to address those particular concerns through some other means.
Yes.
Yes.
Okay. That's all, Madam President. Thank you. So I think it was a Hawkins motion and then a second by Dr. Kraus, potentially?
Yes.
Okay, well,
No.
I'm sorry?
I'm sorry, yes. Forgive me.
Yeah. All right, well, why don't do we feel like we're ready to take a vote on that? I'm just trying to look at the WebEx. It doesn't look like anyone's objecting to that. So let's go forward with the roll call vote on that position.
And the number of members that we have online right now is 8?
We believe that to be the case. Yeah.
Yes, I'm just waiting for this vote so that you have a quorum.
Okay, so let's, Valerie, if you could call the roll on this particular motion, I'd appreciate it.
Dr. Gonadev,
No.
Dr. Hawkins,
Yes.
Dr. Hilzer,
Yes.
Dr. Kraus,
Yes.
Ms. Lawson,
Yes.
Ms. Lubiano,
Yes.
Dr. Mahmood,
Yes.
Mr. Rue,
Yes.
Watkins is not.
That's it.
Okay, so the motion carries 7-1. Is that correct? Did I get that right?
Yes.
Yeah.
Okay, I'd like to just I'm having a hard time, I apologize, seeing who's on WebEx. It's not letting me scroll through the participants. Perhaps that's because we've lost any participants on the other screen. Has TJ rejoined us, or are we losing the quorum as soon as Dr. Mahmood signs off?
I do see Mr. Watkins' computer still on, but he is not unmuted to respond to, so I'm guessing he's away. Yeah.
Okay, So we've just lost our quorum. And so I guess, Ms. Webb, that means that we are concluding our business for the evening, because while we could take some information, we can't take any action without a quorum.
Right. I mean, you could do the updates if you wanted to, but I recognize the hour is already late. But you could do update items and then, or you could postpone the items until tomorrow, but you do have some speakers that have been standing by. So I don't know the availability, for instance, of the folks from the Attorney General's office prepared to talk about the budget. If they were slated today and can't be here tomorrow, that could be an issue. But that is just an update item.
Could we offer the speakers who are available now their choice to present now or tomorrow morning?
My two updates are very short, 14 and 15.
Do we, could someone let me know, is there anybody who is scheduled to speak that's not available tomorrow?
I have Kathleen Nichols up next for HKU, Gloria Castro from DOJ, both here that I can put on the line to ask their availability.
Please do.
First up, I got Kathleen. Miss Nichols, are you there?
Yes, can you hear me?
We can.
I actually have a conflict tomorrow, so I'd really like to be able to give my update if that's possible.
Okay, I guess that's possible. We're just missing, we're just missing
Actually,
the board.
Mr. Watkins just joined us again, so
Okay.
we have a quorum.
All right, we have a quorum. So we're back. All right, everyone else I should ask, is anyone else leaving?
I'll be leaving at 10.
Okay.
Me too.
Is there anyone else that is leaving in the near term that we need to be concerned about, because we've just regained our quorum?
I'll be leaving at 8, so I think I hope we can finish by 8.
Okay.
I can go until 8 as well.
Let's proceed.
So are we going to continue with the SB 806?
No, that's a good question. I have no
There's
idea.
other,
I'm sorry.
So anyway, so that, I mean, for the sake of time, that could be, that could be continued to tomorrow.
Well,
if we want to.
But wait a minute. I thought there were two key issues that have just been addressed. Are there other major things that would influence whether the board takes a supportive amended position or changes that?
Well, we haven't, I don't think the board has settled on whether or not they have other changes in addition to those two that.
Okay, so let's keep going. I'm sorry. I'm sorry that the meeting was disrupted in this way and that I got thrown off my game, if you will, in terms of where we're at. Let's keep going with the agenda item that we're on, which is SB 806. We've resolved our position on the confidential letter of advice. We resolved our position on the postgraduate training license. The question I have for the group at this point is, do we want to change any of our other positions? Our position on fees is that we want the full amount. Our position on cost recovery is we want it to stay in the bill. Our position on the length of the extension is that we want 4 years, not 2. Aaron, are there any other issues? I mean, those are the ones I heard and took notes on that multiple people were talking about. But there are, issues related to the enforcement monitor. I mean, again,
thank you. Agree. The enforcement monitor. So we asked the legislature to make some amendments to it. They did. And so the board, if the board is satisfied with the language that's in the bill right now, then the board could basically strike that from the supportive amended position because it's been satisfactorily resolved. If they have anything further the board wishes to see to be done, there is some differences between what is currently in the bill and what the board laid out in its position letter relative to reflecting things in the prior enforcement program statutes. So if the board just wishes to continue on as is, then we don't need to change anything. But if the board is satisfied with the language that's in the bill right now on the enforcement monitor, then the board should update its position to remove that condition, if you will.
Okay. And then maybe just one other framing question before we get into a conversation. Are there any issues that I did not identify or we did not identify on which you need our direction for the conversations that you're, anticipate having in the next 4 weeks?
No. I mean, I think we have it all, sufficiently laid out. Unless there are other things that's in the bill right now that the board doesn't like, or things that haven't been previously discussed that the board wants to go in, now is the time to decide that.
Are there any of those items? So is there anything that we haven't discussed that the board would like to discuss this evening, or potentially take a different position on, or anything that we haven't thought of before that you'd like to see in this bill?
Just the question of the enforcement monitor, that it is appointed by the DCA director. I think that's going to be problematic because of the inherent conflict of interest. And this is more to preserve the integrity of the enforcement monitor. And I don't know how to solve for that, to be honest with you, because we can't give it to the deputy, because the deputy has also been an interim director at the medical board. So I don't know who takes charge of it at DCA to actually oversee the enforcement monitor for the medical board, because that's what the language says right now. And unfortunately, if we don't address it, then we're going to get the same old trust issues.
Madam President, I would just add that the DCA director being the appointing body for the enforcement monitor is consistent with the board's position. That is the way it was. That's the way it was done 17 some odd years ago. That's what we asked the legislature to do, and that is what is in the language right now.
Well, if we ask that now, and the director that is currently in place and the deputy director that's currently in place have both been previous past directors of the medical board, that is a conflict of interest, and that undermines the whole point of an independent enforcement monitor. And that's all that I'm saying. And I don't know where you get a third party enforcement monitor, but I can, if from the outset it just looks like that's something that will not hold its weight when it's held to public scrutiny, just because of those conflicts.
Madam Chair, I don't have any problem with that. We approved it, and I'm good with it. So I just wanted to say.
So the conflict of interest is okay. TJ,
there is a conflict always in the political appointments. So it is not the person who was the CEO of Goldman Sachs becomes Treasury Secretary. So that doesn't mean that that person cannot make rules. So it's politics. So that's why I don't have any problem, because in real life this happens from the industry to the regulators. So I usually people are good enough to realize what their job is, and they go from there.
But this is both regulatory bodies. This is not coming from the private sector into the public sector. This is both regulatory bodies. This is the issues that would be being monitored are the same issues that would have been under the previous director's care. You see, it's not just like there's a conflict of interest that I've worked for Goldman Sachs out of the private sector. These are two regulatory bodies that are tied together.
So let me answer you that. this person was appointed by the governor
Yes.
to run the DCA. Her job is to run the DCA, what all the functions of DCA are. So if she feels that she is not the right person, she can designate, but she is the right person to do it.
So then you see, the fact that I have to explain that is problematic in itself, because if you don't see that the conflict of interest is it's a more direct conflict of interest, then the public outcry is even more. You see, we can rather say that, you know, that someone designated by the current DCA, the current DCA director or something.
Well, let's leave it there. We disagree. That's all.
You know,
In
can
any
I?
event, a conflict of interest can always be inferred. So I would ask TJ for a suggested solution as to who would appoint the enforcement monitor.
I would suggest maybe somebody out in agency. What's that agency that oversees DCA? That would be completely independent. That would be a step up and removed, and it would give way more independence to the whole process. Now, I don't know what that looks like. I'm just saying, you see.
So let's get back to framing this in the context of where we're at with SB 806. The question on the table is whether or not we should change our current position. The enforcement monitor language is in section 13 of the current bill. It says that the director shall appoint an independent enforcement monitor. It has to do that by a personal services contract, and that there's a new state function. I suspect that the reason why they give the director the authority to do it is because in order to spend state money, they need to go through these very specific processes, right? In order to have the enforcement monitor get a contract in place and that sort of thing. And so do we want to have that authority to appoint the independent enforcement monitor vested in someone else, like we did with the confidential letter of advice? Do we want to, you know, put some more guardrails around it and make it clear that we expect the person who's appointed to be independent or meet certain criteria? I guess that's the question. So do we want to keep our current position, which is what got the language drafted as it is in SB 806, or do we want to change it? And I guess I would take a motion on that so we can.
I would suggest a change, and we say, let's put the secretary of agency, Lourdes, I think that's her name, to make such an appointment. She's also appointed by the governor, but she is a completely neutral party.
But,
so now
but TJ, to that point, remember, she's appointed. So Bill Prasifka could be appointed to that position, right? So I mean, we can't solve for the individuals, right? So if we want to pick who's going to be the appointing authority, we should just pick that appointing authority, you know, notwithstanding who's in the position currently, because that could change on a moment's notice.
Well, it usually changes with the governor. So I'm very sensitive to the public trust issues, and that it's not a perception, it's people's lived experiences. And if we want to build on that, then we start having to act and do tougher things, not just direct because it's convenient. Because the convenience of it, I'll go for that. But there's no independence in this enforcement monitor if it is coming through DCA. That's
okay. Your position is we would ask the legislature to vest this authority to appoint the monitor in somebody else.
Yes.
Okay.
Well, make a statement, Christina.
Yep.
5 years on the board, I've never questioned the ethics of the current DCA, head of DCA. That's a statement I'm just going to make. She knows what conflict of interest is, and she knows a lot. I mean, I don't know about this mistrust in, I think we're talking about Kim Kirchmeier. I don't think that's a real issue for me, but it may be an issue for some other people. So,
could I, sorry to chime in so much, but I just want to say, I built my career on building public trust. That's what my entire career has been built on. So, I hear what Commissioner Watkins is saying, but at the same time, I don't think you could legislate for an individual because I see what Mr. Watkins is saying, because the former director of the medical board is now the director of DCA, so there could be potential conflict there, potential conflict, but that would assume that the former former medical board director was corrupt or bought off by the medical CMA and therefore cannot be independent. So I think there's ethics laws and there's lobbying laws and corruption laws already in the books to deal with something like that, if that was the case. So I think it's hard to legislate or create a rule based on that, because if we did have and I Googled it, the Business Consumer Services and Housing Agency, which is Lourdes Castro Ramirez, who oversees DCA, make the appointment. What happens if 6 months from now, the DCA director gets that promotion? Do we go back and change that again? So it's really hard to, and I don't think you could single out an individual because there's a perception or in a bad way, an accusation. So it's, I see the mistrust, there might be some mistrust, but we have to have faith.
It's not a might. This is real. As is, you see, it's easy to dismiss everybody as just, well, they mistrust, perceived mistrust. These are people's lived experiences, is what I'm saying. They had certain real life experiences with this board. They deeply distrust the board. We still operating as business as usual, right? They don't trust Kim Kirchmeier with regard to this, right? They don't. We've sat through the whole board meetings and all of it. We trust Kim. We believe that she will do the job. But the outside perception, right, that comes with that doesn't smell that. It just smells like, oh, they are all just intermingled along this channel, and we're never gonna get anything right. And that's okay. I don't want to solve for this. What I want to do is give it a voice, hear the voices, the vote will happen, and we'll appoint the director to appoint the person. Because that's how it always works, and it's not a problem. Because we understand that that's how it works.
I don't think that your characterization of us not caring or us not being empathetic or us not understanding the concerns that are brought to us is fair. This board, let me finish, please. This board asked for the enforcement monitor. We asked for someone to come in and say, here's what you're doing wrong, here's what you could be improving, and here's how to do it. We asked for that. Now we're quibbling right now over who should appoint the person to come in and tell us all those things. And we're disregarding the fact that we've asked for this ourselves, right? We are interested as a board in understanding how we can do better. Now, I don't, I agree with Mr. Rue that you can't, that it is not good public policy to legislate because a particular person is in a position, right? Because you create a whole nother set of issues the second that person's out of the position. Or if we get it wrong and we say the agency secretary should do that, we might have the circumstance where all of a sudden that's someone who was previously affiliated with the medical board, right? We just sort of aren't solving for the problem. We could, however, solve for the problem by putting in some guardrails for the DCA director. We could solve for the problem by saying the enforcement monitor needs to not be affiliated with a particular physician organization. On the same, along the same lines, we could say the enforcement monitor needs to not be affiliated with a particular patient advocacy organization, right? So it's truly someone that is independent, that is here to attempt to help us solve the problems and look for the opportunities that we've already identified. So I think it would be more constructive if we thought along those lines rather than spending time talking about what our intent as board members are, or whether or not we're being empathetic or listening, because every single member of this board listens, and we all make judgments based on being put in these positions of privilege to serve the people of California in this way, and we're all trying to do our best job and use our best judgment to do that.
I completely understand, that. But yet, I think we should solve for this problem by putting in those guardrails and building something in that will not make it look like this is just another weaving system, because that's what it looks like. It may not be like that, but that's what it looks like. If we put in a guardrail that, are truly independent and these are the parameters, then that solves for that. I'm just saying that if we, my question is, if we just roll it over, even in our discussions, if we just roll it over and the end result is exactly the same, then we don't solve the trust issues, regardless of how we feel or anything. It just looks the same. But I take that point.
So I'm not sure where we're at with this as to whether or not we want to change our position. I don't think we have a motion on the table as to whether or not we want to change our position on the enforcement monitor. Perhaps I'll put a motion on the table. What if I move that we retain our position on the enforcement monitor and we request that the legislature add some language to the bill that would ensure the independence of the enforcement monitor from any particular advocacy organization? And I guess there are different ways that you could frame that through, certain, there are conflict of interest rules. You could frame that in different ways in terms of, we wouldn't want to hire, we wouldn't want the DCA director to hire an enforcement monitor that is affiliated with any particular group that has any particular advocacy position for us. We'd want that monitor to be independent.
Yes.
Is there a second?
Second.
Oh, you did a second. Okay. I was going to second, but I would tell you, Christine and the rest of the board, I don't know that I trust the legislator to do a better job than Kim Kirchmeier.
I agree with it.
Just saying.
Yeah, just to point out, I don't have any problem with the motion. I don't expect the DCA director to appoint somebody affiliated with the group. I don't expect that. I think Kim is very honest and trustworthy. I don't have any problem. So I'm okay with either way, leaving it alone or the motion you made.
Could you restate the motion, Madam President, so I can capture it correctly? Is we're good with the language as is on the enforcement monitor with the addition of the independence from advocacy organizations?
Exactly. And I don't, I apologize because as a lawyer, I like to spend some time with language and make sure it's right.
I think I got it.
I use advocacy organizations as an umbrella term to, I guess, capture, people who potentially have a financial interest or other, conflict of interest that would prevent them from being impartial as part of their enforcement monitor process. So maybe advocacy organizations just captures that. I don't know. I think the idea is that there be some criteria for the selection of that enforcement monitor by the appointing agency, who in the bill is DCA.
Great.
Is everyone comfortable with that?
Yes.
Okay.
And the second was by
Rouse.
Any comment?
Okay.
All right, let's move to a roll call vote on that.
Dr. Gonadev,
Yes.
Dr. Hawkins,
Yes.
Dr. Helzer,
Yes.
Dr. Kraus,
Yes.
Ms. Lawson,
Yes.
Ms. Lubiano,
Yes.
Dr. Mahmood left, Mr. Rue,
Yes.
Mr. Watkins. I'm sorry, Mr. Watkins.
Mr. Watkins, we can't hear you.
Very
Yes.
faint. Yes.
Okay.
Okay.
Thank you.
All right. So that's enforcement monitor. Unless there's anything else, other changes, then I think we are. I understand that we are maintaining our support if amended position. So to sum up, we're maintaining our support if amended position, but we're modifying it with regard to the enforcement monitor, the postgraduate training license, the confidential letter of advice. Those are the three amendments to our support if amended position. Everything else remains the same. And then notwithstanding the support if amended position, staff will still be encouraging the governor to sign the bill into law, even if we do not get all of the conditions satisfied for our support if amended.
Yeah, I guess I would say with the caveat that assumes that it continues the board, correct? I mean, if it is amended such that there's some sort of sunset, we're obviously not going to advocate for our own death, but yes.
Right. Well, yeah.
I think you got it.
We'd have bigger problems in that case, but yes, but normally if the board did not move from support if amended to support, we would not request signature. This is an exception that we are making to that. So just want to clarify the staff's direction. Okay.
Yeah, I think that's right. I think all of us agree that the board should continue.
Wonderful.
Even if we're faced with legislation we don't agree with in its entirety.
Yes, ma'am. Okay.
And then I guess I would just, before we move on from this item, I just wanted to clarify with the board that if we, that you and I and Dr. Hawkins also, as we continue to advocate, and if we put anything, in writing, we will work on that together to make sure it captures what we've heard this evening.
Thank you.
All right. Anything else on update on sunset review and action on SB 806? If not, we will move on. I see we have Ms. Nichols on the line. We will start with your presentation. I see we're getting close to the 8 o'clock hour that a couple of our members have let us know is the time they turn back into their pumpkins or what have you. So.
Okay, well, good evening. I'm Deputy Chief Kathleen Nichols. It's my pleasure to update the board on the Division of Investigations Health Quality Investigation Unit. There are currently 15 investigator vacancies, which is a 19% vacancy rate. There are 14 candidates in background, and we are conducting hiring panels to identify additional candidates in order to immediately fill these vacancies. As discussed at the prior board meeting, we were anticipating several retirements. 5 supervisors retired. 3 of those positions have been filled with investigator promotions, creating some additional investigator vacancies. Additionally, the vacancy count includes 4 new positions HQIU was granted in July of 2021 as part of an approved budget change proposal to cover the influx of new cases from the passage of SB 425, which requires health entities such as hospitals and clinics to report allegations of sexual abuse or misconduct to the appropriate state licensing agency within 15 days of receipt. Since SB 425 became effective January 1 of 2020, HQIU has received 96 investigations of this case type. We have completed 18 of these investigations the past fiscal year, and the closed case average is 238 days. Last fiscal year, our investigators completed 1,467 investigations. We continue to focus on completing the H cases, which is why the closed case average is rising. We have made tremendous progress in our pending workload and reduced the amount of cases over a year old, which I would like to share with you. In January of 2020, our pending workload was 2,340 investigations. At the end of July of 2021, our pending workload is 1,653 investigations, which you can see is a net reduction of 687 investigations, which is substantial. As you can see from the graph, we have steadily been improving the total pending workload. And moving to the second slide, illustrates the number of cases in HQIU over a year old, which is also steadily decreasing. From January to July of 2021, we have made a net reduction of 222 investigations that are over a year old. As we continue to be successful completing H cases, the closed case average number will rise, but it's a reflection of the older cases being completed. Another way we have achieved workload reduction for sworn investigators is with the success of our new expert procurement unit. The unit started accepting cases in October of 2020. From October of 2020 to the end of the fiscal year, EPU accepted 353 cases to handle the expert review process. As part of the review process, the EPU manager reviews and ensures all the records are certified and all pertinent information is included. I am also personally reviewing all of the cases submitted for expert, and this combined in-depth review has improved quality standards for our investigations. By shifting this part of the process to EPU, it has allowed investigators to focus on investigating remaining cases assigned to them and resulted in lower caseloads for sworn staff, which was desperately needed. We have engaged in weekly meetings with board staff to discuss aged and priority cases, as well as weekly discussions to improve our processes and resolve issues timely. These frequent communications have greatly strengthened the partnership between HQIU and board staff as we work together to improve timeframes. Additionally, we continue to send board staff a monthly report with status updates on aged cases. And to answer the question earlier about unlicensed practice cases, yes, our unlicensed practice cases have aged the past year due to the COVID-19 pandemic. A majority of the clinics and businesses were closed during the COVID shutdowns, and undercover operations could not be conducted. As clinics and businesses reopened, we resumed undercover operations, and those cases are proceeding. Another factor in unlicensed cases are cases that involve telemedicine, where it is alleged that an unlicensed person either owns the business and/or is providing services. These cases are very time-consuming and difficult to prove ownership. In some cases, we've tracked businesses out of the country, and there were no California or other people involved. There is also significant volume of corporate practice of medicine cases that involve extensive documentation to prove violations. Issues that still impact time delays in our investigations are our ability to timely obtain certified medical records, timely obtain information from pharmacies on prescribing cases, scheduling interviews with subject physicians, and obtaining toxicology screens on impairment cases, since those are currently voluntary and they're not mandated of physicians. I look forward to my continued meetings with board staff, and this concludes my update. I'd be happy to answer any questions.
Thank you. Are there any questions from board members? Comments?
Just one, Madam Chair. It's Kathleen. So are we, with the vacancies, are we looking at numbers piling up again, numbers to be investigated? It worries me that you have more vacancies now compared to the last meeting. So I hope you're ready to, you are filling those things very quickly so that we continuously go down in timeline.
Yes, we are. We have 14 people in background right now for those vacancies. So we have a significant number already selected, and we are vigorously holding hiring panels to make sure that we have enough candidates that are in background. We did have a spike in retirements, which some was anticipated and some was not. Some people have given us, 2 weeks notice and they're leaving, and we have to reassign entire caseloads. So I think the pandemic has brought on a lot of that, not just in our sector, but in all kinds of sectors of employment. So that is something that we're experiencing, but we're moving forward with filling the vacancies.
Dr. Hawkins, I have a question. Ms. Nichols, can you give us an idea about the number of investigators you have now and the numbers and background? What skill level are those? Do we have a bunch of young, new folks in background, or give us an idea about the skills of the folks that are going to be seeing these cases?
Right now, all the people that are in background already have their post-academy. So that means that they already have significant law enforcement experience.
Okay.
Additional comments or questions? I do need to open this up for public comment.
This is Lori. I had a quick question.
Please.
For some of the retirements, I was just curious if any of those had to do with any kind of vaccine mandate.
Not as yet. They have not. They have been primarily either planned retirements or just people that have decided they've had enough and want to get out of the field. It's a crushing workload, especially for supervisors. So I think that's primarily the reason. We haven't had anybody leave yet because of a vaccine issue.
Thank you.
Additional questions or comments? I'm going to open it up for public comment if not. All right, Sean, can you open it up for public comment, please?
Yes, I've activated the hand raising and Q&A feature. For anyone wishing to make a public comment, please indicate so by raising your hand or just typing anything in the Q&A box. Give everyone a few seconds here. That's awesome. I'm not seeing any requests.
All right, that's a first. I think we tired everybody out. Okay, we have one other update, which is from DCA, where we may not have Ms. Holmes available tomorrow. So with the board's permission, I'd like to have her give her update quickly.
Also, Ms. Lawson, don't forget about the Attorney General's office.
Okay, are they? I know they're here, but I have heard that Ms. Holmes is not available tomorrow. I would like to give it tonight. But if the AG's office has the same thing, if someone could send a note my way and let me know that. Ms. Holmes, are you available?
I just added Ms. Holmes as a panelist now. She should be able to unmute.
Okay.
Good evening. The AG's office can definitely take precedence if they wanted to go.
I don't know that I have an answer. Ms. Holmes, if you could just proceed and we'll find out. We'll take them next if they're here.
Sure. I will proceed and I will be brief. Good evening, board president and board members. I am Carrie Holmes, Deputy Director, Board and Bureau Relations at the Department of Consumer Affairs. Thank you for allowing me to provide the update. I would like to welcome Dr. Hauser as the newest member of the board. Congratulations on your appointment and thank you for serving. DCA has been receiving many questions about when and how boards will meet again in person and whether they can also continue to meet remotely. As the law and executive orders stand today, after September 30th, boards and committees will be required to return to in-person meetings with publicly noticed meeting locations. However, due to ongoing changes in the COVID-19 pandemic, it is possible the ability to meet remotely will be extended in some capacity. We don't have any concrete news today, so DCA will do all it can to assist boards to plan safely for in-person meetings and keep you informed of any changes to meeting requirements. To combat the spread of COVID-19 and protect vulnerable communities, California is implementing enhanced safety measures for state employees and workers in healthcare settings. State employees must show proof of vaccination or will be subject to regular COVID-19 testing and required to wear appropriate PPE. Board and committee members are considered employees and must follow health and safety protocols if they plan to be physically present in a DCA location, whether for a board meeting or just a quick visit. Members must verify vaccination or follow face covering and testing protocols in accordance with that location's requirements. Statewide guidance for use of face coverings remains in place unless the local jurisdiction issues a stricter ordinance tailored to the situation in their communities. Many counties have revised public health orders requiring face masks to be worn by both vaccinated and unvaccinated individuals while indoors. To further protect Californians and healthcare workers, the California Department of Public Health recently issued 2 public health orders. The first requires workers in healthcare settings to be fully vaccinated or receive a second dose by September 30th. The second directs hospitals, skilled nursing facilities, and intermediate care facilities to verify that visitors are fully vaccinated or have tested negative for COVID-19. Licensees are encouraged to thoroughly read the orders and regularly check local public health departments for additional vaccination requirements. Questions from licensees about the healthcare worker requirements can be directed to the California Department of Public Health. As a reminder, 2021 is a mandatory sexual harassment prevention training year. All employees and board members are required to complete the training during this year. Please be advised that you can now access this through DCA's learning management system. We have created profiles for each of you in the LMS and informed your executive officer of the steps you'll need to take to log in and access the training. We're happy to assist in any way. As always, Board and Bureau Relations is here to help, so if there's anything I can do, please reach out. This concludes my presentation.
Ms. Holmes, thank you. I just have one question for you actually on the vaccine policy. I think we all received a copy of DCA's memo. Of course, it doesn't, well, it applies to board members, but it doesn't have the same effect on board members because we're not always in the board's offices, you know, or you know, present in a location. But if we do want to visit one of the locations for a meeting or otherwise, is it sufficient that we come with our vaccine cards or with our, you know, the QR code, or do we need to register in advance in order to be able to do that?
So there are two methods. So the way that DCA is implementing this is it's through our HR. So that way other staff that are not in human resources are not subject to reviewing that information. So you can either upload your information through that, the verification portal, because you do have those DCA affiliated email addresses, and then the information is reviewed and then destroyed confidentially. You can also set up a Teams call with a member of HR. They can just look at it on the camera and then you'll be checked off.
Got it. So we need to make sure to do that in advance before we decide to show up in Sacramento to visit our staff colleagues. Great, thank you for that clarification. Are there any any other questions from board members? All right, we will open it up for public comment if there's any on the line.
Okay, I've activated the hand raising and Q&A feature for anyone wishing to make a public comment on this agenda item. Give anyone a few seconds here to queue up.
All right, it looks like we don't have any on this item as well. Sean?
No, I don't see it. Any requests?
Great, thank you. Bringing this back to the board, Ms. Holmes, thank you. I know that there were a couple people who wanted to leave at 8. It is just after 8. We have Ms. Castro available, and I understand the presentation is short. So with the board's indulgence, I'd love to take it this evening. Dr. Gananadev and Ms. Lubiano, are you able to stay for a few more minutes?
Yeah, you're killing me, Christina, but yes, go ahead.
Same. All right. Ms. Lubiano, are you okay? And I want to be mindful. If you're not, please let us know. Okay. Thank you. All right, Sean, let's move on to agenda item 12, update from the Attorney General's office.
There we go. Good evening. I hope you can all hear me. And the reason why we believe this will be short is because Dr. Thorpe, who I understand is unavailable unexpectedly, and we wish him well, is not here. It's my pleasure to introduce to you the two folks that have been hanging out here waiting to speak to you. Ashley Harp is our department's budget officer within our Division of Operations. She oversees the development of the department's annual budget, including monitoring the annual departmental expenditures, revenues, and appropriations. She and her team are happy to assist with any fiscal related questions or concerns today. And likewise, it's my honor to also introduce Maria Celerio. She's our budget manager at the Department of Justice. This is Legal Services Division. She has 19 years of experience working in both private entities and state government, with concentration in fiscal, IT, business services, and administration. Maria provides support and technical budget expertise, not only to myself, but to all of DOJ in achieving its goals and objectives by providing direction and assistance in various fiscal activities regarding aiming to resolve programmatic issues. Maria was instrumental in the most recent development of DOJ's increase in its legal billing rates, and Maria and Miss Hilario and Miss Harp have both gotten to meet Reggie Varhesi as well, and it's my pleasure to introduce you to them. Agenda item 8 earlier provides some context to some of your budget questions that you may have had. And specifically, if you look at agenda item 3, agenda item 7 from your last meeting, Dr. Thorpe commented on the board's budgetary allocation for the AG and stated that the board will be over budgeted by approximately $4 million if it continues on the current course. And he commented that the board is seeing no decrease in timeframes for adjudication of cases. On the first count and the second, we're prepared to answer any questions that you may have. But in essence, the increase in $4 million is a straight line that you gave to us to account for the fee increase. And I can report to you that in the last 3 fiscal years, our amount of hours working on your important work has not swayed very much. It's been 84,468 hours, 84,077 hours, and finally 83,983 hours in fiscal year 2021. So we're still doing the same amount of work. And while it may be shocking, the price tag is bigger, but the work continues. And with that, I would like to invite Ms. Harp and Ms. Hilario to say hello and to add to what I already said. I wanted to keep my comments brief for a change, especially. And so, but they're the experts and they're here to help you.
Hi, everyone. My name is Ashley Harp. Thanks, Gloria, for the introduction. And it's nice to see you all virtually, everyone on the board. Just to give a brief overview of kind of the fiscal component, DOJ provides legal services, including advice work and litigation support to client agencies statewide, including NBC. We operate on a billable model where client agencies are charged hourly for legal services provided by the DOJ as authorized by Government Code 11044. Client agencies are invoiced monthly for services, and they pay us using funding that's appropriated to them by the legislature in their budget. Each client's required legal services budget is determined by that agency and in collaboration with the Department of Finance and the legislature, and is appropriated in the state's annual budget act for each agency. In terms of workload, DOJ works to conduct a thorough review of all cases that are sent to us by client agencies, including administrative, civil, lawsuits, and advice work. And then we bill for our time based on the established legal services billing rates. Currently, those rates are $220 per hour for attorney services, $205 an hour for paralegal services, and $195 an hour for auditor and research analyst services. With that, if anyone has any questions on the fiscal side or kind of the billing model, we're happy to answer any of those questions. And with that, I'll turn it back to Gloria and back to the board.
Ms. Hart, what's the difference between, Dr. Hawkins, what's the difference between attorneys and paralegals?
Sure. Attorneys are our attorney classification, the Deputy Attorney General classification, and paralegal services are senior legal analyst classifications.
That's right. And there's no independent level among senior assistants, SDAGs, or DAGs. We're all at the $220 level. And perhaps Maria Hilario can speak to how that fee model was determined if you need more guidance on that.
What's the paralegal rate though?
The paralegal rate is
205
in front of me.
$205.
Thank you.
Mm-hmm.
Say it again.
205.
Well, Ms. Castro, I think I expressed my opinion before, so I just want you to know we think that your attorney rate is fairly low compared to all the attorneys we pay, but your paralegal, I believe, your rate is very high. So we pointed out before, so there isn't anything you could do at this time. So we were hoping that somewhere when I mentioned that the way we can manage the budget is one is raising revenue and one is cutting expenses. And unfortunately, two of our biggest expenses is the AG's office and HQAU. So just, you know that too. So
Yes, and that's why we're very excited that you may end up getting cost recovery. And really, you do get quite a deal with the Attorney General's office when we have to travel. And one day, maybe we will get to travel again and be in a boring hotel lobby again and loving it because we miss it now. We cover the travel. Our billing rate includes copying, postage, secretarial support. I defer to my budget folks to tell me what else it includes. So we don't charge extra for any of that. That's encapsulated in our hourly billing rate. And at the same time, do you know what the billing rate is for investigators at DCA? I do know that some of our clients on whose behalf I collect costs from, their billing rate is higher than the lawyer rate by the hour for some investigators. So I think putting it into perspective and knowing that you have your own independent law firm that is very focused on your work and your work alone and that of 7 other healthcare oversight agencies has to be taken into account. And if it makes you feel any better, Dr. Granada, and maybe it won't, maybe it will, this hadn't happened in about 10 years. By the time it came, unfortunately, the timing was not right for your fiscal woes. But at the same time, all clients serviced by the 1,100 attorneys at the Attorney General's office have the same exact billing rate. So we don't say, the medical board's very hard and then this other client's very easy. So let's have graduated or steps. And like I said, my billing rate is the same as the brand new baby DAG that just got their bar card. There's no distinction. And of course, I'd like to think that I offer a lot of experience and that my SDAGs do as well. And you had the pleasure of seeing them most recently in the panel interviews. There's a lot more I could say, but really I brought our budget folks here for you. And certainly they are available to continue this conversation with Mr. Barhesi, Ms. Jones, Mr. Prasifka, the president, and Dr. Thorpe, if he comes back and he still has some questions and sees the playback and didn't get the answers that he was hoping to get today. But I can assure you that 83,000 hours per year has stayed constant. Our workload is heavy and rewarding and a little different. But notwithstanding the differences in how we receive your work, our vigor and energy has not waned, no matter what we charge.
Ms. Castro, I just,
yes.
I want to thank you for all the good work that you and everyone in the Attorney General's office does for the Medical Board of California. Of course, there are a couple of lawyers that are part of the medical board serving in a public member capacity. And I have to say that you all are a complete bargain if we were going out in the private market to obtain the level of service that we have from you all as our, law firm, if you will. We would be paying substantially more. So while we have a lot of work to do to continue to work to constrain costs and make sure we're providing all of our services as efficiently as we can, your hourly rate for the high level of quality and frankly the level of experience that you all bring to the table is quite low in my experience. The other thing, while we have you, I wanted to share with you that I know that you've received a tremendous amount of feedback from us over the years and recently about the memos that you provide to the panels about our discipline and enforcement cases. And I just wanted to share with you that especially as part of the most recent panels we had this morning, and of course I only have visibility into panel B on which I serve, But I really appreciated you all being responsive to the comments that this board has provided to you, to providing us with additional information. And then in the panels, just coming extraordinarily well prepared, particularly today, to address the legitimate questions that our board members have had. So thank you for your excellent work. On behalf of my experience on panel B today, I really appreciated it. So thank you.
Thank you, Ms. Lawson.
Are there additional comments or questions from board members?
Yeah, Ms. Castro, same
Oh.
is ditto for the panel A. I think this is the first time I saw how much you were involved in answering questions compared to just one of the DAGs sitting there. So it was helpful, and
wonderful.
I think it resolved a lot of questions, especially many new board members have. I think it was very useful, and thank you.
Thank you.
Dr. Hawkins, I won't be repetitious. Thank you, Dr. Ganadev. Did have a question came up about cost recovery, and we had a conversation about that several months ago in my prep for a hearing.
That's
so
right.
one of the questions is, so it can adjust the ALJ can make an adjustment in cost recovery.
That's right.
I think, and then I don't know time frame. You suggested that doctors are motivated to settle when they know the cost recovery is a factor. Could you give us a little bit more about the cost recovery and what you think would be the impact, if not numbers, just in general?
Absolutely. I do not buy that there would be zero impact. I do believe this from my factual experience with my other clients on whose behalf we strenuously bring the hammer and collect costs. We negotiate costs in the stipulation, and we argue strenuously at the Office of Administrative Hearings that you should be entitled to your entire money back for both Ms. Nichols's staff, for your staff, and for our staff. So investigative costs and prosecution costs. For our side, we are very, very able to prove our costs. Why? Because every single legal professional in the Attorney General's office has to bill into a pro law system. We have task codes, and I'm very motivated to have our task codes for every single 15-minute increment that we bill all of our clients to be as descriptive as possible. I provide our clients' staff, Jenna Jones and Reggie and David Russwinkle and Mr. Prasifka, with monthly reports on how much cases are costing as a totality. And if anybody wants to dig in, Mr. Prasifka can pick up the phone or direct someone to call me to find out why is this case so expensive. On the second hand, we also provide copious amounts of milestones and days between markers. We have an annual report that we publish. But back to the costs, we're able to support our cost requests because we take care to have this careful billing. And when the ALJ decides that a cost reduction is necessary, it is usually because there's a doctor there, maybe they're a solo practitioner, and they plead poverty, they plead that maybe they have child support orders or a couple of ex-wives and things like that. So those kind of things are compelling to ALJs. And for the most part, some of our clients have been hobbled to be able to not be able to increase the costs after the fact. So I encourage you to continue to talk to your partners. I was excited to see that one of my clients, the Osteopathic Medical Board, was inquired of to see what the recovery rate is, all that. I thought that was very thoughtfully put together by Mr. Varghese and any other staff that put that together. And that's exactly what you should be thinking about. The Respiratory Care Board in particular has very, very strong laws on the books that allow them to get their costs. And if you think about the costs, our costs are the same for the Respiratory Care Board for someone who makes maybe $40,000 a year, and it's the same as a doctor. So I do encourage you to continue to speak to other healthcare oversight agencies that have collected costs this whole time. And it's an informative process for everyone. It is very empowering to me on a personal level that when I started my career here in HQE in 2009, that I could honestly tell the other side that I was on the side of public interest, and that even though we did watch our bills, we could keep going like the Energizer Bunny to try and get what we need to get for the public. That's somewhat intimidating when you're paying a lawyer, a private bar lawyer, whether your medical malpractice insurance carrier pays for it or not. You still have to pay for the experts. You still are out of your work. You're still having to pay all these witnesses. So it adds up. So from my perspective, as I sit here today, there's been a subsidy a little bit to have them hire that extra expert. So I'm hoping that if they are paying their lawyer and there's a risk that we might collect those costs back for you to put back in your kitty and use for your other public protection initiatives, that there will be some sort of motivation for everybody involved to settle earlier, because that money is no longer going to be there. I spoke yesterday about one case in particular. It's not uncommon to have six-figure cases for you because they can and are heavily litigated. Why? Because there's due process considerations, and this is a property right that people work very hard for and support families on.
Thank you very much.
Thank you, Dr. Hawkins, for your question. I hope that answered it.
Additional questions or comments?
Just a comment. You know, I want to say thank you to Gloria yesterday for bringing in our A team into those panel meetings and really enlightening myself to really get the big picture. You see, it's interesting when you come across these cases and you see and witness certain of these outcomes, and these outcomes looks awful. And then you look into the background, as some of your DAGs pointed out yesterday, and you see that these laws are written in a very strategic way to create such a sense of powerlessness, a sense of powerlessness that I see in your DAGs, a sense of powerlessness that I feel. And then down the course, you know, it creates these statistics. And so you're looking at an entire system that is then skewed in this particular direction. And I was talking about this earlier today, you know, when my first shot, when I get to this numb to seeing all these statistics and not completely understanding the legal background, and that this entire little book is tweaked in presenting outcomes in a very particular way. And then I see how hard your DAGs actually worked to get, you know, what is really not exciting outcomes from a public protection point of view. And I just want to say thank you for, you know, bringing that perspective. And I wish that perspective could be shared with the public, because I think a lot of our distrust issues around these cases would be addressed in that, because I know where the problem lies now. So I just wanted to thank you for taking the time and actually doing that work.
Thank you, Mr. Watkins. That is very meaningful to me, and I will take all of the comments complimenting my supervising deputy attorney generals who review the STIPs, myself. Well, I will let the DAGs know how you feel about that, and I'm glad that it was well received. And I'll do a shout out to the staff as well. I'm sorry to jump on here, but we do get surrenders, notwithstanding all the challenges that we have. And if you just look at your annual reports, it's right there in black and white. Surrenders with accusation pending. I don't know the statistics for 2021, but last year we had 89 surrenders, the year before 85, the year before 87. And that's with all of the challenges, with not collecting costs, with being outnumbered with experts, with the due process considerations, and with the lack of some enforcement, well, discovery tools, let's just say that, and evidence, and our high standard of proof. So thank you very much, Mr. Watkins and Ms. Lawson and Dr. Hawkins, and thank you for indulging us and for the honor to represent you.
Thank you, Ms. Castro. Any other questions or comments from board members? All right, Sean, I need you to, I think I need you to open back up the public comment line, although I've lost track of whether I've already done that on this item or not. I don't think I have.
We have not, no.
All right, let's open it up.
Gone ahead and activated the raise hand feature in the Q&A window. So anyone wishing to make a public comment, please go ahead and do so now. First up, we have Eric Andrews. Eric, go ahead.
Can you hear me?
Yes, we can.
Several quick comments. Anyone else find it odd that the number of complaints has steadily gone up, but the number of hours the AG's office works remains the same? It makes it sound like a certain amount of money is budgeted to work on cases and then the rest are just tossed out. Number two, interesting that Dev, as are many of you, are always so complimentary of the staff, the AG's office, etc., but never have a kind word to say about an advocate. Three, I've been waiting for way more than a year for Gloria to follow up on the questions that Judge Feinstein posed to her about the DAG that screwed up a case and it had to be thrown out. I've asked several times and it appears that she is purposely keeping that information from the public. Must have been some great evidence to hold against the AG's office or she would have shared that with us by now. Lastly, since we didn't get to comment on the enforcement monitor, why don't you have Julie D'Angelo Felmeth, the prior enforcement monitor, make the nomination for the new one? Thank you.
Thank you for your public comment. Next up, we have Rosie Arthur's-daughter. Rosie, are you there?
Yes, I am. Can you hear me?
We can. Please go ahead.
Okay. Sorry about that. I had switched modalities with it being so late. Anyway,
You are, Ms. Arthur, you are very muted or muffled. So if you could get closer to your microphone, or it's difficult to hear you.
Okay, just a minute. Let me try something different. Trying to do this in the dark.
Should we maybe come back?
Just a sec. I think I've got it.
That sounds better.
There, is that better?
Yes, thank you.
Okay. I'm working in the dark here because it's gone 2 hours over time. Okay. Thank you very much for this opportunity. I take it this is the last item, or is it going to continue the meeting? Hello?
Ms. Arthur, this is the time for you to comment on the Attorney General's report. We can't have a back and forth conversation.
I can't hear you. Oh, okay, never mind. I'm done. I can't hear you.
Okay, thank you for your public comment. At this time, I don't see any other requests in queue.
All right, we are going to bring it back to the board. Ms. Castro, I would again like to thank you for being here with us this evening. Ms. Harp, thank you for hanging in there as well with us to this late hour. And with that, I'm going to...
And Ms. Celerio too.
Oh, Ms. Celerio, I apologize for not catching you. The hour's late and I'm losing my ability to artfully manage a meeting. We are going to postpone items 13, 14, 15, and 16 to sometime tomorrow. I do not know that they will be the first items we take on the agenda because we do have some presentations that are time limited. So I will work with staff to figure out the order and we'll announce that at the outset of tomorrow's meeting, but we will stand adjourned until 9 a.m. tomorrow morning. Thank you, everyone. A special thanks to staff for hanging in there with us this late.
Thank you.